So, good evening, everyone. If I'm visible and audible, please give me a thumbs up. हेलो. हाँ, कर दिए. स्ट्रीम तो ऑन है. हाँ हाँ, लाइव हो गया. एक्चुअली यहाँ से दिख तो रहा है मेरे को. स्ट्रीम स्टार्ट. ओके. रिकॉर्डिंग भी स्टार्ट करें, खाली स्ट्रीमिंग करना है. नहीं नहीं, मतलब लैपटॉप पे रिकॉर्डिंग तो नहीं करना है ना अभी. हाँ हाँ, वो भी ठीक है. ओके ओके. डन. हाँ हाँ, ऑल हो गया, ऑल हो गया. थैंक यू. टेक्निकल थिंग्स. So good evening, everyone. Yeah, good evening, good evening, good evening. Hello, sir. Dr. Ranjit, good to see. Sir, Dr. Ranjit has come. I feel so good. And yes, yes, yes. Thank you, Dr. Amit. All good, all good. Dr. Dipanshu, Dr. Isha, Dr. Vibhav. Right. Okay. Are you people still remember chlorine, sugarcane and all? Are great to see Dr. Ravi Shankar. Great to see all of you. Great, great, great. So I think all the people here are now, I think interns and post interns, right? No UG people, na? Hi, Dr. Ravi. Hi, hi. Good to see everyone. Good to see everyone. I think all the old people are the ones which I can see right now. Great. All good, Dr. Ravi. All good. All good. Okay. हाँ हाँ, मुस्कुरा रहा हूँ डॉक्टर मेडिको. ऑल गुड. लेट्स स्टार्ट विद द सेशन, और विल जस्ट वेट फॉर फ्यू पीपल. I know Dr. Ranjit's session was so good. In fact, everyone's session, week from anesthesia, you guys won't believe, I went through all the sessions of everyone and I had my revision also. So Dr. Bidaquilin says interns only. Fine. So let's just wait for a minute, so that people can just join in, and then we'll start with the session for anesthesia. So welcome to this live session, NEET PG Sprint 2023, right? Dr. Girish Nana, just check streaming. Right. Okay, guys, some technical error maybe. Chalo, let's start without wasting any more time. Sorry. Okay. Hello. नहीं, all okay. Going on. Streaming तो ठीक है. Okay. Is it stuck for all of you? Now it's okay, guys. Hopefully now it's okay. Thumbs up, everyone. Everyone, is it okay? Don't worry, we'll extend the class by 10 minutes. As always, what I do. Just give me a thumbs up so that I can start. Hopefully it's not stuck because I can see myself now. Yes, okay. So let's start here. No wasting time. Right. So I got a thumbs up from all of you. Let's go forward. I'll be waiting for your messages. So the class that we are going to take, guys, is in the form of previous year's questions. We are going to discuss the MCQs, their answers, and how to tackle them with anesthesia. Okay, I have your messages right in front of me, so I'll be going through them, right? And based on your answers, we'll go forward. My name is Dr. Vinish. I'll be teaching anesthesia. Okay, over here. So this is the first question, one of the most important previous year's questions. So these are the topics which are all high yield ones, right? These are all high yield topics that we are going to discuss. They are the most common questions which have been asked from anesthesia, and trust me, questions from anesthesia are very easy. And Dr. Dipanshu says, sir, extend by 1 hour to cover the topics. Yes, I'll be extending, as if you people want, we'll be discussing all the points which are there. Don't worry. Okay, so this is the first question that we'll discuss. In the adjoining image, the Malampatti score is, Please give your options. Grade 1 A, grade 2 is B, grade 3 is C, grade 4 is D. To give your answers, the answer is A, B, C or D. I'll give you 30 seconds time and then we'll discuss after that. अरे फर्स्ट ईयर में एनेस्थीसिया कैसे पढ़ोगे? डॉक्टर PW नीट एंड JEE, यू नीड टू फर्स्ट स्टडी फर्स्ट ईयर बिफोर यू कम टू एनेस्थीसिया. एनेस्थीसिया इज बेहोशी वाला ब्रांच यार, बाबा रामदेव. डॉक्टर स्वतंत्रा वर्मा सेज ग्रेड 4, डॉक्टर रविशंकर सेज ग्रेड 3, डॉक्टर रविशंकर. अदर पीपल, डॉक्टर एल्जा सेज D, डॉक्टर ग्रिम रीपर सेज 3, डॉक्टर दीपांशु हैज सेड ग्रेड 4, डॉक्टर रमानंद, डॉक्टर ईशा शक्य says D. Other people, so the confusion is between 3 and D, right? This is an important question, very very important question, right? Malam Patti recently has been asked in the FMGE exam also, and this question has been asked in NEET PG also, right? As I said, these are the high yield topics, right? High yield topics, most common questions and previous year's questions. Through them we will be revising anesthesia. The correct answer here is grade 4, the image in front of you. Lot of questions from anesthesia that they come are basically questions which are image based. This is what is called Malam Patti score. In fact, as you people know, if you people who have attended my class before know, I keep on changing the questions. So now ask me, this is Malam Patti grade 4. So let me change the options A, B, C and D. All of you know this is Malam Patti grade 4. From the image given to you, what is it? Is it supposed to be easy intubation? Or it is supposed to be easy mask ventilation? Is it supposed to be difficult intubation? Or Malam Patti examination is done basically to see the tonsils and the fascial pillars? No, let's change this option. Let's do it as fiber optic. Yes guys, next question based on the same point. Next question based on the same point. You have the same image in front of you. Is it supposed to be an easy intubation, easy mask ventilation, difficult intubation, or for fiber optic? Dr. Swatantra Verma says, Dr. Ravi Shankar says, right. Two people have given the answer. A, B, C and D. Other people, what do you think are the options? As I said, I keep on changing the questions like this. Exam wale aise question पूछते हैं. This is exactly how questions come in exam. They'll give you something and they'll change the options, and that's exactly why previous year's questions are important. I think most of you now have given the correct answer. So before this, you were confused between Malam Patti 3 and 4. But however, when I gave you this question and you people know it's Malam Patti 4, most of you have given me the correct answer, which is difficult intubation. Right? Most of you, absolutely correct. All of you. All of you are absolutely correct, which means you people realize there is some problem in identifying grade 3 and grade 4. But once you know it is grade 4, all of you were aware it is difficult intubation. Take home message. How do you identify? Guys, I've told you in the classes before also. Just remember, when you're doing Malam Patti examination, only one structure that you should be looking at is the uvula. Look at only at one structure, uvula. Correct. So, this is our Malam Patti grading. Right? Malam Patti grading. So, this is Malam Patti 1, this is Malam Patti 2, Malam Patti class 3 and Malam Patti class 4. As I said, you just need to look at the uvula. If you can see in Malam Patti 1, complete uvula is visible. In Malam Patti 2, that tip is not visible. In Malam Patti 3, only the base is visible. In Malam Patti 4, nothing is visible. Right? Right? So, Malam Patti 1 and 2, why is this important then? Why are we doing this? What is the Malam Patti examination done for? So basically, Malam Patti examination is done to visualize the posterior pharyngeal structures. You need to see the posterior pharyngeal structures. What are the posterior pharyngeal structures? As you can see, here is the uvula, right? At the sides of the uvula, here you will get the tonsillar pillars. So these are called tonsillar pillars. And then next to them, you will get those area called fosses. So the green ones are the tonsillar pillars, and the ones next to that are the areas which are called fosses, right? So these are tonsillar pillars and fosses. Then there is this hard palate and soft palate, which you people can see. When all the 5 structures are visible, it is Malam Patti class 1. What is Malam Patti class 2? All of you know, I normally say in the classes also, just cut the tip. What you see, it becomes Malam Patti class 2, right? Here the tip of the uvula is not visible, right? Hard palate, soft palate are visible, and you can see the tonsillar pillars and fosses, that green area and the red area, they are visible only half. Can you see? Only half are visible, only half. right? Half of it is visible. In Malam patti 3, what happens? It gets cut from here like this. Okay, all you can see is the base of the uvula. All right, these things are not visible. Hard palate, soft palate are visible. Malam patti 4, nothing is visible. So therefore, Malam patti 1 and why are we doing it basically? ऐसे ही someone comes in, अरे मुंह खोल है. Why are we doing Malam patti? Someone comes into the hospital, into the PCU, अरे मुंह खोल, open your mouth, है, show your tongue. That's what we do. Why is Malam patti to someone which is coming for a surgery? I am seeing the posterior phalanx. He says that I have got a surgery of abdomen, I have got hand surgery, I have got foot surgery, and I tell the person come inside, मुंह खोल. He'll say, sir, मेरे पेट का सर्जरी हो रहा है, मेरा मुंह क्यों खुलवा रहे हो? Why are you opening the mouth of the patient for an abdominal surgery or a leg surgery? हो डॉक्टर श्वेता, मला मराठी येतात, चांगलं मराठी येतात. Dr. Shweta is asking Marathi also in between, huh? Okay. I can speak good Marathi. I am born and brought up in Bombay, na, that ways. Anyways, my answer. No one is answering me. एक क्वेश्चन में इतना टाइम लगाओगे तो बाकी क्वेश्चन कैसे करेंगे? Right. So the point is, this gives you an indirect correlation for intubation in the people on whom you can see the uvula. Right. The most important structure I told you is the uvula, as you people have mentioned. In the people that you can see uvula, you can see the vocal cords. In the people in whom you can see uvula, like in here, you can see the vocal cords. In people in whom you can't see the uvula, you can't see the vocal cords. So guys, this is what tells you the laryngoscopic grading. This thing is also called as Cormack-Lehan grading in ENT or even anesthesia. This is called as Cormack-Lehan grading. Right, so Cormack-Lehan grading tells you the vocal cord appearance. In Malam patti 1, you can see the vocal cord. Malam patti 2, you can see half of the vocal cord. Malam patti 3 and 4, vocal cords are not visible. Therefore, how we come to the diagnosis then, that in Malam patti 1, if the patient has come to my OPD for a pre-anesthetic checkup, just by looking at the patient's mouth, I can say whether the patient's intubation is going to be difficult or not. Right, so Malam patti 3 and 4 tells you about difficult intubation. And Malam patti 1 and 2 are relatively, they can be difficult anytime, are relatively easy intubation. This is the point of doing Malam patti examination, and that is why this becomes one of the most important things to be done to determine a difficult airway in a patient. Right, when you want to difficult airway, matlab jet airways nahi. You know, sometimes these UG students are also here na, so UG wale bolte sir jet airways. Okay, that's not jet airways. For us, airway is what? Airway is any structure from the nose to the chest. So difficult airway, one of the most important examinations is Malam patti examination, and it tells you about the ease of intubation. Right? So thumbs up everyone. Is this point clear? Question clear? Any doubts? Ask me. Otherwise, I'll go to the next one. Right? Most of you have answered me correctly. For you, the identification, the problem was identification of 1, 2, 3 and 4. I think even that point is now clear for all of you. You people already knew that 3 and 4 are difficult and 1 and 2 are easy. Right? Are, is that okay? May I go to the next question? Thumbs up all of you. Yes? Okay, so Dr. Medico Forever has said yes. Let's go forward, right? So this was question number 1. Remember, this is important question, Malam patti, right? So this is Malam patti, and what the question that we set here was Malam patti 4. I think I got yes from everyone. Dr. Vikash, Dr. Ishan, Dr. Isha, right? All of you have given me, right? Going forward. Next question. Okay, questions from anesthesia are simple. Huh? Don't take tension for anesthesia. Most of you will be doing right most of the times. Which of the following is wrong regarding the color coding of anesthesia gas cylinders? So there are 4 options that we'll be getting, and we have to choose which is the. Read the question. As I always say, read the question. Okay. So Entonox blue with grey shoulder, air grey with white shoulder, nitrous blue and helium brown. So which of the following is wrong regarding the color coding? Okay, so please give your answers guys. A, B, C or D. डॉक्टर मेडिको मैं तो बोलूंगा सब क्वेश्चन एनेस्थीसिया से आना चाहिए. These are simple questions that you get from anesthesia. They're never difficult. Okay, questions from anesthesia are very simple most of the times. Right? Dr. Swatan Dr. Swatantra Verma has given the answer. Other people? Dr. Elza, Dr. अरे यार तुम्हारे नाम भी ऐसे होते हैं ना, हमेशा YouTube पे आता हो तो मेरे को ये समझ में आता है सबके नाम भी ऐसे है ना. I'm thinking where to keep my mobile so that I don't have to bend so much and I can just see. Okay, without an issue. Now I think I can see it clearly. Yes. I think most of you have given me the correct answer. अरे डॉक्टर सागर ने क्या बोला? नाइट्रस का. ले, जब मैं खुश होकर बोलता हूँ सबको करेक्ट 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 तो सडनली रॉन्ग आंसर आता है. Okay, so guys, most of you, in fact 90% of you are correct with the kind of answers that you've given me. No, 90 nahi, I will say 95% of you are correct. So you people were all aware of this important question. Cylinders always get asked in the exam, whether you take FMGE, INICET or NEET PG, right? An important topic. Yes, the correct answer here is A. Entonox blue with grey shoulder is wrong regarding the color coding. Air grey with white shoulder, is it correct? Yes, the color coding is correct. Nitrous oxide blue, is it correct? Yes, it is correct. Helium brown in color, is it correct? Yes, it is correct. Which is the wrong option then? The wrong coding is with Entonox. Entonox is not blue with grey shoulder, but Entonox is basically blue with white shoulder, right? Remember white. Whatever contains oxygen is always going to have something white in color. That's how you remember. So Entonox basically is what? Entonox is a cylinder which contains 50% oxygen and 50% nitrous oxide. Because it contains oxygen, it has got to have some white color. So therefore it becomes blue cylinder with white shoulder. So let's see the colors and revise them. As I said, this is our session to revise our questions also. Gets the revision of anesthesia done. And the previous year's questions are also getting, covered in the same go that we are doing. So these are the various cylinder colors. So you will find that the carbon dioxide cylinder is grey in color. Where is carbon dioxide cylinder used? Use anyone? Jaldi. Jaldi means fast. Dr. Medico says 7 number wala. Correct. One more point is being given to you. Dr. Medico forever. I told you, if your name is Dr. Medico forever, then there is someone called Dr. कहाँ गया हो? Dr. Lifeless 2. मेरा नाम क्या होना चाहिए? I've told you before. Educated drug dealer. Licensed drug dealer. And the next time I'll tell the PW people to keep my name anesthesia class by educated drug dealer. Licensed drug dealer. अरे आंसर नहीं दे रहे हो तुम लोग. कार्बन डाइऑक्साइड कहाँ यूज होता है? Where is carbon dioxide used? Just waiting for your answers, huh? Anyone? डॉक्टर मेडिको फॉरएवर से एनेस्थीसिया वाला. हाँ यार ये बात भी थी, एनेस्थीसिया वाला ये भी सही रहेगा. करेक्ट. डॉक्टर रोज सेज लैप्रोस्कोपी. एब्सोल्युटली करेक्ट. Laparoscopy is where anesthesia is used. I mean carbon dioxide. Which brings me to the next question. Guys, question कर लूं? You people know ना? ये करते हैं. मेरे को ऐसे क्वेश्चन आता है. एक क्वेश्चन आ रहा है. May I? कर लूं guys? एक क्वेश्चन कर लूं क्या? क्वेश्चन आया है जोर से. All of you. Dr. Vikas and everyone, see, most of you are right. Laparoscopy is the correct answer. Based on laparoscopy, I have got another question which I want to ask you. कर लो. जब जोर से आता है तो कर लेना चाहिए. Okay. So what is the question? The question is, which gas is supposed to be the best for laparoscopy? Okay, I'll give you 4 options. That's exactly why things are being discussed. Option A, is it helium? Option B, nitrous oxide. Okay. Option C is carbon dioxide. Option D is let's keep argon. Yes guys, A, B, C and D. चलो मैंने क्वेश्चन कर लिया. That is what was called क्वेश्चन करना. Hey, this is called 1 करना, this is करना 2 करना. ये इसको बोलते हैं क्वेश्चन करना. When we are talking, questions come like this in the mind. Yes guys, so that is a question which has been asked in exam. Which gas is supposed to be best for laparoscopy? All of us know that we are using carbon dioxide. Yes, we are using. So what is the answer? लेट मी टेस्ट योर नॉलेज ना, थोड़ा सा ऐसे घूम के टेस्ट भी तो करना चाहिए. हीलियम, नाइट्रस, कार्बन डाइऑक्साइड के आर्गन. देखो दैट इज व्हाट ना, थोड़ा सा ट्विस्ट किया तो सब गलत हो जाता है. टिल नाउ नो वन हैज गिवन मी द करेक्ट आंसर. No, 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 it's not carbon dioxide. Hence I asked you the question. Na? No, it's not carbon dioxide. I gave you another hint. One question is out. One option is out from here. एक option मैंने हटा दिया. Out. Then, guys, for this, ideally, the correct answer is argon. Ideally. But it is not used. Right? Not available. Right? Helium is not used. Which brings me to the next question. Where is helium used then? हीलियम कहाँ यूज होता है? डोंट टेल मी सर बलून में यूज होता है. डोंट टेल मी हीलियम बलून में यूज होता है. इमेजिन आई एम आस्किंग समवन वेयर इज हीलियम यूज, टेल यू पीपल गिव मी एन आंसर सर बलून, हॉट एयर बलून. वेयर इज हीलियम यूज इन द मेडिकल प्रोफेशन एंड फॉर व्हाट? What is helium used for? Right, guys, remember for laparoscopy the correct answer is argon if it's possible. Okay, remember that, it's a twist, right? Dr. Priyanshu says, Dr. Priyanshu, carbon dioxide basically gets absorbed, and therefore agar carbon dioxide gets absorbed in the bloodstream totally, it is going to increase the PCO2 of the patient, and increase in PCO2 is very detrimental, especially to patients who are having cardiac issues. Right, Dr. Ravi Shankar has given me the correct answer. Dr. Medico Forever says, if it is not best, then why is it used for laparoscopy? Because it is available. See, always the best thing is not. Now, for example, now wait. Let me clear this doubt out. Once we have got the topic, then let's discuss. For example, do you think nitrous oxide is the best gas for anesthesia as a carrier agent? Nitrous oxide is creating so much of environmental pollution. You people are aware of that. This drug is basically causing lot of nausea, vomiting, right? This drug has teratogenic effects, right? This drug has that concentration effect, second gas effect. It also has something called as diffusion hypoxia. These are all exam questions, right? More importantly, environmental pollution is also there. This gas inhibits vitamin B12, right? Leading to vitamin B12 deficiency. You people know megaloblastic anemia and everything. It leads to bone marrow depression. It expands closed air spaces, right? Closed air spaces. So these are all the side effects that you see with nitrous oxide. I've discussed all of them right now. These are all exam questions. Everything about nitrous oxide that I'm discussing right now are all exam questions. Environmental pollution, nausea, vomiting, teratogenic, vitamin B12 deficiency, expands closed air spaces, because of which pneumothorax, laparoscopy, ideally you should not be using anywhere. Diffusion hypoxia it creates. The point is, that is exactly why people are trying to substitute nitrous with which gas? Next question. Again exam question. Nitrous can be substituted by which gas? Is it helium? Right? Is it carbon dioxide? Is it the same argon or xenon? Next question. Sorry, you people know, all the people who have attended my class before, they know. You know, my MCQs go like this only, one after the other. I'm sorry, but I can't help it. What is the gas which can replace nitrous oxide? Again, that's an exam question, guys, from anesthesia. What can replace nitrous oxide? No, guys, it's not argon. Right, Dr. Swatantra has given the answer, and Dr. MBBS Synapse. MBBS Synapse. Nice name. Dr. Rose also nice name. मतलब नाम तो सबके अच्छे होते हैं, but इस तरह के नाम अच्छे हैं. Okay, so anyways, all of you, the people who have given you the answer later on are all correct. Xenon is the gas which can replace nitrous oxide. Alright, it has almost the same effects as nitrous oxide, and it does not cause environmental pollution. Right? So this, you know now why if we use nitrous oxide, you know there's a girl with two chotis. Choti means, you know, those two plates. She comes in front with a flag and she stands in front of your house. You are spoiling my earth, you're spoiling my earth, you're spoiling my earth. Are you people know now there is someone who comes in front of your house to say you are spoiling my earth? She's got a Nobel Prize. She cries in the UN. She's not wrong. Who is she? She's got a Nobel Prize. फ्लैग लेके, दो चोटी वाली, द स्मॉल गर्ल, शी इज नॉट रॉन्ग. That's okay, Dr. Medico. That's fine. That's fine. All good, all good. No issues. You can keep any name, yeah. I'm just trying to, because I feel like keeping educated drug dealer, no one lets me keep that. Hence, whenever I see you people, then I get a little bit jealous. I can't keep those names. Right? Dr. Vikas is Greta. So that is Greta. The point is, nitrous oxide is causing so much environmental pollution. Next MCQ question, based on this. Which two anesthesia gases cause the maximum environmental pollution? So maximum environmental pollution is caused by nitrous oxide and desflurane. And that is exactly why people are doing research on xenon, so that xenon can replace nitrous oxide and it does not cause so much environmental pollution. Problem, X for xenon and X for expensive. Right? नहीं, Dr. Khushbu, Malala नहीं. Malala got for something else. Dr. Greta. Dr. Arshad says that. Okay, Greta is the right answer. Dr. Inkalab Zindabad भी सही बोला. Right, Greta ji, absolutely correct. Right, good evening, Tiwari brothers. Two of them are attending. Okay. Alright, so X for xenon and X for expensive. So it's an expensive thing. It cannot be used. It can cause bronchospasm. There's no anesthesia machine available, and that's why xenon is not used. But ideally, xenon should have replaced nitrous oxide. That is the same thing. Argon should have been used for laparoscopy. It's supposed to be inert and one of the good gases. But because carbon dioxide is available, that's exactly why carbon dioxide is used for laparoscopy. Argon, being a better drug, is still not used. But that is the use of argon. Just remember this point. Okay, that is why it's important. Use of helium. This is again one thing which you are discussing. So let me put these points in a paper so that all of us, can wait. Yeah. So let us just put it over here, the points that we were discussing. So remember helium. What is the importance of helium? Helium, guys, becomes a carrier of oxygen. What is nitrous oxide? Nitrous oxide, 2 points. It is analgesic in nature, and at the same time, it is carrier of inhalationals. And inhalationals would mean any inhalational agent, right? Apart from that, carbon dioxide, where is it used? Basically laparoscopy, right? However, argon, it would have been a better drug to have been used, argon, but argon is not used anymore. For same thing for nitrous oxide, better thing would have been xenon, but xenon is not used. So these are the gases that you should be aware. These are not actually Dr. Medico says कहीं stick note पे लिख लेता हूँ. लिख लो यार. These are short points. As I said, this is a revision. Don't worry. I'm going to cover most of the topics, all the topics from anesthesia in short. Plus, I'm giving you the small points. So these are the points which can just help you. Don't get into too much details of things. In the last, we don't need to read so much nitrous oxide. But this becomes all the side effects of nitrous oxide that you can see, right? And here you find the next point that I've discussed is wait. इधर गया यार. Where's my sheet gone? Here is my sheet. Sorry. Okay, so remember, carbon dioxide is used for laparoscopy. Argon would have been better. Nitrous is analgesic and carrier of inhalationals, and helium is a carrier of oxygen. Okay, all of you okay? So let's see the color of other cylinders also. Now here I discussed few points with you. Going to the color of other cylinders. अरे यार, मेरे को थोड़ा रब करना पड़ेगा. Because in that case, how will we see the colors? Let me just rub it thoda sa. Okay, sorry. So remember here, the gray colored cylinder which you get is carbon dioxide, right? Gray with white. This is what is a cylinder of air. Okay, so the gray color cylinder that you see is carbon dioxide. It is gray in color. Gray with white is a cylinder of air. Black with white, the whole world knows, is oxygen. We saw it during COVID. Absolutely blue in color is nitrous oxide. N for Neela, N for nitrous, N for Neeli, Neelam, whatever. All correct. Okay, any way that you want to remember. Oxygen plus nitrous is Entonox. So blue with white, it becomes Entonox. In fact, Entonox looks like this. Wait, so this is Entonox cylinder that you can see. This one, right? Blue with white. It contains 50% oxygen, 50% nitrous. And here you will find brown in color. This is helium, right? So if I'm discussing this thing, might as well just go forward and discuss with you, like someone like me, mere sa aadmi, someone like me. You know, ulta सीधा करने वाला. Ulta सीधा means what? All of a sudden, one day I get khujli, irritation. And my irritation, you know, I'm sitting in the OT. You know, anesthesia people are very cool, na? They're sitting and doing time. अरे सुबह सुबह anesthesia वाले जाते हैं, मास्क रखते हैं और बाबा रामदेव को फॉलो करते हैं. Sevoflurane. First breath. Next breath. Close your nostril and take a breath. Okay. All of us do that. Now the point is, after taking those breaths of Sevoflurane, when you are in a separate world, that's why you find anesthesia people so cool. Okay. In the OT, you look at the surgeons. Dr. Sandeep, I'm not telling you, not at all, otherwise Dr. Sandeep will get at me. Okay, very good surgeon, very good teacher. I'm saying of other people. Okay. Now the point is, person like me, I've started to give anesthesia. Other people are operating. You know, let's take all the surgeons, all the surgeons that we've had, all of them, everyone, Dr. Jagdish and everyone is operating. I'm enjoying myself. All of a sudden I feel, let me change the cylinder. Can you see, this is blue colored cylinder of nitrous oxide, this is black and white colored cylinder of oxygen. All of a sudden I feel I want to change oxygen here and I want to put nitrous here. Okay, can I do that? No. There is something which prevents me from doing that, and that is what is called as the pin index safety system. Guys, this is an important point, again asked in the exam. Pin index safety system basically is a system that connects the cylinder with the anesthesia machine. It prevents the wrong attachment of cylinder. Okay, so it prevents the wrong attachment of cylinders. So here the pin index of 4 important gases which you people should be knowing. Pin index of air, this is 1 and 5. Pin index of oxygen is 2 and 5. Pin index of nitrous is 3 and 5. And remember Antonox, this is 7, right? So these are important pin index safety numbers that you should be knowing. Casually, even carbon dioxide, if you know, it's okay. So carbon dioxide is basically anything with will be with 6. So 1 6 or 2 6. Why there are two numbers? It depends on percentages of carbon dioxide which has been there. If you don't remember carbon dioxide, guys, it's okay. But you cannot be forgetting air, oxygen, nitrous and Antonox. These pin index is important. Okay, so pin index prevents the wrong attachment, which means I can't put oxygen cylinder here and I can't put the nitrous cylinder over here. Right, everyone, is that okay? So this is about the anesthesia machine. In the anesthesia machine, they ask you questions regarding the cylinders which are important, which is the high pressure system. In between is the intermediate, and here you get the low pressure system where vaporizers become important. Again, a recent question was there on vaporizer. May I ask? It's a question aaya hai. And the question is, okay, this was a FMGE question. Which of the following has a separate electrical supply? Separate electrical supply. Which of the following? Vaporizer. Let me add vaporizer. There are 4 options given to you: halothane, sevoflurane, isoflurane, desflurane. Yes, guys, answer. I'll be waiting. Oh, I'm only at second question right now. Yes, guys. Dr. Isha has given the answer. Right. Dr. Tiwari brothers, both of you. Nice. Good, huh? Dr. Tiwari twins. Dr. Tiwari twins. Okay. Dr. Lifeless. Dr. Ames. Wow. Array, Dr. Ames. Other people, what answers do you think is the correct answer for this? This has been asked in the exam. Huh? This again a previous year question only. Last year question of FMGE. That's what I'm asking. This is the last year question of FMGE. Okay. Alright. Right. So most of you have given me the correct answer. Right. Most of you have given me the correct answer. Yes, and the correct answer is D. Reason is desflurane boils at 23 degrees centigrade or room temperature, because of which all the others almost will look similar. But because desflurane boils at 23 degree or room temperature, it has got a separate vaporizer which has an electrical supply. And this separate vaporizer is called Tech 6. If you don't remember the name, it's okay. But just remember that desflurane, can you see S? It has got special vaporizer. And that special vaporizer is called Tech 6. You will say, sir, S is sevoflurane. Let me change it. S of sevoflurane is sweet smelling. So it does not have special vaporizer. Okay, so that's why that S is different. Sir, isoflurane S. Yeah, it also has S. But what to do? Yeah, isoflurane also does not have special vaporizer. For me, that's how I remembered. Okay, sometimes you can't have always way to tell. I remembered it this way. S is a special vaporizer. This is Tech 6. So all of you don't say, sir, S is here also, S is here also. That's a small way to remember in exams here. S of desflurane is special vaporizer. That's one property to it. Because S of desflurane can also be sympathetic stimulation. It causes sympathetic stimulation, increasing heart rate, increasing in blood pressure. Small points which are asked in the exam for desflurane. Okay. So that's how the two important S from desflurane is there. Right. So correct all of you. Correct answer is desflurane. Most of you have given me the correct answer. When we speak of anesthesia machine, so you will find it is the desflurane vaporizer, which doesn't look like this. And that vaporizer, if you have, this is isoflurane, you will find desflurane vaporizer which will have an electrical supply. This is not that, this is iso. But in case there is desflurane vaporizer, it has a separate electrical supply. And this question was last year FMGE question. Because questions get repeated. You people know sometimes the same questions from NEET PG are asked in FMGE, same from FMGE asked in NEET PG. May I go forward, all of you? Thumbs up if it's okay. All of you, may I? Arey, may I? Okay, right. So Dr. Medico forever. Okay, so let's take the next question. Okay, very important question. Important one. Even without giving the option, you should tell me the answer. Even without giving you the option, you should tell me the answer. Identify the adjoining image which was used maximally in patients with COVID-19 infection. Right. I was just waiting for your texts and messages now so that you're following me up or not. You know me, na? That's how I teach. Right, guys? So give me the correct answers. A, B, C and D. What are the options? Right, Dr. Athira. Absolutely correct. I think Dr. Athira has given that answer first. Dr. Isha, नहीं वो आंसर नहीं है. Dr. Aim says B. नहीं यार, B नहीं है. B is not the answer. No, B is not the answer. That's the point, guys. Such questions come in exam, and this has been asked right from 2020 onwards. जब से COVID आया, in fact 2020 June, this question was asked, June or July. When the COVID was there, even that time this question was asked. In 2021 again this question was asked. Right? The correct answer is D, non-rebreathing mask. What is a non-rebreathing mask? Guys, can you see it looks like a normal face mask, right? This is a normal simple face mask which you can see till there. But to that what you have attached is a reservoir, right? When a face mask is attached to the reservoir, it becomes different. So let me tell you what it is all about. So we are discussing with oxygen delivery devices. So let's go back. Oxygen delivery devices. Okay, so when we speak of oxygen delivery devices, guys, so they can be classified into two types. When you're about to give oxygen to someone, imagine a patient comes to the casualty and the patient is about to collapse, gone. So you can use low flow devices initially, or you can use high flow devices, right? So the low flow devices that you will be using may be nasal prongs or nasal cannula. You must have seen something going inside the nose, those 2 points, that is called nasal prongs or nasal cannula. Then you have got this simple face mask, and the simple face mask is called as the Hudson mask or the Mary S mask, right? Simple face mask. But what happens is nasal prongs, maximum oxygen you can give is 44%. Simple face mask, maximum you can give is around 60%. Room air that we are breathing is 21%. Remember, that means someone who's hypoxic will need more oxygen. So nasal prongs will give 44%. It's not adequate. So use a simple face mask. Simple face mask is what you can see. It gives 60%. Right? Even that is not sufficient. So what I do, in that simple face mask, if you have attached that reservoir bag, you know, that simple face mask with the reservoir, as we can see, with the reservoir, simple face mask plus this reservoir, that is called as a partial rebreathing mask. Okay, and that can give this partial rebreathing mask, which normally is not asked in the exam, it gives around 70%, but hardly there's difference between 60 and 70. You would need something which gives you good percentage of oxygen for someone who's hypoxic in nature, especially people who were COVID positive. So therefore you have, guys, a mask which contains reservoir, and it also has a small valve over here. Valve. There is a presence of a valve. It keeps oxygen inside for long duration. So what's the function of the reservoir? This reservoir is full of oxygen, So this patient gets more oxygen instead of getting 60% or 90%. Plus we have already also added a valve onto that. So it's not a partial rebreathing mask anymore. This becomes a non-rebreathing mask. The figure which you're seeing before, it's called non-rebreathing mask, which can give up to 90% oxygen. Nasal prongs work between 1 to 6 liters, maximum is 44%. Hudson mask is basically between 5 to 10 liters, maximum is 60%. NRBM works between 12 to 15 liters, and that's exactly why in COVID there was shortage of oxygen, because in COVID all the patients were put on this mask. The whole India was on NRBM, and because of that every patient was getting 15 liters of oxygen to get 90% FiO2, and that is why, guys, there was such a huge shortage. Right? So let's not go into those details. Dr. Aim, 44% plus 21%, you're saying 21% is room air, na? You and I, what we are breathing. If someone is hypoxic at 21%, you're getting 44, and that doesn't mean it's 44 plus 21. No, you're wrong. It's not 44 plus 21, Dr. Aim. Okay, so let's go forward, guys. Hopefully you understood this point. Okay, so nasal prongs gives 44%, simple face mask gives 60%, partial rebreathing gives 70%, and non-rebreathing, again important question, it gives you the maximum fraction of inspired oxygen out of all the low flow devices, 90%. Okay, high flow mein you basically get two of them, which is high flow nasal cannula, and you get the Venturi mask, which was again asked in the exam. Venturi mask is a device like this, is a cone shaped device like this, which has got slight openings over here, right? It has got openings like this. It has got opening over here. That is a opening. All right. So Venturi mask is basically based on Venturi principle, Bernoulli's law, and it causes air entrainment. Means it is something which is called as a fixed output device. All right. So that is the Venturi mask. Yes, Dr. Madhavan, that's exactly what I'm talking about. This is the Venturi mask. It's a small thing which gets fixed here. So instead of the reservoir, you will have a small thing fixed over here. That is the Venturi mask, right? That is the Venturi mask. Okay, a small triangle shaped device which gets fixed to the end of the mask. That's a Venturi. It's a high flow device. It's not a low flow. In low flow, you will find nasal prong, simple face mask, non-rebreathing. In the high flow is what you find Venturi mask. Problem. What is the problem of Venturi mask? The maximum FiO2 is only 60%. So if this question comes in exam, which of the following gives maximum FiO2 to the patient? Maximum. So is it non-rebreathing mask? Is it simple face mask? Is it Venturi mask? Or is it, oh, let me make it A, B, C, D. A, B, C, and D. High flow nasal cannula. Dr. Swatantra, that Venturi effect is not entrapment, it is called entrainment. So I'll just correct you there. I'm sorry, I'll just correct you there. It is called entrainment of air. Entrainment is that word, okay? Almost same thing, but it's called entrainment, right? Color coding of Venturi mask is not important, guys. color coding is not important for you, don't worry nowadays, because they have a single color only by which you can rotate and change the percentages. Doctor, now good question, हाँ यहाँ पे सब लोग थोड़े से confuse हो गए. Dr. Isha says D, Dr. Yusuf says A, Dr. Arshad says A. Anyone else? What's the correct answer? Which one gives maximum FiO2? Sorry यार, मैं ना अभी third question पे लटका हूँ. It's okay, but I'll extend the class, huh? All of you, hopefully it's okay with you. Dr. Madhavan says A. Anyone else? So remember, the correct answer is D, because I didn't tell you how much is the high flow nasal cannula. High flow nasal cannula can give 100%. Okay, 100% out of all of them. Remember, the maximum FiO2 of non-rebreathing is around 90%. Simple face mask is 60%. Venturi mask also 60%. The only difference between the two is Venturi mask becomes a high flow device. At the same time, it is a fixed output device. Why is it fixed output device? Because different colors, as Dr. Correct, HFNC is the correct answer. As Dr. Lifeless was saying, you know the color coding. If you have a green colored one, it gives the maximum 60%. If you get the red colored one, it gives 40%. You know, similarly, it's going down 60, 40, 35. You get 31, 28, and 24. So blue color, white color, orange color. You know, that's how it goes. So these color codings are not important for Venturi mask, but you should be knowing the maximum given is 60%. And the 3 points: Venturi mask is high flow, fixed output device, right, based on Venturi principle or Bernoulli's law, and entrainment of air, right? So hopefully this point is clear, guys. We discussed oxygen delivery also, right? So this is your non-rebreathing mask. Any questions or doubts till here? Ask me, guys. These are the questions where questions have come recently in FMGE as well as NEET PG. All these are previous years questions on all the things which I discussed with you are previous years. Any doubts, ask me, all of you. Otherwise, I'll go forward. Yes, guys. Any questions? No questions, guys? Okay, right. Okay, just one point I want to discuss with you here also. Since I was discussing these points, I wanted to show you those masks. Okay, so just remember, this is exactly what I was discussing about nasal prongs. This is nasal prongs that you people must have seen, maximum 44%. This is a simple face mask, maximum is 60%. This is the non-rebreathing mask which you can see. It's like a simple face mask over here, which has a reservoir bag. At the same time, it has a valve. This becomes non-rebreathing mask, correct? And what is a Venturi mask? In this normal simple face mask, you will have a small triangle shaped device kept over here, which may be green in color or red in color. And that is what is called as a Venturi mask. And that Venturi mask just gives 60%, not more. Hopefully all clear. मेरे को डॉक्टर तिवारी ब्रदर्स का ना आंसर अच्छा लगता है सर. क्लियर टू बोथ ऑफ अस. आई रियली लाइक इट. थैंक यू गाइस. ओके, नाइस. लेट्स गो फॉरवर्ड. नेक्स्ट क्वेश्चन. ओके, नो वेस्टिंग टाइम. अभी तक वी हैव डिस्कस्ड ओनली 3 क्वेश्चंस यार. 1 घंटा होने को आ गया. ऐसे हम लोग 4-5 घंटा पढ़ेंगे. वील हैव टू कैंसिल इट फास्ट एंड फिनिश ऑफ फास्ट. वी आर अबाउट टू फिनिश अबाउट एन आवर यार. लेट्स गो टू द नेक्स्ट क्वेश्चन. 40-year-old female has to undergo incisional hernia surgery under general anesthesia. Which of the following is the most important technique to monitor the depth of anesthesia in this patient? So you have 4 options: electromyography, somatosensory evoked potentials, transesophageal echo, bispectral index. So all these questions, some of them I've twisted. A lot of you attended my class before know that I twist and set up. This is a twist. The same words have not been asked, but yes, the options are the same, but I've twisted the question. Dr. Swatantra Verma says correct. Dr. Athira says one answer correct. Okay, most of you are right. How many questions are there, Dr. Arshad? Dr. Arshad, how many questions you want? Other way around. How many questions you want? See, my point was to discuss somewhere around 16 to 20 questions. So we have on the 3rd or the 4th right now. Okay. but my point was to discuss all the points and all the topics of anesthesia, especially previous years, and it has covered everything. Whatever we have is covering every topic from most of the topics from anesthesia. We are not trying to leave out anything, right? Dr. Arshad, is that okay? Dr. Swatantra says the answer. Most of you are right here. So 3 of them give. Baki log kahan hai yaar? Dr. Swatantra, Dr. Athira, and Dr. Isha has given the answer, right? So I think let's take up as that is the answer for everyone, and the answer here is bispectral index. Absolutely correct. So basically what we are talking about, someone is supposed to undergo general anesthesia, GA. It's not spinal and all, which is the most common technique to monitor the depth of anesthesia. Depth of anesthesia means how deep is the patient under anesthesia. Behosh. For example, Dr. Dipanshu says A. No, Dr. Dipanshu, the correct answer here is D, right? Bispectral. It's okay. Make mistakes here. Make mistakes here, but get your points clear. That's the point. Make mistakes here. It's absolutely okay. Even 1 week, even sometime before the exam, it's okay. But get your points clear before you appear for the exam. This is sufficient. What we are doing from anesthesia will be covering up most of the previous year's questions, the points where they are really focusing upon in the last 2-3 years. Okay, so we are covering up all of them. So what is depth of anesthesia? So depth of anesthesia means how deep is the patient under anesthesia. Let me give an example. You are sleeping and I hit you. You wake up. Are you deep? No. If you are sleeping and I hit you twice and you don't wake up, deep anesthesia. That's deep sleep. लोग बोलते नहीं अरे क्या था बेहोश होके सोड़ा था, उसको 2 बार झापड़ मारा उठा नहीं. Someone was sleeping. I hit them twice and the person did not wake up. That is almost anesthetized. So basically someone who you have hit is not waking up is deep under anesthesia. Someone who's sleeping and you hit and he wakes up, he's light under anesthesia. So basically this tells you depth of anesthesia. But how will you monitor it? It basically is monitoring the brain activity, because you're going off to sleep in the brain. So anesthesia is also there in the brain. So what am I doing is I'm going to monitor the brain activity, whether the brain activity is there or not there. Of course it's going to be there, patient is alive, but is the activity more or brain activity is less? How can I see that? Brain activity, all of you know, go back to physiology, can be seen by EEG, electroencephalogram, not by EGG. EGG मतलब अंडा, egg. EGG मतलब अंडा होता है, इसको nothing is there. Okay, electroencephalogram, not EGG. So brain activity is measured by electroencephalogram. So what we do is we take electrodes. हाँ डॉक्टर मेडिको सरली पूछते हैं, टेंशन मत लो, right? Don't worry, they are easy questions normally from anesthesia. Normally they are easy. Yes, you just have to read them once, revise them once, and things are fine from anesthesia. इतना difficult नहीं होता. So this is what you can see is what is called as the bispectral index. One time I showed a diagram to two students and I said, sir, identify this. They said, sir, wrong image. Why wrong image? They said, sir, electrodes are supposed to be placed on the chest, not on the brain. Understand? That is the amount of ignorance that we have from anesthesia. Once I showed this diagram, and as I said, I was discussing with you. So, okay. So I showed this diagram to to students, and I asked them, identify, what is this? So they said, wrong image, wrong question. You know the students, when we were small, we used to come home and tell our parents, galat question pucha tha. Similarly, people say, sir, wrong question. Electrodes are to be placed where? Electrodes are to be placed on the chest, not on the brain. No, this is something else. These electrodes on the brain are measuring your brain activity, right? They are measuring your brain activity. They are measuring the electroencephalogram, those values which are there. Based on that, guys, you going to get a numerical value. I think some of you has given the answer also, right? About the values. Who's given the answer here? I saw the answer now. Oh, mid bhi gaya. I can't see now. Dr. Medico. Anyways, coming back to our discussions here. See, so the point is, this is based on EEG. So based on electroencephalogram, you are basically getting a numerical value. right? So this numerical value tells you what? Means a value that you're getting is based on the electric EEG activity. So a value of 100, this means that the patient is awake. Can you see the number is 96 over here? And a number of 0 means the patient is in coma or deep, I mean he is not in coma, that's wrong. A value of 45 to 65 or 40 to 60, both of them are okay, is to be kept for general anesthesia. 65 to 85 is said to be for sedation, or some people say 60 to 80 also, depending on different books which are there, right? So they are based on the brain waves, right? Beta, alpha, theta, delta. That's how the sleep pattern goes, you know, the deep sleep which is there, beta, alpha, theta, delta, right? So it is measuring the brain activity, and it just gives a simple thing. All I'm doing is attaching electrodes onto the forehead. If it comes in the exam, it's not wrong, please. If something like this comes in the exam, remember this is bispectral index or depth of anesthesia monitor. Okay, bispectral index or depth of anesthesia monitor. It tells you how deep is the patient. If I get a value of 96, it means our patient is awake. All right, for general anesthesia, I have to keep the value between 45 to 65. Now imagine under general anesthesia, if someone gets a value of 96, then under GA you are getting 96, matlab means what will happen? Yes, all of you. Correct, Dr. Isha, absolutely correct. It means under GA, if someone has got a value 96, it means our patient has become awake under GA. Patient has become awake under GA. इसका मतलब है you're supposed to give more drug. इसका मतलब है सर्जरी चल रहा है और पेशेंट को पता चल रहा है. The patient can understand, right? So under GA, you should not be getting a value of 96. It means the patient has become awake, right? And what I was saying, in case you get a value of 20, value of 20 would mean that under GA the patient is going towards coma. If a value is getting 20, it means you need to decrease the dose of anesthesia. So do you realize our bispectral index is helping us to get the adequate dose of anesthesia? So it prevents me from doing an overdose, as well as it prevents me from the underdose, and that's why it's one of the best monitors which can be used for exams. India में इतना नहीं यूज होता है. I know our country is progressing in every field, but in government hospitals you don't have bispectral index yet. Even in MAMC, Maulana Azad Medical College, yes, you know those colleges still have it, but you go to the other government colleges all throughout India, you still don't have bispectral index, and people are not using it so often. If you use bispectral index, your doses become optimal for the patient. You neither need to give overdose nor underdose for the patient, and patient is adequately kept under anesthesia. और बार बार यूसी एनेस्थीसिया पीपल, अरे उठ जा, अरे उठ जा, अरे उठ जा. अरे जब उसका 100 वैल्यू आ जाएगा तो उठाएंगे ना उसको. At 45 is sleeping and you hit them, अरे उठ जा, सर्जरी हो गया, उठ जा. अरे कहाँ से उठेगा वो? He is under GA. He has to come back to 100 to wake up ना. I don't know whether people have seen or not. There are anesthesia people who join anesthesia, you know, the fresh first year PG. They hit the patient like this. अरे उठ जा. कहाँ उठने वाला है? Right, Dr. Medico forever. Patient should not be aware. All of you are absolutely correct. Hopefully you've understood these concepts regarding bispectral index. Okay. So bispectral index basically measures the brain activity. Some of you gave me the answer also. Correct. It's measuring the brain activity. It tells you how deep is the patient. It tells you depth of anesthesia. So bispectral index is one thing which measures it. Bispectral index. It's also called as the BIS monitor. Apart from that, you also have entropy. What is entropy? Entropy is something which is remember E. Isme E is prominent. Entropy is based on EEG and EMG both. It tells you about the muscles also. It's, however, I have never seen it. We have not used it in India. I mean, people must have used it. I have never seen entropy. Bispectral index I have used, but entropy I have never used. Apart from that, there's a new thing which is called as patient safety index. Not important. If you forget it, it's okay. Remember, these 2 points are important. Bispectral index and entropy questions have been asked. This is what tells you the depth of anesthesia in the patient, right? Apart from that, of course, there are clinical parameters also that you can see the patient's reflexes, heart rate and BP, but this is bispectral index and entropy. Okay, so let's go to the next question, guys. Okay, let's go to the next question. The device depicted in the image is used to measure which of the following parameters? So mark your answers. Once you give the answers, then we'll have a discussion on this. Again, important question. Dr. Medico says, why not using in India? अरे इंडिया में कुछ नहीं होता है यार, मतलब people are not aware. People are not aware. People are not aware. Dr. Medico forever, right? People are not aware. Plus we are cutting costs ना. इंडिया में we always cut costs. जो सस्ता मिलता है वो लेते हैं. You also know ना, what is cheap is what we buy. In spite of that iPhone being manufactured in India, all of us run for Samsung, we run for Vivo. We know iPhone is now made in India, but still, sasta, Samsung, Vivo, not even that. What is that phone with Redmi and all? I don't know how many people buy Redmi in China, but India में people buy Redmi. ठीक है, cheap, सस्ता जो मिलता है हम खरीद लेते हैं. That's the whole point, right? So this question, Dr. Swatandra has explained things also of that, right? SpO2, correct. I think all of you have given me the correct answer, right? SpO2 measurement, which is the saturation of oxygen. Saturation of oxygen is the amount of oxygen carried in the blood. So this is a pulse oximeter, remember that. Otherwise, I would have asked another question, but Dr. Swatandra has given me that answer. ठीक है, इसलिए मैं उसमें आई एम नॉट गोइंग टू दैट. इट्स बेस्ड ऑन बियर लैम्बर्ट्स लॉ. मेरा गलती नहीं है, उसके माँ बाप ने उसका नाम बियर रखा है, तो इट्स नॉट माई फॉल्ट. अदरवाइज यू पीपल विल से एनीथिंग सर हैज टोल्ड फ्रॉम एनेस्थीसिया राइट फ्रॉम सिवोफ्लोरिन, बियर, कीटामी, यही सब बात चल रहा है मेरा. दैट्स व्हाई आई पिक्ड अप एनेस्थीसिया. आई शोड यू एम आल्सो क्वालिफाइड चेस्ट फिजिशियन. आई एम आल्सो क्वालिफाइड चेस्ट फिजिशियन, बट आई डोंट प्रैक्टिस चेस्ट मेडिसिन. एनेस्थीसिया मजा उधर ही है. इमेजिन चेस्ट मेडिसिन में मजा है क्या? उधर खांसी, उधर खांस रहा है, उधर. आई मीन बॉम्बे साइन हॉस्पिटल, यू गो, ऑल आर MDR पॉजिटिव पेशेंट्स, मल्टी ड्रग रेजिस्टेंट ट्यूबरकुलोसिस, ऑल coughing on your face. That N95 also will not protect you. It might protect, but I'm not very sure. At my time it was not there. Okay, मजा वाला ब्रांच तो anesthesia ही है. We don't share with anyone what we do, Have you seen anesthesia HODs of people? Always cool. इतना सिवोफ्लोरिन लिया रहता है कि वो लोग का दिमाग ऑलरेडी ठंडा रहता है, शांत है वो लोग. They're always शांत. Have you seen the surgery HOD? हाँ, डॉक्टर मेडिको इज आस्किंग में क्वेश्चन है, लेकिन एनेस्थीसिया से थोड़ा अलग है. इमरजेंसी मेडिसिन वो जनरल मेडिसिन का पार्ट है या फिर एनेस्थीसिया? ओके, slightly deviated, but let me answer that question. So guys, now depending on emergency medicine, guys, is basically a branch which is made as a separate MD now, right? It's a separate postgraduate degree. Initially what was there that people, in fact, forget that. If you're talking of emergency medicine as a branch where you're just dealing with the casualty, it's a separate postgraduate course. So what they do normally is emergency medicine, you'll be posted sometime in surgery, you'll be posted in medicine, you'll be posted in anesthesia, right? I think even in pediatrics, I'm sure, I think, right? And radiology and everywhere, so that you're aware of all the things and you are doing the emergency management of the patient immediately. That is the point. But if you're looking at critical care, ICU, if you're looking at critical care, right? So critical care basically, guys, is a DM, and DM means you're going to do it after MD. So critical care, guys, happens if you have done MD medicine, if you have done MD chest medicine, or if you have done anesthesia, then you do a DM critical care, right? So critical care, guys, basically is what is a DM. For that, medicine people, chest medicine people, anesthesia people can take DM critical care after their MD or DNB, either of that, right? And emergency medicine is taken up right after your postgraduate exam, and you take it as a separate MD in emergency medicine, where you're posted in various branches of surgery, anesthesia, medicine, right? Yes, Dr. Medico, clear? Fraction of light. Now coming back to studies, hopefully your doubts are clear, right? Let me clear this out. So we are discussing about the pulse oximeter, right? Pulse oximeter, guys, is based on the Beer-Lambert's law. And all of you must have seen, this is the number which tells you the saturation of oxygen, and this is what tells you the heart rate. My question, how did it pick it up? कैसे pick up किया? Does it tell you partial pressure of oxygen? No, you get to know it from the ABG. Oxygen content, you get to know, in fact, dissolved oxygen. Basically, if I have to say dissolved oxygen, this is again from ABG, right? You get all these parameters from ABG, dissolved oxygen or oxygen content. All these two parameters you are getting from ABG. Amount of inspired oxygen, this you don't get to know, right? It's nothing. It's a wrong question over here. Saturation of oxygen is the point, right? So how does it pick it up? All of you must have observed that there is a blood flow normally which goes, there's a light which comes basically. So you see the light is coming from here. One color light is red, other going from here is infrared, right? And there is a blood vessel which is flowing from here. So the blood vessel will be arterial blood goes like this and venous blood goes like this back. Okay, so arterial and venous blood is flowing this way. So what happens is one kind of light absorbs the oxygenated hemoglobin, other kind of light absorbs the deoxygenated hemoglobin, and the difference between them they just calculate. डॉक्टर कौन से CLG में, व्हाट इज CLG डॉक्टर मेडिको, कुछ छोटा सा CLG है, अरे व्हाट इज CLG गाइज? तुम्हारे शॉर्ट फॉर्म मेरे को नहीं समझ में आते ना, मैं पुराने जमाने का हूँ यार, आई एम द ओल्ड जनरेशन. यू पीपल राइट FOMO, आई डोंट अंडरस्टैंड. ठीक है, यू पीपल राइट सो मेनी अदर थिंग्स, TTYL, आई डोंट अंडरस्टैंड. अभी तुमने CLG लिखा, मुझको समझ में नहीं आया, सॉरी. अच्छा कॉलेज, लुक एट यू यार. ओके कॉलेज, अभी कॉलेज में नहीं हूँ ना, मैं बुढ़ा हो गया यार. कितना साल तुम लोग कॉलेज में पढ़ाओगे? तो आई वॉज इन बॉम्बे ग्रैंड मेडिकल कॉलेज, राइट? नो, उसके पहले चेस्ट मेडिसिन. सो चेस्ट मेडिसिन फ्रॉम लोकमान्य तिलक म्युनिसिपल मेडिकल कॉलेज, साइन हॉस्पिटल बॉम्बे. Anesthesia, DFCPS from Grand Medical College, Bombay. After that, DNB is basically from FCPS also from Grand Medical College. DNB from Deen Dayal Upadhyay Government Hospital, New Delhi. DNB secondary. After that, Maulana Azad Medical College, senior residency, and also assistant professor. After that, I'm working with Fortis now. Okay. I know. अभी मैं दिल्ली में हूँ यार. Okay. Right, Dr. Medico. Correct. Let me come back to studies. बोला ना मैं पुराना जनरेशन हूँ यार, आई एम द ओल्ड जनरेशन, नॉट योर यंग जनरेशन. नाउ कमिंग बैक टू स्टडीज. सी, blood is flowing from here, oxygenated blood. What goes from here is deoxygenated blood. So one amount of light absorbs the oxygenated, other absorbs the deoxygenated, and the difference between them is given to you as SpO2 or the saturation, right? Amount of oxygen carried in the blood. Normally all the SpO2 is supposed to be more than 95%. And that is why in COVID, when saturation was falling less than 93, government said hospital jana hai. Because SpO2 should always be more than 95%. Plus, can you see you are getting to see the peripheral blood supply? Based on that, it is telling you the peripheral perfusion, whether the peripheral perfusion is happening or not. Right? Based on that, you're getting to know the heart rate or the pulse rate of the patient. And because you know the peripheral perfusion happening, so peripheral perfusion can be slow like this, heart rate 60, 70, 80. It can become tuck, 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 tuck. Arrhythmia. You get to know the arrhythmia also from the pulse oximeter wave, and flatline, cardiac arrest. So all this is the information that you get from a pulse oximeter, right? Cardiac arrest, that is also what you get to know. And all this reason is because this graph that you see on the pulse oximeter, right? There's a graph which comes like this. I think all of you must be knowing about it. There's a graph which comes like this. That graph is what is called as plethysmography, but I don't think we'll go into more details of that. This much is sufficient, right? So plethysmography, where do you get wrong readings, guys? Simple. Wrong readings is if your hemoglobin is damaged. So if your hemoglobin is damaged, instead of oxygenated and deoxygenated, you start getting carboxyhemoglobin or methemoglobinemia, means your hemoglobin is damaged. Or if your blood supply is altered, so blood supply being altered means hypovolemia, shock, right? Or in case there is vasoconstriction of the blood vessels. So this is the reason where you get pathological problems and time pass. Time pass means nowadays in my hospital there are girls who come for surgery. Not with a normal nail paint. They have something stuck on here. यहाँ पे चिपका के आते हैं. चिपका के आते हैं. I know some girls would be knowing that. Right. राइट डॉक्टर मेडिको अब तो स्मार्ट वॉच और स्मार्ट बैंड में भी आ गया. एब्सोल्युटली करेक्ट. बट फॉर अस देखा पुराना जमाना चलता रहता है. यू नेवर नो वेदर इट्स वर्किंग और नॉट. Okay, so the point is nowadays if in case people are coming with this kind of nail paint nail polish what is kept, so in that case it might interfere with the passage of light and you may get wrong readings. So these are the, I mean not pathological, but these are the other reasons by which you will not be getting the correct readings of the pulse oximeter, right? हाँ वही वाला nail paint जो चिपक जाता है. You need to call someone from the parlor to take it out. It is stuck onto the nails and they come for a surgery like that यार. Lipstick I understand, earring, nose ring also I understand. Nail paint इतना बड़ा, how will the pulse oximeter work? It should be given in writing to patients now. Okay, chalo, let's go forward. Any questions or doubts? Ask me guys. This is the pulse oximeter. Next question. Very good question, Dr. Medico. Very good question. Very nice question. Wonderful. ठीक है, चलो. Very nice. So Dr. Medico has asked us the question. Very good. So if someone has had an amputation, a wonderful question. Okay, someone has an amputation, तो उस patient में क्या करोगे? So therefore very important. What are the sites of monitoring the pulse oximeter? Very good. Right. So everyone knows finger, but in case there is amputation that has taken place, so what I can do is I can use the toe. Let hypothetical, something like this should never happen to anyone. Hypothetical, or forget that. Let's not talk of amputation. Like थोड़ा सा वो नहीं करते हैं. Let's talk कि some girl has come. Sorry, girls don't get offended. But I need to talk like that. Okay. So यहाँ पे सब लोग nail paint. तो imagine the someone who was going for a wedding, some female. Because you will not expect a male to come with 5 nail paints over here. Na? Imagine me putting a nail paint here. What will you people think about me? So let's take for example, we are taking girls only. Okay. So there are हाँ दूसरा हाथ पे भी नहीं, तभी तो बोल रहा हूँ एग्जाम्पल लड़की का लिया मैंने. आई एम नॉट टेकिंग एम्पुटेशन एग्जाम्पल. आई एम टेकिंग एग्जाम्पल. देयर इज अ गर्ल हु इज गॉन फॉर अ वेडिंग एंड देयर इज दैट नेल पेंट चिपका हुआ ऑन ऑल दीज फिंगर्स हियर एंड हियर, राइट? एंड फॉर सम सर्जरी और समथिंग शी इज कम, जैसे मेरे को खांसी आ रही है समथिंग, आई वांट टू चेक द पल्स ऑक्सीमीटर रीडिंग. फिंगर में देयर इज नेल पेंट, यू कांट चेक इट. यू से चलो आई विल ट्राई द टोज. ऑल द toes, they also have the same kind of nail paint. You think only fingers have that nail paint? Toes also have the nail paint. You can't use it. What is the next option, guys? Remember, it tells you the peripheral circulation. Am I right? It's telling you the peripheral perfusion. Periphery. Body में और periphery कहाँ है? Think about it. Where else is the periphery? Finger, toes. Periphery. Ear, right? Ear lobule. So see, the girl has gone for a wedding. Not one earring. She comes with 10 earrings here and here. So ear also not there. You can't put on the ear, huh? That ear is also, ear lobule is also gone. Next. नहीं, ईयर गया ना डॉक्टर विकास, ईयर इज गॉन. नेक्स्ट आफ्टर ईयर इज नॉट पॉसिबल. बोथ द ईयर्स हैव इयररिंग्स फ्रॉम ईयर टू ईयर. 10. फिर क्या बच गया? एनीवन? बस इतना ही. व्हाट एल्स कैन यू थिंक? Nose, right? Dr. Harshad, absolutely correct. Nose tip, absolutely correct. Tip of the nose. But that girl has gone for wedding. They have nose pin, they have nose ring, and nowadays they've got a nose, this connection also between the two. Even that is not possible. Next option. There are 3 more options, guys, which you have seen basically in NICU or pediatric patients. So apart from finger, toes, ear and nose, guys, remember you can also use the thenar, hypothenar and sole of the foot. but this is more commonly used in neonates. So you must have seen people keeping this a band also over here, right? So that band basically is not, in adults it's not very easy or gives you a correct reading, but yes, in pediatric patients, in neonates, it has been used many times. Especially neonates, you use the thenar, hypothenar and sole of the foot. So people who have seen or worked in NICU, NICU, they would be knowing that in neonates we use the thenar, hypothenar or sole of the foot. अरे टंग में नहीं, डॉक्टर मंकी किंग, आई न्यू दैट. मैं यही सोच रहा था कि किसी ने आंसर अभी तक मुझे कैसे नहीं दिया. Someone was supposed to give this answer. The point was to stimulate your thinking. No, that is the wrong answer. It doesn't work over there. Okay, right? Lips पे भी नहीं होता है, tongue पे भी नहीं होता है. You can't keep a pulse oximeter reading on the lips. Imagine a surgery is going on. If you just want to measure it, is maybe fine, but no one has done that. We don't do it also. But tongue and lips are not used. Remember, it is finger, toes, ear, nose, thenar, hypothenar, sole of the foot. Okay, clear guys? So that is pulse oximeter. Let me take the next question. That was a good question. Basically, amputation, that can be asked in the exam. Patient with amputation, where will you check the pulse oximeter reading? Right, that's a good one. Okay, next question. Okay, so next question guys, give me the answer. Eight-year-old patient is to be operated for squint surgery under GA. Which of the following anesthetics should be avoided in this patient? Nitrous oxide, sevoflurane, desflurane or halothane? Dr. Pooja has given an answer. Other people, I'm waiting. Then I'll share the answer after that. Other people, yeah, the answer. Dr. Pooja has given the answer. Other people, I'm just waiting for the answer. Dr. Syed Udasi says nitrous. Anyone else? D, C. Oh, all confusing. Huh? Some people have given the answer A, some people have given D, and some people have given C. A, C, D. A, C, D. This is the 3 में कैसे confusion होता है यार? Confusion should be only 2 of them, not 3. So, doctor, let me just go forward and just see who gave the correct answer. D. Arey, read the question first. Wait, all the people with D. So people who said nitrous oxide, I can still understand. People who said nitrous or people who said halothane, I don't understand, because first read which of the following should be avoided in this patient. 8-year-old patient, उसमें halothane कैसे contraindicated होएगा? डॉक्टर मेडिको इज सेइंग, यहाँ पे पॉल डाल देते हैं. हाँ यार, आई गेट योर पॉइंट, वील ट्राई टू डू दैट. पॉइंट टेकन डॉक्टर मेडिको फॉर एवर. करेक्ट करेक्ट, वो पोल से मेरे को समझ में आ जाता है. करेक्ट करेक्ट, एब्सोल्युटली करेक्ट, एब्सोल्युटली करेक्ट. सो सम पीपल फॉलो, दे आर फॉलोइंग, राइट. एनीवेज, लेट्स कम बैक टू डिस्कशन यार. सो हियर what the point is, halothane and sevoflurane ideally are drug of choice for a pediatric patient. So this option is out, both of them. As I said, your confusion should have been between A and C. I accept it. If there is a confusion, I accept it. It should have been there. So, which of the following anesthetics should be avoided in this patient? Nitrous or desflurane? Remember, desflurane property D. D is for dirty smell. Dirty smell means pungent. Pungent means bronchoconstrictor, and bronchoconstrictor should not be used for inhalational. I mean, for a pediatric. More than that, in a pediatric patient, the point is the reason why this pungent and dirty smell, even forget the bronchoconstriction part. This pungent, why is it not to be used? Because what happens in a pediatric patient, they don't let you take IV cannula. Imagine 8-year-old patient is coming for squint, right? The parents have said get the squint surgery done. Now you think, do you want the 8-year-old to, she or he would want to undergo the squint? No. That 8-year-old does not know what is squint. The 8-year-old will not have any problem with squint. Okay. The patient will never let you take an IV cannula. So when you have a pediatric patient, guys, in this case, what we do, instead of taking an IV cannula, but all of you know na, IV cannula, from where we give medicines, right? So you cannot be using drugs for that patient from the IV. So what we do is we can become old-time anesthetist. We take the mask, we keep it on the face and put the patient to sleep, right? We put the patient to sleep. And that is what is called as inhalational induction. Means you're taking a mask, you're keeping on, so this is a patient, I keep a mask on the patient's face, right? I keep a mask on the patient's face. And this mask basically is giving the inhalational. So I'm not getting, there's no IV that I have in the patient. There is no IV that I'm getting. So I'm giving all the inhalationals to the patient from here. From the respiratory system, it goes to the lungs, and from here it reaches the brain, right? That is how it works, right? So now you will realize, because I don't have an IV cannula, there is no IV available, I am using a inhalational induction to put the patient to sleep. That means four of them will be holding the baby, and we'll hold a mask on the face, and the baby will be fighting. So in this case, if you are using desflurane, which has got a pungent smell, okay, pungent smell, which also is a bronchoconstrictor, and a baby is fighting, there are high chances of bronchospasm. Plus the baby will always remember the dirty smell. All the things are there. So therefore, because of these reasons, I will not be using it, and therefore why we say is, that is why desflurane is contraindicated for a inhalational induction. You will not be using it. It is contraindicated for a pediatric induction. You will not be using it. It's not a drug of choice. Desflurane becomes drug of choice only at 2-3 places. One, desflurane will be drug of choice for renal patients. It is drug of choice for daycare surgery, right? So renal patients, daycare surgery, this is exactly where you will use desflurane. And one more thing is shock. In a patient of shock, remember I told you it's a sympathetic stimulation. So these are the only places that you will be using desflurane: daycare surgery, in shock, and renal patients. Apart from that, desflurane is not preferred, or I mean, I would not want to use it everywhere. Kidney patients, daycare surgery, and shock. This is exactly where we use desflurane, right? Desflurane. Okay, everyone. And remember, for a pediatric patient, sevoflurane, halothane become drug of choice. So let me do one thing. In short, I'll just discuss with you. So if you get a pediatric patient, here the drug of choice is going to be sevoflurane, better compared to halothane. You get a liver patient, here I will prefer sevoflurane, right? If a patient is renal, kidney, here I prefer desflurane. I'm discussing all the drug of choices. You get a cardiac patient, ideally isoflurane, almost the same as sevoflurane many times, because it has coronary, it's a coronary vasodilator, it causes that coronary steal phenomena. So therefore it's approximately the same, CVS. In CNS, again sevoflurane is preferred, right? So if I'm missing out in system, in daycare surgery, you go for desflurane, right? So pediatric patients, and also respiratory is left. In respiratory, again sevoflurane, better compared to halothane. Both can be used. So these are the drug of choices for various system, guys. So in short, you can just kind of go through it as a last moment thing. Pediatric patient, always sevoflurane over halothane. Liver patients, we prefer sevoflurane, it is non-hepatotoxic. Renal patients, we prefer desflurane. Cardiac patients, isoflurane equal to sevoflurane. And in shock, as I said, we can go for desflurane. CNS, we prefer to use sevoflurane. Again, iso is also used, but nowadays we prefer sevoflurane. Daycare surgery is desflurane. Respiratory patients, sevo more than halo. Thumbs up, everyone. Okay, clear all of you? हाँ, डॉक्टर दीप दास लिखा तो सीवो हेलो. Both are bronchodilators. Remember, sevoflurane, halothane are both bronchodilators. They are both bronchodilators and both are sweet smelling. Sweet smelling and bronchodilators. Right, Dr. Deepdas? Okay, Dr. Pooja, okay? Any questions or doubts still here? So that is inhalationals in short. Question घुमा फिरा के इसमें से ही पूछते हैं. In short, that is the last moment revision before you go for the exam. These 5 points from sevoflurane, from all the inhalationals, right? These 5 points. 5, 6 drug of choices. Clear? हाँ, Dr. Agrajyoti. Nice name, huh? Dr. Agrajyoti Chaudhary. Nice name. Sweet smell means ekdam Baba Ramdev. You think after doing chest medicine, I still took up anesthesia? Early morning, I go to the hospital. Which branch you get where you change into your scrubs, hold the mask on patient space. The early thing in the morning, you change into your pajamas, kurta, you know the scrubs which are there, slippers, hold the mask, and when the patient is breathing, just follow Baba Ramdev. Parents say follow him and I follow. Right, everyone? Okay. So let's go forward. It's the branch of smokers, dopers and rave party goers. You people don't know that. Absolutely. अरे branch यही है. When you tell anyone कौन सा branch का है, हिंदी में you translate. You say anesthesia branch का है. कौन सा branch का है? नशा वाले branch का है. नशा करता है और कराता है. It sounds so cool, you know. It sounds so cool. नशा करता है, नशा कराता है. Imagine how good it sounds. And officially, officially I'm allowed. Officially. No one else. In my hospital also, I'm the narcotic head. Narcotic means no one else can prescribe. I signed the narcotic form. Narcotics. Got it? All of you? Dr. Khushbu says, you have great sense of humor. Oh, thank you, yaar. Thank you. Humor to nahi hai, yaar. This is normal way what we do, yaar. I just tell you the secrets. No one tells you the secret, yaar. You think why we all anesthesia people are always happy in the OT? Always khush. You people, interns and post-interns, has any anesthesia person ever told you, please attend the posting, I'll not give you signature? You talk to the senior, you talk to AP, you talk to associate professor, you talk to professor HOD. They say, don't attend, beta. Ghar jao, padhai karo, hum signature de denge. Have you seen a gynec person ever tell you, beta, ghar jao, main sign karungi? Have you ever seen a gynec person say, beta, you go home, I'll stand outside the blood bank? Your whole internship in gynec goes outside the blood bank. Am I right? Gynec internship is outside the blood bank. Yes, yes. Dr. Medico says anesthesia boss of surgery. No, anesthesia, basically anesthesia people are in charge of the OT and then in charge of hospital. And I'll tell you what happens. Anesthesia, guys, remember, is quick decision making. You know, this is the most important thing about anesthesia which people don't know. Quick decision making. I'm talking of 3 days back in my hospital. We inserted, I'll tell you, there was something in airway device. We took it out. Immediately there was laryngospasm. We had to intervene then and there. Quick decision. I could not have given oral medicine. Chal, ghar pe ja, laryngospasm theek ho jayega. Then and there. If a patient gets arrhythmia, I need to treat the arrhythmia then and there. You know, I'm scared of heights. This is what gives me my adrenaline rush. Trust me. Anesthesia, when the things are going wrong, is the branch which gives you adrenaline rush like no other. I mean, I'm not saying surgery might not. It might for few people. But I was not a surgeon. I never wanted to take up surgery. But because of the quick decision making, if you have to intubate, you will intubate. You have to do CPR, you will do CPR. It's quick decision making which gives you that adrenaline rush. Right? वो डॉक्टर लाइफ से सर आई वाज टोल्ड टू अटेंड ओटी. अरे तो वो लोग जो बोलते हैं ना एनेस्थीसिया में अटेंड दी ओटी, दे आर दोज पीपल जो सीवोफ्लोरिन नहीं लेते हैं. गॉट इट? द पीपल हु टेक सीवोफ्लोरिन दे डोंट टेल यू एनी टाइम टू अटेंड एनीथिंग. जैसे कि तुम भी मजा करो, हमको ही मजा करने दो. चलो नेक्स्ट क्वेश्चन गाइस. राइट, 60-year-old patient with cardiac issues is to be given GA. Which amongst the following IV anesthetics is best suited for this patient? Yeah. 60-year-old patient with cardiac issue is to be given GA. Which amongst the following IV anesthesia drugs is best suited for this patient? So I've discussed all the inhalationals with you. What is the drug of choice in various systems? And we are taking about a cardiac patient, 60-year-old. Dr. Uikawa says one answer. Yes, other people, let me see. Dr. Vidyasagar has given an answer. Yeah. देखो यार, तुम लोग, all of you have given me the correct. Dr. Deepdas also, Dr. Surya also, all of you absolutely correct. So you have given me the correct answer, all of you. So the correct answer here is A. Etomidate. Absolutely correct. Okay, a patient who has a cardiac issue, ideally the best drug of choice for that patient is etomidate, because it kind of maintains the cardiac output. Okay, it maintains the cardiac output. All right, it maintains the cardiac output, etomidate. But if you want to enjoy the drug, the best drug is here. Okay, that we'll discuss later. Right, so if the patient has cardiac issues, in that case we're using etomidate. Can we use thiopentone and propofol, guys? Yes, in a cardiac issues I can use thiopentone and propofol also. However, if someone says which is the best suited, which means which is the drug of choice in a cardiac issue, it's always going to be etomidate. So this becomes the best suited. It's not that if a patient has cardiac issues, thiopentone is contraindicated. So there are places where it is contraindicated, right? Right, Dr. Chaudhary, right? Dr. Jyoti Chaudhary, absolutely correct. So when we speak of these inhalational agents, sorry, IV agents, let's discuss the IV ones. So if I'm discussing the IV agents, if a patient has cardiac issues, remember here the drug of choice is etomidate. Etomidate in cardiac. However, if in the cardiac, if the patient is in shock, I'm going to use ketamine because it increases everything, right? All other drugs are going to decrease heart rate, BP. And if you will find etomidate is something which maintains the cardiac output, right? It maintains heart rate, BP and cardiac output. Ketamine kind of increases everything, and therefore it is used in shock. Apart from shock, if someone is having shunt, okay, which is tetralogy of Fallot, here also ketamine becomes drug of choice. Okay. Dr. Medico, ketamine is the first love of anesthesia resident. I'll come there, yaar. Ketamine. Imagine, it is such a good drug that psychiatry people have taken it, yaar. Dr. Dharmendra ko pucho. Dr. Dharmendra will tell you. Dr. Dharmendra and I have got close friends. You know, in fact, all the people when we are together, a lot of us are close friends, you know. So I think anatomy, all of you must have seen from Dr. Pradeep. I don't know whether people are aware or not. Dr. Pradeep and I used to play in childhood together, Bombay mein. Dr. Dharmendra and I almost practice together. We are together, right? Clinically also, right? We are over there. And Dr. Dharmendra says, "You've taken ketamine, yaar. Ketamine हमारा drug था." It is used as an antidepressant. I'm not really sure whether you people are knowing it or not. This is one of the new uses of ketamine. It's also used as an antidepressant. Correct. It was not like this before, but recently ketamine studies, it is also said it is used as antidepressant. But let's not go into it. We are discussing the anesthesia part of it. Okay. So I'm not going into that. Etomidate, guys, maintains cardiac output. Ketamine increases heart rate, BP, cardiac output, everything, used in shock, tetralogy of Fallot. But if someone does not have a major cardiac issue, right? Major cardiac issue agar nahi hai, so in cardiac patient you can still use propofol and thiopentone. However, etomidate is always going to be preferred, right? I can still use propofol, I can still use thiopentone. Only places where I will not use propofol and thiopentone in a cardiac patient is if someone's BP is less, right? If someone is in hypotension or hypovolemia, right? In that case, you can't use propofol. It will cause straight away fall in blood pressure. Same thing in thiopentone. If someone has hypovolemia, let me put it this way. Okay. Both propofol and thiopentone should not be used if someone's BP is low or if someone has hypovolemia. Alright. And thiopentone is also one more thing in case of blocks. If someone is having a block, you will not use thiopentone in case of blocks. Various arrhythmias and all, you're not going to use it. Okay, you will not use it. So this is about the cardiac patients. If you speak of CNS, remember thiopentone is barbiturate. Barbiturate is phenobarbital. Phenobarbital is used for CNS. So thiopentone becomes the drug of choice for CNS. Just remember that. Thiopentone is a barbiturate. Barbiturate is phenobarbital. Phenobarbital is used for CNS. So thiopentone is used for CNS. It is the drug of choice more over propofol. Okay? More over propofol. However, if someone is to be given psychiatry, ECT, electroconvulsive therapy, shock, it's become psychiatry, not CNS though. But in psychiatry, ideally the drug of choice is methotrexate. Right? But because of complications, we don't use it. Methotrexate. Can you see hypothalamus pituitary? It causes HPA axis suppression. So because of that, it is not used. And nowadays what we use is, rather than methotrexate, we use propofol for shock in psychiatry when you give ECT. Right? So this is about the CVS, this is about the CNS. Let's talk about the respiratory system. Respiratory system, the best drug is ketamine. Remember, if someone has active bronchospasm, means someone is having a bronchospasm, here the drug of choice becomes ketamine. Right? If someone is having active bronchospasm, I have to give GA. There's no other option left with me. I will use ketamine in this patient. Active bronchospasm. Okay? And if someone is having no bronchospasm, in that case, propofol can be used. Right? Pediatric patient, ketamine is preferred. Full stomach patient, ketamine is preferred. Right? Liver, renal, daycare, routine sedation, routine GA, malignant hyperthermia, porphyria, everywhere else, guys, everywhere. Let me put it like this. Everywhere else is propofol. Everywhere is propofol. Okay? Everywhere is propofol. Otherwise, these are the only places that you will see. Otherwise, everywhere, liver patient, renal patient, daycare surgery, sedation, GA, routine anesthesia, everywhere we are using propofol, guys, propofol. So propofol is a drug of choice which can be used at most of the places. Malignant hyperthermia, porphyria, ICU sedation, everywhere you will use propofol and you can use it, right? Apart from that, these are the things which we are discussing. So this basically kind of is a complete revision for all the drug of choices of all the IV drugs. Everyone okay? Thumbs up. That's exactly what is revision. Okay, in short. Eye surgery. Again, same thing. Eye surgery also you can use the same thing. CNS and ophthal you can put over here. Both thiopentone and propofol can be used, right? Right? Thiopropofol. Both can be used. Almost the same, but I'll put it in this way because this decreases the intracranial pressure, that decreases the intraocular pressure. Both I put it here, na? Dr. Medico forever, same. Thio and propofol. So if it is ophthal, then I will not say thio is preferred. In ophthal, we'll say thio equal to propofol. Propofol equal to thio. Let's put it this way. Okay? In ophthal, thio and propofol are considered equal. But yes, as you can see, everywhere is propofol. So nowadays what we do is we prefer propofol. But as a drug of choice hai nahi, ophthal mein. It's nothing like that. It is just that you'll find thiopentone decreasing the intracranial pressure. Thiopentone also decreases very much the intraocular pressure. So if it is possible, you will try to use thiopentone. But because propofol is used everywhere, and that's the whole point that propofol is also preferred over ophthal. Okay? Otherwise, you will find thiopentone decreasing both intracranial pressure and intraocular pressure. Everyone okay? Okay till here? Thumbs up all of you. It's okay, then I'll go forward. Yes. So basically all the drug systems we have done. So sevoflurane, when we spoke of inhalationals and IV, we finished all of them. Complete revision. Yes guys, may I go forward then? I was waiting for your text. Yes guys, may I go forward? Dr. Amit, okay. Chalo. Right. Billionaire club. Please include me also in the club. Try to. ठीक है, मेरे को भी include करो. Right. So all of you have given me a thumbs up. Let's go forward here. So I was missing talking to everyone and then taking a class like this. Yeah. I missed for quite some time. Now it feels so good. Nice. All of you prepare well, give your exams well, and do clear. I got so many messages from all the FMGE students. So many messages. I could not include them. People have done absolutely well in FMGE. It was almost 39% or 33 to 39% passing, and FMG was absolutely great. Wonderful to have seen messages from everyone, guys. So guys, for same thing holds true for all of you. Prepare well, clear your NEET PG, do well, and pick up the seat of your choice. Okay, all of you, be confident. Yeah, that's the whole point. Be confident. Don't get worried कि NEET PG आ रहा है. अरे आ रहा है तो आ रहा है. अरे ऑप्शन तो देने दो डॉक्टर स्वतंत्र. करेक्ट. Okay, right. The patient is undergoing plastic surgery for the second time for scar recorrection. He still remembers that the first time when he was being given IV anesthetic, it was very painful. This time he requests for an IV anesthetic agent that does not elicit pain on injection. Which of the following should be considered? This is the same question which was asked in previous year, but I've changed the format. As I said, I keep on changing. You people know that. So I've changed the format to make it more clinical. Okay? More clinical. That's how clinical questions come in exam. डॉक्टर अग्रज्योति ने प्रीवियस अभी क्वेश्चन दे दिया. देखो मैं आई नॉर्मली आस्क वन क्वेश्चन एंड आई से ओके लेट मी चेंज द ऑप्शन. डॉक्टर अग्रज्योति हैज गिवन द आंसर फॉर द प्रीवियस आल्सो एंड ही हैज गिवन द आंसर फॉर दिस टाइम आल्सो. गुड, दैट्स नाइस. डॉक्टर पीयूष गर्ग इज आस्किंग मी, इज प्रोपोफॉल गिवन इन LA सिस्टमिक टॉक्सिसिटी? डॉक्टर पीयूष, नो इट इज नॉट. Ideally, that's not the point. If you want to intubate, then otherwise it's not given. Alright, so I've got different answers from people. Right, Dr. Swatantra Verma has given the answer regarding pain on injection by which drugs. Dr. Mayank has given the answer for here. Dr. Agrajyoti has given two answers. Even if the question पूरा depth में नहीं बोलते कि तो question के depth में घुस गया, that is Dr. Agrajyoti has gone totally inside the question. Right, Dr. Vidyasagar has given an answer. डॉक्टर दीपांशु सेज हम सर एमडी मेडिसिन के लिए कितने कोई नंबर? अरे यार इट्स नॉट द नंबर ना. यू पीपल हैव गॉट मैचेस गाइस. अपार्ट फ्रॉम द नंबर दैट यू गेट, इट इज ऑल्सो विद द काइंड ऑफ मैच दैट हैपेंस. इट्स व्हाट द ऑप्शंस दैट यू आर फिलिंग अप. समटाइम्स पीपल विथ लो रैंक हैव गॉट बेटर कॉलेजेस विच यू पीपल डोंट नो. Right, sometimes people with high rank because of the choices have got colleges that they can't expect. And now a bigger newer thing that I've heard from all of you people who are appearing for and asking is like, sir, if I'm getting MD in a bad college, according to you, bad college, bad means bad government college, huh? Not private also. Sir, MD in a bad government college according to you, or DNB in a good private college, good private hospital? Biggest point is this. So many students have asked me this. I always have gone with the fact. For example, DNB in Delhi, there's something called as Gangaram Hospital, which is very famous for doing DNB, or Apollo. It's got huge, even Fortis and all, they've got huge seats. All of our hospitals have good DNB. But whatever said and done, I will say, if you're getting MD in government, yaar, always prefer it over DNB. Because MD में घुसना मुश्किल होता है. To clear MD is easy. DNB में घुसना मुश्किल होता है. I mean, easy होता है. But many times you don't know. Sometimes to clear the final DNB, it is very, very difficult. Yaar, you people have seen all the people who have cleared DNB the very first go. But there are people who have not been able to clear DNB for so many years. ठीक है? So I always tell students, यार जहां भी हो सके pick up MD. And if you don't learn in MD, it's okay. You can always do your senior residency after that. You do a senior residency in a good private hospital. Now, what difference does it make? They're going to pay you good amount of money. So you're working and learning at the same point, but according to me, MD should always be preferred over DNB. Whatever said and done, that's my personal opinion. Some people don't agree with me, and I've got these discussions done with my colleagues also. A lot of my colleagues feel that no sir, DNB in a good private institute should be preferred over MD in bad. No, I am not of the view. I am of the view straight away that pick up MD over DNB at any point of time. I myself have done DA DNB. The whole point of doing my DNB was because I left my MD seat to pick up DNB, to pick up DA. I did my DA because I wanted to stay in Bombay. I didn't want to move out of Bombay. Right? उस समय मैंने MD outside Bombay छोड़ दिया था. I had left MD anesthesia outside Bombay in good colleges to pick up DA to stay in Bombay, Grant Medical College. Right? But the point is later on I realized कि ultimately DNB तो करना पड़ेगा ना. So why you want to take all these things here? Don't go for DNB straight away. If possible, go for MD. That is my sincere advice. Okay, everyone. Coming back to the question now. Sorry, we got deviated thoda sa left. Let's come back. CPS ka diploma, right? Again, one more point. I've also done CPS. Now the point is, okay. CPS ka yaar diploma mein na DGO, DCH, and I think one only they are MCI recognized. If you do FCPS, so according to me, it is FCPS surgery, FCPS medicine, and FCPS pathology, which are MCI recognized. Rest all CPS and FCPS are not recognized. I am DA, DNB, no wait. I am TDD, FCPS, no DA. Sorry yaar, DA, FCPS, DNB, right? So this basically FCPS I thought was equal to MD, but no, FCPS many times is not recognized by MCI. It is DNB which gets recognized. It is your university DA which gets recognized. Okay. So my point of view always is jahan tak ho sake, all this should go last. Any MD should be preferred over diploma, and all this should be preferred over DNB. And after that should go CPS. That is my point of view. This is my point of view. Everyone else might differ. This is my point of view, right? So Dr. Medico forever, ठीक है? Dr. पीयूष ने पूछा था. हाँ तो Dr. Medico, you'll have to see ना CPS के कौन से courses recognized हैं. Lots of them they are not recognized many a times. That's the problem. That's the problem, and you don't come to know कब recognition change हो जाएगा. ठीक है? Wait, Dr. Piyush has asked me. So Dr. Piyush has asked me one question regarding local anesthesia systemic toxicity. So in this local anesthesia systemic toxicity, option A is chest compression at 100 per minute, right? Dr. Piyush, I have got that answer later on here, but chalo theek hai, I got that question. So B is ventilate with 100% oxygen, right? And propofol C, which bind to the local anesthesia drug, and D. C is the wrong answer. Correct answer A, B and C, A, B and D are all done. So Dr. Piyush, the C is not done. Okay? Dr. Piyush, got that answer? Dr. Piyush, is that okay? Sorry, मैं पूरा झुक गया तो मैं दिख नहीं रहा हूँ. Sorry. Dr. Piyush, all okay? Right, so let us come back to the answers now, questions now. Sorry. Slight deviations. Now coming back to our discussions. Sorry, मैं पूरा अंदर घुस गया था. मैं पूरा घुस गया था यार. I could not see myself on the screen also. पूरा अंदर घुसा हुआ था मैं. Okay. So Dr. Piyush, the answer there is C. It's not propofol. Okay. A, B and D are all done for your question, but I have got a question like that later on. Now, all of you have given me the correct answer over here. Guys, remember, ketamine is the drug that does not elicit the pain. It is correct. Reason, ketamine is an analgesic drug. Right? All these three basically are painful injections. When you speak of painful injections, you will find that propofol is more painful. Sometimes they say equal to etomidate, which is more painful than methotrexate, which is used for psychiatry, and compared to thiopentone, right? And ketamine is analgesic drug. Reason, all these drugs that you see, propofol, etomidate, methotrexate and thiopentone, these are the drugs which work on GABA receptors. Okay, so all these drugs you will find they are working on GABA receptors. However, you find ketamine, that N, ketamine is a drug that works at NMDA receptor. So ketamine, guys, is a different drug from all of them. It has got different properties. All of them are kind of decreasing the things. Ketamine is kind of increasing the things. All of them are otherwise decreasing. Okay, and ketamine is sort of increasing. So ketamine is that drug. Apart from that being having analgesic properties, guys, this drug also has hallucinations and delirium. Alright, it produces something which is called as dissociative anesthesia. This question has been asked in exam. It also produces amnesia, right? And because of dissociative anesthesia, it causes hallucinations, delirium, and the patient is coming out. There is dreaming. So these are called emergence reactions. Okay? Correct, Dr. Swatantra. Correct. So these are all the drugs which work at NMDA receptors, and you'll find which drugs work at NMDA. Correct. Let me just put it fine. Ketamine works at NMDA receptors, right? Nitrous oxide works at NMDA receptors. Entonox works at NMDA receptors, and you'll find xenon also working at NMDA receptors. Okay. So this is about ketamine, and because it produces hallucinations, guys, ketamine is the drug of choice in medical college. You love it. One more question, huh? मेरे को question आया है, कर लूँ क्या? One more question. I have got another question. I want to. This question has been asked in exam. Ketamine can work from all routes except, okay, IV, IM, subcute, nasal. Yes, guys. A, B, C, D. Yes, guys, answer. क्वेश्चन आता है ना, तो वैसे क्वेश्चन आ गया. हो डॉक्टर JNV, मला मराठी येतात आणि चांगलं मराठी येतात. मी सांगितलं पहिला पण. थोडा थोडा मराठी येतात, हा. मी बोलू शकतो. आय कॅन स्पीक मराठी. मराठी माणूस, बॉम्बे. Right? Give me the answer, guys. Ketamine can work from all the routes except. I'm waiting for your answers. अरे हाफ इंजीनियर, रियल गाय, तो हम लोग क्या हैं? नाइस नाइस नेम्स, हाफ इंजीनियर, हाफ गर्लफ्रेंड, हाफ डॉक्टर. ओके, सो डॉक्टर कैसा लगता है बोलने में? डॉक्टर हाफ इंजीनियर, डॉक्टर रियल गाय. तो डॉक्टर दीपांशु कैसे बोल रहा हूँ? डॉक्टर दीपांशु. आई एम सेइंग डॉक्टर दीपांशु कालरा, राइट? सो डॉक्टर दीपांशु, आई एम एड्रेसिंग बाय हिज नेम. डॉक्टर इंजीनियर को बोलना पड़े, डॉक्टर हाफ इंजीनियर. So the people who give me the answers are all correct. Subcute. It can work from all the routes except subcute. That's an important point which has been asked in exam, right? Ketamine can work from all the routes except subcute. Therefore, remember, ketamine works from all the routes, huh? All the routes. It can work from nasal also. It can work from oral also. It can be given intrathecal also, right? It can work from all the routes except subcute. That's a question which has been asked. Okay? So most of you are correct. Absolutely. अरे किसी के नीचे डॉक्टर मेडिको फॉरएवर ने क्या लिखा है? अरे अब कुछ चीजें तो मेरे को समझ में नहीं आता यार. ओके, लेट्स गो फॉरवर्ड यार तब तक. ऑलराइट, वेयर वर वी? ओके, तो इफ यू पीपल आर नॉट बोर्ड अप, कैन आई टेक दिस? इसमें आई विल डिस्कस अ लिटिल बिट. ब्रेक तो नहीं चाहिए तुम लोग को अभी? ऑल ऑफ यू, let me know before I take the question. So I want to discuss one point. That's an important question, and that will if I'm discussing it out, I want to discuss the mechanism also. So in that discussion, I will take about 10 minutes when I want to discuss this point, right? So do you want me to take the break, or should we go ahead with the session? क्या चाहिए? डॉक्टर स्वतंत्र लेट वे को ऑप्शन तो देने दो ना, वेट ना. I know you are right, all of you know it, but then let us go forward with that ways. Yes guys, so let us take this question. Let's do this as the last question before we take the break. Okay, so let's do this last question before break. Wait, let me put before break, before the break. Okay, so we are doing the last question before the break, and after that we'll take a 15-minute break, and then we'll meet again and finish off the other parts of anesthesia. So if you will see, a lot of points we have covered. Let's start with this point, muscle relaxants. Okay, so these are the options. Which of the following is the mechanism of action of the curare group of muscle relaxants? Is it repetitive stimulation of acetylcholine receptors or the muscle end plate, competitively blocking the binding of acetylcholine, persistently depolarizing, or inhibiting the calcium channels? So mark your answers A, B, C, or D. Yes guys. Right, Dr. Rose and Dr. Swatantra have given the answers. Other people, I'm waiting for your answers. This question was again a recent question. I think it is 2021 NEET PG question. Straight away the previous year. Okay. Dr. Rudra, Dr. Real Guy. Dr. Arshad. Dr. Medico Forever. Okay, I think most of you, in fact all of you, have given me the correct answer. Okay, let's change the question. Okay, let's change the question. May I? Dr. Beat says Marathi पण. अरे पर सब लोग मराठी नहीं आएगा ना सबको. मैं तो मराठी बीच में बोल सकता हूँ, लेकिन बाकी लोगों को तो मराठी नहीं आता ना. अरे थोड़ा थोड़ा गुजराती आता है. थोड़ा देर के बाद ना पूरा नेशनल इंटीग्रेशन का प्रोग्राम चालू रहेगा यार. It's okay. We'll do with English and Hindi also, right? So that everyone else also understands. English and Hindi is okay, right? With everyone, right? Dr. JNV Bead. We can speak in Marathi also, but then in that case, not everyone will kind of understand. Okay. So in this question, the correct answer is B. Absolutely correct, all of you. Let me go question अब बदल देने दो. Let me change the question. What is the mechanism of action of? Let me change it now. I'm changing it. I'm changing the question. Question ही change कर दे रहे. Mechanism of action of succinylcholine. Option remains the same. Sort of. I have kept almost the same thing, but sort of. So what is the correct answer here in this case? I mean, थोड़ा सा change हो सकता है. Mechanism that I'll discuss with you. Right? बीच में हिंदी बोल लेंगे ना, कोई दिक्कत नहीं है यार. हिंदी बोल लेंगे, इंग्लिश कर लेंगे, so that everyone understands, whosoever is there. So both the languages are okay with everyone around, right? Nice. Other people, answers दे दो फटाफट. So we'll discuss this point out. Okay, Dr. Mudassi, Dr. Travanthi, Dr. Swatantra, Dr. Real Guy. Okay. So all of you have given me the correct answer. If it is succinylcholine, it is depolarization. Correct. So when you speak of muscle relaxants, guys, remember muscle relaxants. Okay. So muscle relaxants are drugs or agents which kind of paralyze the muscles. Okay. So when we speak of muscle relaxants, these are the drugs which cause muscle paralysis. Okay. These are drugs causing muscle paralysis. How do they paralyze the muscle? Paralyze का muscle मतलब होता है कि there is no movement seen. No movement. How does that no movement take place? So routinely what happens is that when you pinch someone and you withdraw the hand or you contract the hand, the contraction takes place because the action potential is generated, right? So if I pinch someone here, यहाँ पे अगर pinch करते हैं, action potential generate करता है, ऐसे जाता है, it goes like this to the spinal cord, from here it reaches the brain, from the brain that action potential again comes back to the spinal cord, and from there it comes over here and you withdraw the hand, right? So that is how you are doing a contraction, and the contraction takes place where? At the neuromuscular junction. It is taking place at the nicotinic receptors, right? Neuromuscular junction. So when we speak of neuromuscular junction, this is our neuromuscular junction. So when this action potential comes back to the nerve ending, so this is the nerve ending, action potential is coming back. So this is your nerve, this is the muscle. Ultimately, it is the muscle where the movement will take place. So the action potential has come back to the nerve ending. From there, it's going to go inside the muscle, which will lead to contraction. I want to stop the contraction. I want this contraction not to take place, right? I want the muscles not to move. So what to do? Don't let the action potential come inside. Understood? If I want the contraction not to take place, the muscle not to move, the whole problem was action potential came inside the muscle. So when the action potential is coming back, stop this. Okay, how to stop this? Normal muscle contraction takes place when this is the nerve, here is the muscle, nerve and the muscle. Normal contraction takes place when the action potential comes to the nerve ending. These are synaptic vesicles which contain acetylcholine, as you can see, right? These are synaptic vesicles. So when action potential comes to the nerve ending, it releases acetylcholine in the synaptic cleft, right? And these get bind to the receptors over here. So when molecules are bound, then suddenly what happens? Sodium goes inside, potassium comes outside, and this is what is called as the depolarization. And depolarization means this is what is causing the muscle contraction. So I don't want muscle contraction to take place. So I don't want depolarization to take place. So what I do? Instead of letting acetylcholine sit over here, don't let acetylcholine sit, because once acetylcholine will sit, only then it will enter inside. So what I do? I give non-depolarizing. I give vecuronium. Or if I've given rocuronium or rocuronium. So now there is no place for acetylcholine to sit. Why? Because they become competitive in nature. Competitive means they are fighting with each other. No, not here. Competitive means here, right? Competitive means here. So what is happening is acetylcholine is fighting with the non-depolarizing to see who will sit at the receptor. The one who is stronger will sit. If you've given a strong dose of non-depolarizing like vecuronium and rocuronium, they will sit. Until the time they are sitting, acetylcholine can't enter inside. So therefore, till then there is no muscle contraction, and this is how paralysis takes place. Thumbs up all of you. Clear? Okay. So basically, what are these vecuronium, rocuronium, atracurium and cisatracurium doing? They are basically competitively blocking that receptor. Okay. So they are competitively blocking the receptor, the same point which has been given here. Right? So they competitively bind or block the binding of acetylcholine to the receptors. This is the action of curare group of muscles, which is vecuronium, vecuronium, rocuronium, okay, atracurium, pancuronium. Clear? It blocks the binding to the of acetylcholine to its receptors, because acetylcholine cannot get bound over there. Okay, so once you have given vecuronium, or you have given rocuronium, or you have given pancuronium or atracurium, they forget atracurium because even acetylcholine is A, right? So acetyl, once they are sitting, so therefore acetylcholine can't sit over here, and that is exactly why it is called non-depolarizing block. It is non-depolarizing because no depolarization takes place, because acetylcholine does not go inside. Clear everyone? Right? That was the answer over there. When we speak of succinylcholine, right? When we speak of succinylcholine causes depolarization. Is an example of depolarizing block. What is depolarizing? It causes depolarization. So succinylcholine goes and sits at the receptor and it causes depolarization, which means when succinylcholine is sitting, sodium goes inside, which means if sodium goes inside, there is muscle contraction, which means this is what is causes some muscle contraction before the paralysis takes place, right? So therefore it leads to persistent depolarization. That is exactly why you have skeletal muscle relaxants. We divide our group of skeletal muscle relaxants into two types. Skeletal muscle relaxants are divided into two types. One group is this non-depolarizing, which I just discussed with you. Other group is this depolarizing. So non-depolarizing will have no depolarization, so therefore there is immediate paralysis, no movement, and there is immediate paralysis, immediate, once you've given the drug. But in depolarizing, you will find some movement taking place, right? Because succinylcholine leads to depolarization. That's why it's called depolarizing, and that movement is called fasciculations. So therefore, non-depolarizing are your drugs like vecuronium, rocuronium, atracurium. Depolarizing is succinylcholine. Okay, fasciculations. तो डीपोलराइजिंग में फैसिकुलेशन होता है और उसके बाद पैरालिसिस होता है, राइट? इन नॉन डीपोलराइजिंग में स्ट्रेट अवे देयर इज नो मूवमेंट एंड स्ट्रेट अवे पैरालिसिस टेकिंग प्लेस, राइट? So here it can be reversed by using anticholinestrases. यहाँ पे there is no role of anti-acetylcholinesterase, right? Anticholinesterases are used for reversal. Here there is no role of anticholinesterase. Right? Examples for depolarizing is only succinylcholine. In the past there was a drug called decamethonium. आजकल वो भी नहीं है. Rest all the drugs are non-depolarizing, all of them. And the depolarizing further is divided into two types based on the structures. One type of drug is called aminosteroid group. Other group is called benzyl isoquinolinium group. Aminosteroid group guys has drugs pancuronium, long acting. You have vecuronium, rocuronium, right? And you have on the other hand, in benzyl isoquinolinium, you'll have drugs like doxycurium, you have drugs like atracurium, cisatracurium, and we have mivacurium, right? So these are the group. Here vecuronium is the most cardiostable. So if anyone has any cardiac problems, so this drug used in cardiac patients. Rocuronium routinely can be used in patients who are full stomach. Atracurium and cisatracurium, they have Hoffman's elimination, because of which they are preferred used in liver patients, renal patients, pediatrics, and neonates. And mivacurium is preferred in daycare. This finishes the muscle relaxants, also drug of choice. Okay, all of you, okay? So cardiac patients, vecuronium, rocuronium in full stomach patients. If you what about CNS? What about respi? Respi, any drug which does not release so you will have this vecuronium, rocuronium, all this can be used in respiratory patients also. They can be used in CNS also. Okay. Cataract का question पूछा था. Wait. Which anesthesia is used for cataract surgery and diabetic retinopathy? You give a block, na? Local anesthesia, you give regional anesthesia, right? So that question which they have asked me, all of you, regarding cataract surgery, what type of anesthesia is done? You just have to anesthetize the eye. So you give a regional anesthesia, you just give a block to the eye. It may be a retrobulbar block, it may be a peribulbar block. It is just like how you do a dental procedure. In a dental procedure, you just anesthetize that region, that area of your tooth, right? Similarly in cataract, all you're doing is anesthetizing the eye, you're doing a block. Clear everyone? ठीक है, ये वाला काम भी हो गया. Okay, किसी को doubt? So I discussed with you muscle relaxants also, and here also I discussed the mechanism as well as I discussed with you the classification, and I discussed with you the drug of choices also. Everyone, okay till here? अब थोड़ा सा break ले लेते हैं, 15 मिनट का break. Is that okay? And I'll catch up with all of you after 15 minutes. Any questions or doubts? Ask me. So we'll take another session for about an hour once we come back from the break. ठीक है, ब्रेक के बाद फिर से हम लोग लेते हैं 1 hour के लिए लेंगे. Okay. So let's take a break. Yes, all of you. ठीक है, तब तक एक गाना हो जाता है. जब से तब से गाना नहीं गाया यार, एक गाना गा लेते हैं. क्या बोलते हो? राइट? लग गया मैं भी वैसे. अरे ऑल कॉलेजेस आर गुड फॉर एनेस्थीसिया, डोंट वरी. ठीक है, विल टेक अ ब्रेक इन अ वाइल. ये भी तो ट्राई कर लें. यस ऑल ऑफ यू. छोटा सा. Let's try. I don't know if it will work or not, but let's see. Let's see. Huh? All of you, something different. Hey, a lot of people can play the guitar, yeah. Nothing great, and I don't sing well. But basically, what happens if all of you could sing along with me, then that would have been much better, right? Arey, thank you. Arey, Dr. Paras, thank you. So Dr. Paras is also here. Good to see, guys. Yeah, good to see. Thank you, Dr. Paras. अलग सेशन. हाँ, एक काम करेंगे ना, वापस आएंगे तो फिर से कुछ प्ले कर लेंगे. डॉक्टर दीपांशु ने पूछा आना कब है. करेक्ट, 15 मिनट्स. लेट्स टेक अ ब्रेक ऑफ 15 मिनट्स. ओके, थैंक यू गाइज फॉर ज्वाइनिंग मी एट दिस सेशन. नो, नॉट 15 seconds. We will take a break of 15 minutes and we'll be back for another 1 hour or 1.5 hours and then we'll finish off. ठीक है. नीट एस्पिरेंट इज आस्किंग ये क्या चल रहा है. अरे गाने चल रहे थे यार, अभी ब्रेक ले रहे हैं. नीट पीजी और नीट यूजी ऐसे ही होता है. चलो, विल मीट आफ्टर 15 मिनट्स. थैंक यू गाइज. सो विल मीट आफ्टर दैट. ओके, 15 मिनट्स ब्रेक. अरे डॉक्टर जेएनवी ब्रेक ले लेते हैं, उसके बाद लेट्स फिनिश ऑफ द स्टडीज ऑल्सो ना, उसके बाद. ठीक है. 905. Okay, so timing is being asked by Dr. Dipanshu because you people are also sitting from 6:30 यार. कितने देर बैठोगे? थोड़ा देर कुछ खा पी के आ जाओ. ठीक है. We'll meet at 9:05. It's 9:50 at my watch, 8:50 at my watch right now. We'll take a 15-minute break. 9:05 p.m. we will start with the remaining part of sessions of anesthesia. Till now, I've discussed so much regarding inhalationals, muscle relaxants, and I've seen oxygen delivery devices, anesthesia machines, cylinders, difficult airway, and the rest part of anesthesia we will cover after that. That will finish off the complete revision. Okay, that is exactly the meaning of high yield questions, right? Previous year's questions and a complete revision of the subject, right? So we are trying to touch up all the topics, and that will take care of our studies for hopefully for the NEET PG. Things will be easy. Questions from anesthesia are normally easy. Don't worry. So 905. Bye guys. Okay, we'll catch up at 905. Jaldi jao, jaldi aao. Fast, fast. चलो पापा स्टार्ट करें. आ गया मैं स्क्रीन पे, पर मैं अपने आप को नहीं देख पा रहा हूँ यार. I am laughing because Dr. Rose has commented who is playing the guitar. So I took some time extra because I was tuning the guitar. Okay, the guitar wasn't tuned. Okay. I can't see myself here. I don't understand. Am I visible and audible, all of you? Yes, guys? But I can't see myself on my screen somehow or the other. Refresh भी किया. Now I can see myself. Thankfully. Dr. Yogesh says, sir, you look like Hardik Pandya. Very good compliment, yaar. Thank you. I like Hardik Pandya. हार्दिक पांड्या से यार तो भी देखो शादी किधर हुई उसकी. Have you seen that? Have you seen his wife? हाँ शुरू हो जाए. Dr. Deepdas says you are anesthetized. Yes, all of us are anesthetized, energized. All of us are back. Okay, so let's start here. Actually, Dr. Rose had asked me very good question. कि डॉक्टर रोज का था वहां पे कि सर हु इज प्लेइंग द गिटार. अरे मैं ही बजा रहा था गिटार यार. आई वाज ट्राइंग टू ट्यून द गिटार बिकॉज इट वाज आउट ऑफ ट्यून. ओके, वो थोड़ा सा आउट ऑफ ट्यून था. हाँ, नॉट ऑडिबल एंड विजिबल गाइज. सो लेट्स स्टार्ट विद द सेशन विदाउट वेस्टिंग एनी मोर टाइम. ओके, तो अब बाकी के लोग यहाँ ज्वाइन करते रहेंगे. Okay, so let's start. Actually, I'm just trying to keep in such a way so that I can see your text without any problem. Ah, Natasha, right? Hardik Pandya's correct. He's a good cricketer, yeah. He's a good cricketer, right? चलो शुरू करते हैं अभी. All of you ready? Billionaire Club. डॉक्टर दीपांशु किस चीज का? वो मैं गिटार ट्यून कर रहा था. ओनली डॉक्टर रोज हर्ड इट. डॉक्टर रोज ने लिखा भी हु इज प्लेइंग द गिटार. So I was just trying to tune the guitar at the back यार, because when I played, I thought the guitar was not tuned. ठीक है. हाँ अभी फॉर्म में यार हार्दिक पांड्या. करेक्ट. Okay, so let's go forward. I think everyone has joined then. Shall we start? All of you, thumbs up. Yes. I have one question. Which is the best medical college for anesthesia? अरे यार सब कुछ अच्छा है यार. You do your anesthesia. Point is to just learn ना. Best क्या होगा? If you say all the institutes are well, no one teaches you bad. You ask me where I learned anesthesia, Bombay, Grant Medical College. I love it. ठीक है, free hand the total. I came to Delhi. I came to Maulana Azad Medical College. I did my senior residency. I was assistant professor. I loved it because Delhi was also good. So Grant Medical College तो Bombay हो गया ना. This is Mumbai. This is Delhi. Correct. Both the places are good. I enjoyed. I learned both the things, and I love. Imagine college में you carry the guitar. You guys, do you know the importance? All of you. चाहे वो बॉम्बे हो या दिल्ली हो, all of you. Mumbai or Delhi. More important. Forget anesthesia. Do you know how important guitar is? Dr. Deepdas says, sir, I am in duty attending your class. Oh yeah, how sweet of you. Thank you, Dr. Deepdas. How sweet. Thank you. That's such a wonderful compliment from Dr. Deepdas. Okay, thank you. Okay, guys, forget that. Guitar बजाओ या नहीं बजाओ, कम से कम उठा के चल आना चाहिए स्टाइल में. Let's start with the session. Yeah, now forget. I think everyone is joined now. Okay, so we've got all our people who have been joining in. So let's start with the session now. Okay, without wasting any more time over here. So now let's start. Okay, Dr. Medico says I play piano. अरे great यार, रुक जाओ. डॉक्टर पहले जब म्यूजिक का बात आता है थोड़ा सा चेंज कर लेते हैं. ठीक है, म्यूजिक के लिए मैं थोड़ा सा हट जाता हूँ पीछे. डॉक्टर पियानो सेज नहीं, डॉक्टर मेडिको फॉरएवर सेज ही प्लेज पियानो. ही और शी यार, मेरे को ये भी नहीं पता ही और शी है. पॉइंट इज दैट ना, इफ समवन राइज मेडिको फॉरएवर, मेरे को कैसे पता ही और शी है? वो भी थोड़ा सा मुश्किल हो जाता है. बट एनीवेज स्टिल, हाँ तो यार हम लोग एक काम करते हैं. नेक्स्ट टाइम वी विल जैम. एंड द बिगेस्ट प्रॉब्लम विद दिस यूट्यूब इज, यू नो व्हाट, आई कांट सी यू पीपल. यार कोई दिखता रहे साथ में तो समझ में भी आएगा. एटलीस्ट आई एम सीइंग योर मैसेजेस. बट एटलीस्ट इफ पीपल आर सीइंग, देन डॉक्टर मेडिको व्हाट वी विल डू, यू हैव द पियानो, I have the guitar, we'll get a singer. Dr. Jagdish sings also, you know, ENT. We'll catch him also. Okay, let's include Dr. Jagdish also in the team and have one person for drums. अब एक drums वाला ढूंढो, फिर एक बैंड बजाते, फिर पढ़ाई लिखाई छोड़ देते हम लोग. ठीक है, राइट डॉक्टर मेडिको फॉरएवर. ठीक है, हाँ लड़कों करेक्ट, गॉट इट. ठीक है, ओ ग्रेट. चलो लेट्स स्टार्ट विद पढ़ाई देना. डॉक्टर मेडिको फॉरएवर सेज ही डिड जैम इन कॉलेज. Sure. Dr. Deepdas, perfect. Definitely would like to meet all of you. Definitely, for sure. Now let's start with the studies so that अब पढ़ाई पे आ जाते हैं. और बीच में ब्रेक हो जाएगा तो फिर से गिटार एक ले लेंगे. ठीक है, we'll start again one session, 1 or 2 songs later on, but let's finish off our studies now. Okay, let's start with this session. Okay, all of you, I expect answers from all of you so that we can have the discussion this ways. Okay, so a patient, you know, हाँ, so डॉक्टर दीपांशु कालरा सेज डॉक्टर जगदीश की सीरीज आ रही है. हाँ हम लोग यही सब काम करते हैं यार. ऑल ऑफ अस, यू नो, वी डिड मेडिकल, so they don't realize the medicos are so behind everything that हमको कुछ बोल दो ना, चलो गिटार बजाओ, गिटार बजा देंगे. बिकॉज पढ़ाई का इतना आदत पड़ गया कि जो चीज में घुसते हैं हम लोग पूरा घुस जाते हैं. डॉक्टर जगदीश को देखो, एक्टिंग, ये गिटार, सिंगिंग. डॉक्टर जगदीश ऑल्सो कैन डू एवरीथिंग. ओके, राइट. सो लेट्स स्टार्ट. अ पेशेंट, डॉक्टर JNV BD सिंह, सर स्टार्ट नाउ. बात सही है यार, क्यों टाइम वेस्ट कर, शुरू करते हैं अभी. अ पेशेंट इज गिवन निकोटिनिक रिसेप्टर एंटागोनिस्ट एज मसल रिलैक्सेंट. Which drug is given post-operatively to recover from the muscle weakness? Important question. This has been asked in exam. I've twisted a little. Let's see whether you can give me the correct answer. A is carbachol, B is neostigmine, C is physostigmine, D is succinylcholine. Please give your answers. So Dr. Neelam says one answer, right? Some people have given, okay, so B, Dr. Deepdas has given the answer. Dr. Medico Forever has given the answer. Dr. JNV Beed is right, and Dr. Dipanshu, Dr. Yuvraj. Okay, so as I can see, most of you have given me the correct answer, but I was expecting you to get confused between two of them. Which is the second option, guys? Second option that I wanted, and I didn't want, where you could have got confused, was physostigmine, right? Physostigmine. So between neostigmine and physostigmine. So basically I'm talking of a reversal agent. So when I was discussing previously with you muscle relaxants that I was discussing with you over here. So when you have given drugs, not succinylcholine, when we were discussing, where is it called? Oh, वो तो रब करना पड़ा था मेरे को, ठीक है. So when we were discussing, guys, non-depolarizing muscle relaxants, when we were discussing about vecuronium, rocuronium, and all those drugs. So here we said that non-depolarizing, all you're doing is basically they are causing paralysis, and the reason for paralysis was because they were causing competitive inhibition, right? They were causing competitive inhibition of acetylcholine. So if you want to stop the paralysis, you want the contraction to start again. In that case, you want the acetylcholine to sit at the receptor, na? Because initially vecuronium was sitting, but now you want acetylcholine to sit at the receptor. So you want that vecuronium should be thrown away from the receptor. And for that, what do? You basically give neostigmine. What neostigmine does, guys, is that neostigmine basically prevents acetylcholine from getting metabolized or getting broken down into acetyl and choline and going back into synaptic vesicle. It increases the quantity of acetylcholine in the synaptic cleft. At one time, acetylcholine becomes more than vecuronium, and this is what is called reversal. Is it clear, everyone? So neostigmine, what it does, it prevents the destruction of acetylcholine, which is taken place by cholinesterase enzyme, right? So normally what would happen? Acetylcholine gets destroyed by cholinesterase enzyme and goes back to synaptic vesicle. I give neostigmine, it prevents this cholinesterase enzyme. So therefore, now acetylcholine is not getting destroyed and not going into synaptic vesicle. So therefore, acetylcholine lies in the synaptic cleft, right? Because acetylcholine is in the synaptic cleft, there is increase in the concentration of acetylcholine in the synaptic cleft. At one point, what happens? It becomes more than the non-depolarizing, and therefore non-depolarizing will then go away and acetylcholine can now sit at the receptor. Remember, it's a competitive block. And how did that take place? By giving neostigmine. So neostigmine, that's why is called as reversal agent, right? Because it increases acetylcholine. Clear? Reversal agent. It increases acetylcholine, which can then bind to the receptor. Remember, it's a competitive block. Thumbs up, everyone. Clear? Hopefully this point is clear, right? So the correct answer here is neostigmine. So what are reversal agents, guys? And remember, neostigmine basically is used for non-depolarizing muscle relaxants, not for succinylcholine. Okay, it is not used for depolarizing. All right, not used for succinylcholine. It is used for non-depolarizing muscle relaxants only, not for succinylcholine, right? And when we speak of these drugs, so these drugs that we are discussing are all called as anticholinesterases. Okay, so these are all reversal agents are called anticholinesterase. Anticholinesterase, guys, can be of two types. One is irreversible, malathion, palathion, OP poisoning, ecothiopate, forget that. Other is reversible. So that Dr. Ankit has covered, already taking care in Pharmac. Correct? The reversible ones are the ones which are called as edrophonium. They are neostigmine, there is pyridostigmine, and there is physostigmine. MCQ question. Out of this, which is not used for reversal? MCQ question. Reversal of muscle block. Okay, let me give you the options then. A, Hydrophonium, B. neostigmine, C. pyrostigmine, D. physostigmine. So, which of the following is not used for reversal? Yes, guys. Answer. Dr. Dipanshu has given one answer. Baki log? अरे important question है pharmac का. Based on this, it's based on one property of pharmac. Till now no one has given me correct answer, huh? All of you, who will give me the correct answer then? It's not the correct answer, guys. A is not the correct answer here. For reversal of muscle block, which is the one that cannot be used, guys? No guys, it's not A. It's not hydrophonium. Physostigmine is the answer. No, not because of that. See, physostigmine crosses the blood-brain barrier. This is important. D, right, Dr. Medico forever. Correct. Physostigmine crosses the blood-brain barrier. True. Hydrophonium is short-acting. I agree. Neostigmine is intermediate acting. I agree. Pyrostigmine is long-acting. I agree. But all these three can be used for reversal if you want. It's a different thing that we don't use hydrophonium, we don't use pyrostigmine. We use neostigmine just because it is intermediate acting. Okay. In fact, neostigmine is the most common used. But if given an option, I can use hydrophonium pyrostigmine, but I can't use physostigmine, and that is the reason, because physostigmine, guys, remember, it is important from even a pharmac point of view. This question has been asked. You people know it. It crosses the blood-brain barrier. That's the reason, right, Dr. Bharat? Absolutely correct. Okay, so that's the reason behind it. It crosses the blood-brain barrier and it should not be used for reversal. Clear? So this is the point which was important over here, and I thought initially you people would have got confused between these two, right? So that was the reason physostigmine is not used, because it crosses the blood-brain barrier. Anyway, succinylcholine is a muscle relaxant, out of question. Clear? So this, right, and neostigmine can't cross it. Clear? So this is about the reversal agent, all right, and this is about the neostigmine, what we discussed. Next question. This is last year's question only. The image given below shows neuromuscular monitoring of a patient during anesthesia. Which of the following is being used for this monitoring? Right? A, B, C or D? Which is the answer, guys? Okay, so Dr. Medico forever has given the one answer. Other people, I'll just wait for your answers and then we'll go forward, right? किसी ने A भी बोला, किसी ने Dr. Neelam has said ulnar nerve, Dr. Mohammad Umar has said D, Dr. Real Guy has said median nerve, Dr. Ajay Kumar says C, metacarpal, Dr. Bharat says train of 4, ulnar nerve, B. Right, I think most of you have given the correct answer, but guys, some of you had a point in giving an answer regarding median nerve and metacarpal. No, they are not the answers, guys. The correct answer is ulnar nerve. What you are doing is, guys, you are doing a neuromuscular monitoring. What is neuromuscular monitoring? I am monitoring the neuromuscular junction. Same, going back to the previous point when we were discussing where do the skeletal muscles act. These, can you see this? Muscle relaxants, where do they work? They cause muscle paralysis. They work at the neuromuscular junction at the nicotinic receptors. So if you want to basically monitor, you know, हर चीज में monitor आ गया है. We anesthesia people initially were working a lot. Initially we used to see the patients by putting hand on pulse. Then we used to see the BP by measuring with hand, right? And then after that we were just keeping a watch on the respiration, moving of the chest. Now we want to just relax. We have made monitors for everything. If the patient is not sleeping or in depth of anesthesia, we have depth of anesthesia monitor. We have advanced monitors, pulse oximeter, we are using capnography, so many different monitors. Similarly, we have made a monitor to monitor the neuromuscular block. This monitor is called neuromuscular junction monitor. It monitors if the block is there or not there. Basically, it will monitor if the receptors are occupied or not occupied. It's going to see that. Correct? So this is what is called neuromuscular monitor. Now the point is, most of the times the periphery part is available because surgery is taking place in the center of the body, abdomen, maybe heart, maybe chest, maybe back, maybe spine, maybe lung, hand, even legs. Hands में रहेगा तो एक हाथ free रहता है. So normally what happens, you are trying to see the most peripherally easily available part. Therefore, neuromuscular monitor, if I talk about, this is a neuromuscular monitor. This is last year's question. And neuromuscular monitor basically monitors the neuromuscular junction. It is monitoring the neuromuscular function, right? So basically the neuromuscular block is there or not there. So this basically, you will monitor one nerve and one muscle. The most common nerve, peripheral nerve, which is seen is the ulnar nerve, and the corresponding muscle to that is the adductor pollicis muscle. So in the diagram that you have seen here, so this is what is being monitored, ulnar nerve, and you are going to see the response in the adductor pollicis muscle. So I am going to give 4 stimuli from here, 1, 2, 3 and 4. This becomes train of 4. So train of 4 is the most common mode, and I'm going to see the response on the thumb, whether it is 1, 2, 3 or 4. If you get the same response, it means patient is not paralyzed. If the patient is not if the patient is paralyzed, you get no response. Okay, this is exactly what it tells you. और बीच में बता देता है whether it is a non-depolarizing or depolarizing. So this is basically ulnar nerve, adductor pollicis. By chance ulnar nerve is not available, hand surgery is going on, you can also use the facial nerve. Corresponding to that is the orbicularis oculi muscle, or even if the face is not available, you can use the leg. You can use the posterior tibial nerve, and corresponding to that is the flexor hallucis brevis muscle in the foot. So basically the most common mode which is used is train of 4, 1, 2, 3 and 4. You give 4 stimuli, right, in a span of 2 seconds, each of 2 hertz. All right. If the block is seen with non-depolarizing, you get to see something called as fade. Fade means first will be this much, second will be less, this will be less, this is more. This is what is called as fade. It is a hallmark of non-depolarizing. In case there is succinylcholine, you get same height, right? Less height, but all of them will be equal. So this is decreased amplitude, but same height. That is succinylcholine. But this is succinylcholine phase 1. If succinylcholine is in phase 2, you get to see the same fade. So this is what is important that you should be knowing. This is what is called as the mode, which is called as train of 4 mode. Train of 4 mode, right? Train of 4 mode. This is what is normal, right? You get this if it is non-depolarizing or succinylcholine phase 2 block, and this is succinylcholine phase 1 block. Clear everyone? So this is about the neuromuscular monitor. Don't have to go too much into details about it. Simple questions get asked from here, and this was even the last year's question. Kindly just identify which nerve is being monitored. The correct answer was ulnar nerve is being monitored. Clear everyone? Thumbs up. So I'll go forward to the next one. Next question. Everyone okay? Yes guys, everyone okay? Right, so going forward then, okay? It's good, huh? It's good. I've got a very good responsive set of people who are there. Plus, I will also say I did not have anyone who was trying to put things here and there. All serious people in the class, and all people responding well and paying attention. Really nice. It's really nice. Really wonderful. Okay. मतलब no one putting any wrong in the sense कि diversions कुछ नहीं था, कुछ wrong questions नहीं थे और spamming नहीं थी. Nice. So nice to take a class like this. Really. I'll go forward then. Dr. Medico Dr. Medico Forever का एक message आया. बाकी लोग, can I go forward? Yes. Okay. So the next question, we'll start from there. A 20-year-old young male patient was given brachial plexus block with 0.5% bupivacaine for open reduction and internal fixation of humerus, right? A block has been given to the patient. Shortly after the injection, the patient suddenly becomes unresponsive and the pulse was not recordable. Which among the following is the best course of management for this patient? Okay, so CPR with 20% intralipid, CPR with soda bicarb, with calcium, or with dopamine. This guy, guys, chalo. So waiting for your answers, and then I'll go forward. I mean, in the sense that we'll have the discussion based on that. Correct. I think we've already discussed बीच में ना Dr. JNV Beed ने भी आंसर पूछा था. He had asked about this point and I had given the answer there also. But all of you are right, absolutely correct, with 20% intralipid. This was also a recent question. I think this was 2020 question in the month, the later one which was used. This was asked then. नहीं, B आंसर नहीं है. Dr. Real Guy, B नहीं है. Correct answer is A. C भी नहीं है. No, C is not the right answer. Let's discuss Dr. Paban, I think. Dr. Paban Pramanik is what I can see, right? Dr. Prateet. The name is so good, yeah, but even I can't. That's my point, that I'm not getting it. But otherwise, such a good name you people have. Nice. So that's a nice name, right? 2021 का शायद क्वेश्चन था यार, इवन आई डोंट रिमेंबर यार, इतना मेरे को नहीं याद रहता है कि कौन से ईयर में पूछा था. बट दिस वाज अगेन, दीज आर ऑल क्वेश्चंस आई एम डिस्कसिंग बेसिकली 2019, 2020, 2021 and 2022 mostly, plus few questions that we have added from FMGE. So these are all the previous years questions recently asked is what we are discussing, guys. Okay, and in that case we are covering whole of anesthesia also. You'll realize we have covered all the parts of anesthesia without leaving anything. Okay, so the point is, I was discussing about this question. Most of you gave me the correct answer, intralipid. Soda bicarb is not correct, this and this is not correct. What is the question asked over here? You are giving a brachial plexus block to someone, right? You're using the local anesthesia drug, right, with bupivacaine. So when you speak of local anesthesia drugs, guys, you know, local anesthesia drugs based on the drug properties can be classified into three types. I'm not talking of chemical structure. Based on chemical structure, okay, let me discuss that also in short. Local anesthesia drugs based on structure are classified into two types, right? One is amino ester, other is amino amide. All you people would be knowing amide change and amino change, right? So you will have drugs like procaine as amino ester, right? Drugs like benzocaine as amino ester, tetracaine amino ester, drugs like lignocaine, amino amide, bupivacaine and mepivacaine. So all these amino esters are the ones which get metabolized in the plasma, and these are the drugs which get metabolized in the liver. INICET, this question has been asked. The point is, if these drugs get metabolized in liver, someone has a liver disorder, these drugs can't be used, and that is why these drugs are preferred for liver disorders. This was the point. Based on chemical structure, amino esters and amino amides. Clear? Now, second group of classification of the same local anesthesia drugs can be run into two types. Like one can be surface local anesthesia drugs, okay, surface local anesthesia drugs and injectable, right? So surface is again of two types. One is soluble, other is insoluble. Soluble and insoluble. So soluble, you will have drugs like lignocaine, benzocaine. Insoluble, you will have that oxazethozine and things like that, you know, that oral ulcer drugs, right? So I think lignocaine, benzocaine, oxythazine will come here. Oxythazine. We don't need to go into those details of that. So surface local anesthesia drugs and injectable. Injectable based on property is classified into three types. One are the short acting drugs. These short acting drugs. Other are intermediate acting drugs. And the third one is long acting drugs, right? Short acting drugs are also less potent and they are less toxic. Intermediate acting drugs are intermediate potent and intermediate toxicity. Long acting drugs are highly toxic. Guys, am I audible? Thumbs up all of you. Audible, visible. I was not getting your messages. बीच में कुछ problem आया था. Thumbs up all of you. Am I okay? Thumbs up anyone? Yes guys, thumbs up. I can see myself. Yeah, Dr. Mohammad Umar का मैसेज आ गया. Right. सबका आ गया. Dr. रुद्र चौहान का भी सबका आ गया. Right. Thank you guys. Actually हुआ था ना, it was in my mobile, it was showing retry, server is not connected. So I thought might as well ask you यार. वो पता नहीं चलता ना कभी कभी. ठीक है? Good. Thank you guys. Thank you everyone. Thank you. So anyways, coming back to the discussion we were talking, local anesthesia drugs, injectable, are classified into three types: short acting, intermediate acting and long acting. The short acting drugs are less toxic. These are drugs like procaine and chloroprocaine. MCQ question. Remember, chloroprocaine is the shortest acting local anesthesia drug. Intermediate toxicity, you will have drugs like lignocaine, mepivacaine, right? So lignocaine here is the most common. Highly toxic drugs, you have dibucaine. This is the longest acting local anesthesia drug. You have tetracaine, second longest acting, and you have bupivacaine. Point. All the local anesthesia drugs. Okay, I want to ask one more question. Okay, एक और करते हैं. Local anesthesia toxicity affects which organ system first? Okay, I'm making the question here itself. A, CVS, B, CNS, C, musculoskeletal, and fourth is all of the above. D, all of the above. Yes, guys, answer. Dr. Bharat has given one answer. Other people, A, B, C, D. Dr. Mohammad Omar has given one answer. Dr. Rose says CNS. Dr. Mohammad Omar says arrhythmia. Dr. Medico says whatever. Dr. Rudra says CVS. No, guys. Till now, only Dr. Rose has given me the correct answer. Right? Only Dr. Rose. No one else. Huh? Dr. Rose is the only one who has said CNS. Dr. Rose is the only one who has said CNS. Remember, local anesthesia drugs, when they work, where do they work? They work at the nerves, right? They are working at the nerve fibers. The local anesthesia drug is working at the nerve or the nerve fiber. So this drug, it's very easy to penetrate the blood-brain barrier. Therefore, the first effect that you see is in the CNS. Therefore, the first organ system that gets affected is the CNS. Thumbs up. Dr. Rose is right. The CNS, not the CVS. Everyone, thumbs up. Is this point okay? Okay, it is the CNS. It's not the CVS. So you will find that the CNS toxicity takes place before the CVS toxicity. In fact, the first thing that you would see in a patient is circumoral tongue numbness and all those things leading to tinnitus, ear symptoms, ophthalmic symptoms, ultimately patient landing up in convulsion, and CVS comes after that and the patient lands up in arrhythmia, right? So convulsions take place before arrhythmias. Convulsions can still be controlled, but once arrhythmias takes place, it cannot be controlled, and many times that can lead to death of the patient even with local anesthesia. This is what is called as local anesthesia systemic toxicity. Thumbs up, everyone. Clear? Clear? So this is local anesthesia systemic toxicity. What is the treatment now? You know, whenever toxicity takes place in the medical profession, kahin bhi, the basic treatment is what? ABC, CPR. ABC. You will do that. Maintain the airway. That's exactly why that question by Dr. JNV Beed was important over there. He had asked me, airway maintained, breathing maintained, circulation maintained, IV line, fluids, if needed CPR. Correct? All this becomes a part of local anesthesia systemic toxicity. He had asked me the same question, right? So ABC, CPR becomes the treatment. Apart from that, so you'll be giving 100% oxygen, chest compression, IV fluids, whatever you want to do. Absolutely all. But most important point nowadays they are saying is that this toxicity that takes place is not more commonly seen with lignocaine. Have you seen with lignocaine? No. Itni baar hota hai lignocaine, you people close your eyes and you can take sutures in the hospital, right? This toxicity normally takes place with bupivacaine, because bupivacaine is the most cardiotoxic local anesthesia drug, where your cardiac complications take place at the same time as CNS, which means if you have given bupivacaine to someone, in bupivacaine, rather than this taking place convulsions before arrhythmias, in case there's a toxicity with bupivacaine, what happens is that the convulsions, forget convulsions, the arrhythmias and the convulsions take place together. Suddenly the patient lands up in arrhythmia, and along with the arrhythmia you also get convulsion. Both the systems are together. It's the most cardiotoxic drug. So therefore the point is, the reason what has happened is it is local anesthesia toxicity. Of course I will do my ABC and CPR, but the most important thing here becomes is that somehow or the other a research has shown that you can use 20% intralipid in the patient. What is intralipid, guys? Intralipid is the same lipid which is used for total parenteral nutrition in the ICU that you people must have seen. Have you people seen a white bag in the ICU? The patients who are on ventilator, they get total parenteral nutrition, you must have seen, right? Lipids. It's a white color bag that you see. So that's why, because it's a white bag, a lot of people say it is propofol. Nahi yaar. Har white cheese propofol thodi hota. Any person who has a long hair is not a girl, na? Ye to wahi baat ho gaya. You find someone walking on the road and without seeing girl or boy, you see a long hair or a ladki hai. How do you know? Boys also can keep long hair, yeah? You can be mistaken. So just because TPN white bag, people say white color drug, propofol, and that is exactly why this question is set in the paper. Because everyone thinks it's that white color thing, so the correct answer would be propofol. It is not propofol. It is CPR to be taken care with 20% intralipid. It is also a white color bag which contains lipids. Okay? Correct? So this is what was used for. What happens is that this is supposed to be like a binding agent or a chelating agent. It binds those local anesthesia properties which is like bupivacaine, and it throws them away from the body. It's like a binding agent or chelating agent. So nowadays this is used during the CPR, and that's the correct answer for local anesthesia systemic toxicity. CPR with 20% intralipid is the correct answer. Thumbs up everyone, clear? Right, Dr. Bharat, absolutely correct. Okay. Any questions? Otherwise I'll go to the next question then. Okay, let's go to the next question. Right, a 20-year-old patient was undergoing strabismus surgery under GA. During the procedure, patient suddenly developed rise in temperature, rise in CO2 levels and muscle rigidity. Which of the following drugs is most likely implicated in this condition? So I'll wait for your answers and then we'll go forward, discuss about it. Yes, guys. Dr. Rose straight away tells me correct. Dr. Rose, you have got the correct diagnosis of the situation. Drug. Dr. Medico gives one answer. Anyone who disagrees with Dr. Medico forever? Dr. Amit says dexamethasone. B. Anyone else? I don't think anyone would want to disagree. I think most of you are right. So let's continue with the discussion. Absolutely correct. It is dexamethasone. And Dr. Bharat says dantrolene. Oh, hey, correct. Dantrolene is a drug of choice for what? So now, correct. All of you have given me the option. Chalo, let's make one more question then. Since you people are discussing, let's make one more question. Temperature, rise in CO2 and muscle rigidity. So all of us have understood that this condition that the patient is suffering is malignant hyperthermia. Okay, malignant hyperthermia. I am talking about malignant hyperthermia. अरे अब तो बहुत क्वेश्चन आ जाएगा. Guys, one more question. मेरे को एक और क्वेश्चन आए. 2 क्वेश्चन आए मेरे को. कर लूँ? 2 questions. I've got 2 questions. First, malignant hyperthermia is a disorder of which channel? A, B, C, D. Sodium, potassium, calcium, chloride. It's a disorder of which channel? I've got 2 questions, huh? मेरे दिमाग में एक जोक आया, but I'm not sharing. Okay, I'm on YouTube. You know, there was something I got 2, so I'm not sharing that. I can't. I'm on YouTube. right? So what is the answer? A, B, C or D? I think Dr. Real Guy has given an answer B. Dr. Bharat says ryanodine receptor, calcium is written, right? Which means answer C. Dr. Real Guy says A. Dr. Rose says C. Correct, guys. Now, malignant hyperthermia. Okay, it is a disorder of this thing, calcium, and that is okay. One more question based on this only, right? Let's change it. Local anesthesia acts majorly where? Which channel? Let's change it. So when we discussed malignant hyperthermia, guys, the correct answer was calcium. I have changed the question. Local anesthesia acts where? Options remain the same. Sodium, potassium, calcium, chloride. क्या करे यार? I'm on the other side of the table ना, so I get the options to change the questions. You know, it becomes easy when you are on the other side and giving the answers ना, तो उससे difficult होता है. But जब इधर आ जाओ ना टेबल पे, same thing changes. Same thing will happen with all of you also. Right? So local anesthesia acts majorly at which channel? Correct. So I think Dr. Anubhav, Dr. Rose, Dr. Mohammad Omar, Dr. Tahir have all given absolutely correct answers. Absolutely correct. It works at the sodium channels. But one more point. Remember, local anesthesia can work at sodium, potassium, calcium, chloride, anywhere, but the maximum effect takes place at the sodium channel. That's the point. Okay, don't think that so local anesthesia will not work at potassium, calcium or chloride. It can work at all the channels, but the maximum effect takes place at sodium. Anyways, coming back to malignant hyperthermia, we discussed it's a disorder of calcium channels. So, you know, can you see the questions coming? Now let's see, a patient of malignant hyperthermia has to be given general anesthesia. Now, for that thing, what is our drug of choice that we will prefer to use to this patient? Thiopentone, dantrolene should be used. Okay. Malignant hyperthermia patient coming for surgery. Let me give you 4 options: A, B, C and D. So we are using dantrolene for this patient. Am I using thiopentone? Am I using propofol? Or the best thing is to go for ketamine? Anyone? What's the correct answer? Next question. Malignant hyperthermia patient coming for local anesthesia. Dr. Bharat says dantrolene. So he gives an answer A. Anyone else? Dr. Medico Forever says dantrolene. Anyone else? Dr. Hamika says dantrolene. Caught you. I caught all of you. Trap? ये तो ट्रैप है. मैं ये आंसर पहले दे चुका हूं. Dr. Rose correct, absolutely correct. Propofol. When I was discussing propofol, I discussed with you malignant hyperthermia, porphyria, ICU sedation. I had mentioned this. I had mentioned that. So why the point is, I said malignant hyperthermia coming for GA, that is dantrolene. Let's discuss the malignant hyperthermia. इसका मतलब थोड़ा सा बेसिक में जाते हैं. Let's clear the basics of malignant hyperthermia. When you talk of malignant hyperthermia, guys, remember malignant hyperthermia is a genetic disorder, right? Malignant hyperthermia is a genetic disorder. Genetic disorder of what? Sarcoplasmic reticulum having that ryanodine receptor gene abnormality. And ryanodine receptor is basically calcium release channel, right? So if this is your ryanodine, this is the ryanodine receptor. So if this is sarcoplasmic reticulum, it's a disorder of what? Sarcoplasmic reticulum, right? It has a ryanodine receptor gene abnormality. So this is the ryanodine receptor, and the ryanodine receptor is a calcium release channel. So sarcoplasmic reticulum is present in all the muscles of the body. Now what happens is, so this is basically a genetic disorder, which means it's already there in the gene. The patient will be normal, walking, talking like all of us. When this patient comes for surgery, imagine this patient has genetic disorder and I expose this patient to anesthesia drugs. Which drugs? If I give halothane, if I give succinylcholine, or if I give lignocaine itself, right? So any of these drugs given to the patient, suddenly something goes wrong with the ryanodine receptor. वो पागल हो जाता है. The ryanodine receptor goes mad. So ryanodine receptor, what is, something is wrong with the ryanodine receptor. You know, once it gets anesthesia drug, अरे हम भी तो anesthetize हो जाते हैं. You take sevoflurane, you enjoy. You take halothane, sweet smelling drugs, we enjoy. So ryanodine receptor suddenly goes mad. It has no control over itself. Ryanodine receptor suddenly starts releasing calcium throughout the body, and this calcium release takes place in all the muscles of the body. पूरे body में, right from your head to your toe, imagine how many muscles are there. From all the muscles, all the calcium starts to get released. पूरा calcium निकल गया बाहर, तो क्या बचेगा अंदर? कुछ नहीं. The calcium moves till the time patient is dead. That's exactly what happens. Is there is increased metabolism taking place, there is increased carbon dioxide production, there is increased temperature taking place because muscles are involved. You start getting myoglobinuria, you can also get arrhythmia. These are all the signs and symptoms: raised CO2, more temperature, arrhythmias, and myoglobinuria, right? Because muscles are involved. What to do? Nothing. This patient will die on the OT table if you don't stop the calcium release. The only drug that stops calcium release is dantrolene sodium. So dantrolene sodium, guys, remember, is the treatment of this condition inside the OT. If the patient starts to have more carbon dioxide, more temperature, arrhythmias, and myoglobinuria, dantrolene becomes a treatment of that condition. But the patient has genetic disorder. He is coming for surgery. In that case, you will not use dantrolene, guys. Dantrolene the treatment hai. For surgery, if you have to use general anesthesia, in that case, our drug is going to be propofol. And if there is local anesthesia, I will be using procaine. This is malignant hyperthermia. Thumbs up, everyone, clear? Okay, no doubts now? So Dr. Medico Forever, clear? वो dantrolene sodium, I think you know whosoever यार जो भी आंसर दिया था, I'm sorry if I have taken wrong names, but my point is कि just remember, dantrolene sodium is used as a treatment of the condition. Dantrolene is a treatment, and the other things are used for giving anesthesia. So propofol is used to give anesthesia, procaine is used to give anesthesia, right? So here the correct answer is, if you have to give GA, it's not dantrolene. Dantrolene is used for treatment of malignant hyperthermia in the OT. Right? Propofol is used to give GA to this patient of malignant hyperthermia. Yeah? Don't worry. Guys, make mistakes here. Absolutely okay. Don't make mistakes in the exam. That's the whole point for the discussion, na? That is exactly what is revision. Don't you think your points are getting reinforced? You people have studied it. Most of you have given me the correct answer. But revision का मतलब ही यही है कि जो छोटा मोटा points का problem था वो यहाँ पे clear हो गया revision में. Am I right? All of you? That's exactly what is revision. It's not easy, na? You people have to study 19 subjects. It's not easy. It's not easy for anyone. All of us agree to that. It's not easy. But we just have to use tips and tricks, keep on revising again and again and score our marks. But you have to remember, everyone is sailing in the same boat. खाली तुम अकेले थोड़ी हो, सब भी तो उसी बोट में. Don't worry, all of us will sail through. Okay? Okay, so that clears malignant hyperthermia. That was an important question. I discussed all points about it. It's a very important point. Last 2-3 times they've been asking questions on that. So let's go to the next one. Okay, this is again last year's question. Same thing was asked in FMGE, and a similar question was asked in NEET PG also, right? So a 30-year-old patient presented with headache, vomiting and fever. अच्छा कोई क्वेश्चन, कोई डाउट्स तो नहीं यार किसी को, तो मैं आगे जा रहा हूँ. Is that okay, everyone? All of you, thumbs up, guys. I'll go forward. Okay. Hopefully. Chalo, ठीक है, let's go to the next one. So, what is the correct answer here? 30-year-old patient presented with headache, vomiting and fever. Meningitis was suspected. Which is the last structure you will pierce just before entering the lumbar cistern while performing lumbar puncture? Arachnoid matter, emerald membrane, dura matter, ligamentum flavum, or pia matter. Yeah. So this question, similar question, one was asked in FMGE. Another similar question was asked in NEET PG. This is last year, 2022. Okay, both. Just before lumbar puncture, which is the last layer? So Dr. Medico Forever gives that answer, one answer. Dr. Tau Patil has given one answer. Other people, बाकी लोग जल्दी जल्दी. Anyone else? Dr. Tahir Riyaz has given an answer. Dr. Tao Patil has given one answer. Dr. Muhammad Omar. Yes, guys. Chalo, I think most of you are right. With few things here and there, most of you are right. Okay. Dr. Real Guy has given C. नहीं यार, C वाले लोग गलत हो. That's what. C is not right in this place. यहाँ पे ना ligament flavum is not the correct answer. You are giving spinal. So for that you need to know the things properly. It's arachnoid membrane. A is the correct answer. Arachnoid. Okay. A is the correct answer. So when you are giving spinal epidural, guys, it's important to know where you're giving spinal or even epidural, guys. So you're giving the injections at the back of the patient. So they ask you what are the layers. First layer is going to be skin and next is going to be the subcutaneous tissue. This all of us know, right? If I'm giving spinal from the back, so the first layer you're going to get is the skin and then comes the subcutaneous tissue. Beyond that, what you will get? Beyond that, right? So beyond that, what you will get? So if I have to see this first layer that I get here is the skin. The yellowish color this you see is the subcutaneous fat. Okay, so this is the subcutaneous tissue. Skin, subcut. After that, you are getting a ligament which is covering up the spinous process of the patient, right? So this is what is called as the supraspinous ligament. Supraspinous ligament. Then you get a ligament in between the layers. This is called as interspine, in between that vertebra, spinous process. So it's called interspinous ligament. So these are ligaments. Then you get a ligament over here. This after that. This is what is called as ligamentum flavum, right? So skin and subcut over here. Then you got three ligaments: supraspinous, interspinous, and ligamentum flavum. See, so these three are together, sort of thing, right? So these three came together. The initial two parts were here. Skin and subcut is here. Supraspinous, interspinous, and ligamentum flavum are till here. As soon as you cross ligamentum flavum, guys, what is this? This area, what you can see is basically this. What you can see over here is what is the epidural. So therefore, after the ligamentum flavum, you straight away get the epidural. After the ligamentum flavum, straight away it's the epidural, right? Straight away, epidural. You have not reached the spinal yet. You've already reached the epidural. After the epidural, guys, you get one thin layer. This is what is called as dura. Dura से चिपका हुआ एक और layer, that is called arachnoid. Can you see? This is dura and this is arachnoid. So after the dura, you get arachnoid. Okay. So this is our dura. This is the dura. This is arachnoid. After the arachnoid, this is the CSF, right? And then you get the spinal cord. That is exactly why you will not give spinal anesthesia before L3. It is always given below L1, L2 because spinal cord finishes off at the lower border of L1 or upper border of L2 in adult. So when you give spinal anesthesia, it should always be below the level of L2, whether it's L3, L4, L4, L5. You can do that. This is the space for spinal so that we don't damage the spinal cord. However, epidural mein, you are not going inside the spinal cord. So hence epidural can be given anywhere. Spinal anesthesia is when you're giving it inside the CSF, right? When the drug goes inside the CSF, this is spinal anesthesia. Okay. And in spinal, therefore, you will find the layers. If you're seeing spinal anesthesia is the drug going after the arachnoid. So what are the layers that we have got? So the first layer that we started with was the skin. After the skin, we came to subcutaneous tissue, right? So skin, subcutaneous, supraspinous ligament, interspinous ligament, ligamentum flavum. As soon as you cross ligament flavum, you come to epidural space. Then you come to the dura, arachnoid, and then the CSF. The CSF is where you give the spinal anesthesia, and epidural is over here. Hence, it is called epidural outside the dura, and spinal is after the arachnoid. It's also called subarachnoid. So lumbar puncture, when you do, it's the same thing, na? Correct? Clear, everyone? Thumbs up. All of you clear? So these are the various layers which are there. The layers, right? All of you, may I go forward then? All of you? Yes. So Dr. Medico says yes. Dr. Mohammad Omar. Hopefully all of you have understood these points also. Remember, spinal is single shot and epidural is where you put a catheter. right? Spinal, you give a single shot drug to the patient, and this is what is called spinal anesthesia. Epidural is when you find the epidural space with a needle which is much more thicker. Spinal needle is thin, and from there we give. So spinal needle can be cutting or non-cutting, so it is called Quincke, Babcock, or Whitaker, or Sprott. So these are the pencil tip non-cutting needles. Quincke, Babcock is the cutting needle. So these are the spinal needles. When you talk of epidural needle, it has got 1 centimeter marking, and the name of the needle is what is called as a Tuohy needle. Tuohy. Tuohy needle is what is used for epidural, and from here we put a catheter inside the patient, right? So this is spinal and epidural, guys, right? Going forward, 60-year-old male patient with gasping breaths is brought to the emergency. Without delay, the patient was immediately intubated by the intern on duty. Which of the following is the best method to confirm correct endotracheal intubation? Okay, so give your answers and then we'll discuss this point out. Dr. Medico says, what happened if the spinal cord is injured? Arey, pura transaction of the cord, patient mar jayega. That's exactly why you're not supposed to do. You are right, it can happen. It can cut the spinal cord. Absolutely correct, Dr. Medico, forever. Okay, so I'm taking the next question, guys. 60-year-old male patient with gasping breaths brought to the emergency. Without delay, the patient was immediately intubated by intern on duty, right? Which of the following is the best method to confirm correct endotracheal intubation? So I think all of you are giving Dr. Rose, Dr. Real Guy, Dr. Medico Forever. Correct. End-tidal carbon dioxide concentration, or ETCO2. Capnography. Okay. Same thing. It is absolutely correct. Can chest rise be used? Yes, it is correct. Auscultation? Yes, it is correct. X-ray chest? Yes, it is correct. But this is supposed to be the best method. Okay. Because chest rise can sometimes be wrong. Auscultation may be difficult. X-ray you cannot understand. But remember, when you intubate someone, your tube has gone inside the lungs. Right? So lungs is the only place from where carbon dioxide can come out. You will, in case your tube has gone into the stomach, this is the stomach, and a tube has gone here, you will not get carbon dioxide coming from the stomach, na? Not possible. Carbon dioxide, अरे थोड़ा सा ही रहेगा ना. If you have swallowed also carbon dioxide, the little bit carbon dioxide will be there, but proper carbon dioxide is going to come out from the lungs. So therefore, if you have intubated someone correctly and your endotracheal tube is inside the lung, so therefore when the carbon dioxide is coming out from here, this can be seen, and hence that we say that ETCO2 or carbon dioxide or capnography, right, is supposed to be the best method for intubation. All of you are absolutely correct. All of you knew the answer, and this was again last year's question, right? How will you confirm intubation? So the point is end-tidal carbon dioxide or capnography is the best. Second thing, nowadays people say even better than this thing is fiber optic. Why fiber optic? A fiber optic is a small tube that can go from the endotracheal tube or the mouth, and it can actually see the vocal cords here, right? So if fiber optic is given, guys, so fiber optic basically is a direct visualization. So normally end-tidal carbon dioxide and fiber optic will not be given together. But if they are given, according to me, fiber optic should be correct, because fiber optic, forget about carbon dioxide coming out. That is correct, I'm not denying, but fiber optic is a small that tube, bronchoscopic tube, which can go from here. It can actually see the vocal cords, if you're there or not. Vocal cords, if you've gone from here or not. I mean, vocal cords are somewhere here, right here. So this one can see the vocal cords and know if you're placed correctly inside the trachea or not. So fiber optic is a better method for this. Okay, so but end-tidal carbon dioxide, capnography are anyways considered gold standard. Hence the people always call this as gold standard. Gold standard is ideally the best method, but nowadays fiber optic is also available. It's still supposed to be slightly better than that. Apart from that, chest rise, yes, if you give IPPV from here, positive pressure, chest rise will take place, right? That is correct. Auscultation, yes, even that is correct, right? Esophageal detector devices are all correct. All right, no gastric distension, cyanosis nahi hai, saturation normal hai. These are all indirect methods. X-ray chest, yes, even that will also show you the correct placement. So this is what is for intubation, the correct way to determine. This is a very important question asked. Thumbs up all of you. Is it clear? ठीक है, simple question. So these are all simple questions. Now we've come to intubation. So we are just discussing that. So this is the endotracheal tube. A question has been asked many a times. This part of the endotracheal tube is called bevel, and here is a small hole that is called Murphy's eye. Remember, Murphy's eye is a part of endotracheal tube. It is not ophthal. Murphy's eye has been an additional port given for ventilation. This question has been asked, Murphy's eye. Right, according to me, fiber optic should be better, but you never know who has set the paper. But according to me, fiber optic should be better if both are given. But till date, no one has given you capnography on fiber optic together or carbon dioxide and fiber optic together. Till date, no one has asked. Till date. Okay, Dr. Medico forever. So, here we discuss the Murphy's eye point also, and let's go forward. Next question. Right, since we were discussing capnography, let's finish off this more thing. Adjoining image of the capnography monitor is of a 30-year-old intubated patient on controlled ventilation. Which of the following is most likely responsible for the image depicted? Yes, guys? Right, so I'm just waiting for your answers, guys. Don't worry, I'll take about half an hour more, then I'll finish off. Just half an hour. By 10:30 we should be done. So our revision of anesthesia will be done by then. So Dr. Medico forever says spontaneous respiratory efforts. Dr. Neelam says B. Dr. Rose says D. And Dr. Medico forever says chloric left. Dr. Mukesh Singh. अरे मुकेश, डॉक्टर मुकेश सिंह, आई वुड लव टू कॉल यू डॉक्टर, लेकिन 7th स्टैंडर्ड में एनेस्थीसिया कैसे समझेगा? इट इज गुड टू सी 7th स्टूडेंट, 7th में तो बहुत छोटे हो यार तुम. आई वेल यू अंडरस्टैंड, इट इज सो गुड दैट यू आर सिटिंग ओवर हियर. आई एम डिस्कसिंग एनेस्थीसिया बेटा, आई एम डिस्कसिंग एनेस्थीसिया. इफ यू आर अंडरस्टैंडिंग, वेरी गुड. ठीक है, बैठने में क्या, यूट्यूब पे इंस्टेड ऑफ सीइंग आगे पीछे का तुम ये भी देख सकते हो, उसमें क्या गलत है? But how sweet, yeah. We have a 7th class student amongst us. How sweet. We will call you Dr. Mukesh. यहाँ पे सब डॉक्टर लोग हैं. Nice to see, यार. Nice to see. So sweet. 7th standard वाले को एनेस्थीसिया मिल गया. हाँ, एनेस्थीसिया वाला बेचारा देख रहा है 7th standard का. How sweet. Okay. तो हम लोग कहाँ पे डिस्कस, व्हाट वर वी डिस्कसिंग? हम डिस्कस कर रहे थे chloric left A, chloric notch. So yes, Dr. Neelam and all of you. हाँ यार, ड्रीम, yes डॉक्टर मुकेश. अरे मैं अब उसमें अब उनको डॉक्टर मुकेश ही बोला जाए. लेट्स कॉल द स्टूडेंट डॉक्टर मुकेश ओनली. ठीक है, डॉक्टर मुकेश, वी वांट यू टू बिकम डॉक्टर मुकेश, राइट? गिव योर 10th. बट एनीवेज, इसमें से आई डोंट नो हाउ मच यू विल अंडरस्टैंड, बट एनीवेज लेट्स गो फॉरवर्ड एंड डिस्कस द सीरियस डिस्कशन दैट वी आर डूइंग विद ऑल द डॉक्टर्स हियर हु आर प्रिपेयरिंग फॉर देयर एंट्रेंस एग्जाम फॉर देयर MD सीट, राइट? ठीक है, चलो. तो यहाँ पे आई थिंक डॉक्टर रोज, आई थिंक टिल नाउ ऑल द आंसर्स यू गेव वर करेक्ट. ठीक है, अभी तक ऑल ऑफ देम. दिस इज द ओनली प्लेस आई थिंक डॉक्टर रोज मेड स्लाइट मिस्टेक. आई थिंक मोस्ट ऑफ द पीपल हियर हैव गिवन आंसर्स व्हिच आर करेक्ट, एंड यू नो आगे पीछे दोनों. करेक्ट आंसर हियर इज डी. स्पॉन्डी डॉक्टर रोज ने भी करेक्ट दिया शायद. डॉक्टर रोज ने क्या दिया था? ओ सॉरी, आई वाज टॉकिंग समवन एल्स, कोई और ने बोला था. सॉरी डॉक्टर रोज, माय फॉल्ट. मैं किसी और का नाम देख रहा था. someone else who I was discussing was supposed to be given. हाँ, the real guy. So A is not the answer, Dr. Real guy. So the correct answer here is spontaneous respiratory effort. We are talking of capnography. What is capnography? So imagine ये कोई patient है. अब हम लोग क्या लेते हैं? We take oxygen inside, carbon dioxide comes outside. So when carbon dioxide comes outside and I keep a instrument here to detect कि carbon dioxide detect हो रहा है कि नहीं. ठीक है, so whenever carbon dioxide comes out, you get a graph like this, and after that, of course, if carbon dioxide has come out, oxygen will go inside. So when oxygen goes inside, then this will not detect carbon dioxide, so you get a graph like this. उसके बाद carbon dioxide फिर बाहर आ गया. ठीक है, carbon dioxide फिर बाहर आ गया. Then carbon dioxide comes out, you get a graph like this. Then you get a graph like this, oxygen going in. So CO2 coming out, oxygen going in, and this is what is called your capnography का graph. कैप्नोग्राफी का मतलब होता है दिस शोज एक्सपिरेशन, this is showing carbon dioxide, that means carbon dioxide is coming out, and that is exactly if you have put an endotracheal tube and continuously carbon dioxide is coming out, it means your endotracheal tube is inside the lungs, right? And that is why it is considered as the best method to identify intubation, right? That's why it's considered as the best method. Okay, that is why. Now imagine if the graph goes like this. So remember, here we are saying whenever the graph is going down, can you see this is oxygen? Graph is going down, it means oxygen, right? It means patient is inspiring. So imagine this was the graph, what you see in front of you is for IPPV or controlled ventilation. If someone else is giving a breath, this is the graph that you get. Now, someone was breathing, suddenly he took a breath. Someone was breathing and suddenly he took a breath. Can you see this now? This is what happens. So someone was breathing, carbon dioxide coming out, suddenly took a breath. Someone was breathing, suddenly took a breath. Someone was breathing and now it becomes spontaneous breathing. So this basically tells you that patient is coming out of the muscle relaxant effect. It means the spontaneous breathing effort has started, means वो खुद से सांस ले रहा है, and it is going towards the spontaneous breathing part. So this is what is exactly called as the curare notch. All of you have mentioned it correctly also, right? So this curare notch, as Dr. Neelam and I think Dr. Medico Forever and I think Dr. Rose, I think all of you have mentioned that. Okay, so this is what is called as curare notch. So curare notch means the patient is trying to breathe, is out of muscle relaxant effect. This is spontaneous breath. So this what you see over here is spontaneous respiratory effort. It is going down. Patient with inspiration with cardiac oscillations, what will that show? Cardiac oscillation means something like this, and in inspiration, so that graph will become like this, something like this. That cardiac oscillations during inspiration will become like this. Is it clear? This will be that graph. Inspiration with cardiac oscillations, inspiration with cardiac oscillations, you get a graph like this. Bronchospasm, the graph is not coming out correctly, means bronchospasm ho gaya hai. What is bronchospasm then? CO2 not coming out. This carbon dioxide is not coming out properly. So what will happen? You start to get something like this. It was supposed to come like this, लेकिन रुक रुक के आ रहा है. This is what is seen in bronchospasm. This is called shark fin appearance. This is seen in bronchospasm or obstructions, right? And the last one is esophageal intubation. So if you have put your tube not in the lungs, it's got inside the stomach, will you get carbon dioxide? No. What will you get? Flat line. No carbon dioxide. So that is esophageal intubation. No carbon dioxide coming out. So this was bronchospasm. This is esophageal intubation. What was given to us is spontaneously effort, patient trying to breathe out, and cardiac oscillations during inspiration means it is coming over here. Okay? Correct, Dr. Medico Forever. In children is where you get correct. Because that is what it picks up. The oscillations are picked up. Dr. Neelam says flat. Correct. I think capnography is also clear for all of you. Okay. I think good one. All of you, mostly all of you have given me correct answers. Okay. बेटा स्पॉन्टेनियस का मतलब होता है लोग खुद से सांस ले रहे हैं. आईपीपीवी का मतलब होता है कोई दूसरा सांस दे रहा है. ठीक है, तो आईपीपीवी का मतलब होता है कोई दूसरा सांस दे रहा है. डॉक्टर मुकेश इज ऑल्सो आस्किंग अस अ क्वेश्चन. 7th standard. We are privileged यार. 7th standard person listening to anesthesia and still trying to understand anesthesia that to capnography. Good. But I don't know how much it will be helpful for your studies, हाँ मुकेश बेटा, आपको बाकी सब सब्जेक्ट से ज्यादा ध्यान देना पड़ेगा अभी. ये तो एनेस्थीसिया हम डिस्कस कर रहे हैं, बेहोशी. ऑलराइट एवरीवन. अच्छा, एनी क्वेश्चंस और डाउट्स पीपल टिल नाउ? सो आई विल गो फॉरवर्ड. ठीक है, तो स्पॉन्टेनियस एफर्ट का मतलब होता है जो खुद से सांस ले रहा है. यहाँ पे पेशेंट खुद से सांस लेने लगा. पहले हमने सांस बंद कर रखा था, वो खुद से सांस ले रहा है. Okay, so I'm trying to explain him also here since he's sitting over there. Let him also understand little bit of anesthesia. Spontaneous का मतलब होता है जब कोई खुद से सांस ले रहा है. Okay, identify the device. There are 4 options given to you. This question also has been asked in the exam. Give me the answer and then we'll go forward. एक बार सब खत्म कर लेंगे फिर गिटार बजाएंगे. ठीक है, ओके, गिटार बाद में. एक बार खत्म कर लें थोड़ा सा. 3-4 क्वेश्चन और बाकी हैं. आई थिंक 3-4 क्वेश्चंस मोर एंड देन वी आर डन. So Dr. Sukubai says LMA, Dr. Medicophora says Proceed, Dr. Neelam says A, Dr. Lives 2 says C, Dr. Agrajoti says A, LMA, Dr. Rose says D, Classic, Dr. Sukubai says Classic. Classic LMA? नहीं, ये क्लासिक LMA नहीं है. दिस इज नॉट क्लासिक LMA. डॉक्टर आई थिंक ओनली किसने करेक्ट दिया आंसर? डॉक्टर मेडिको फॉरएवर ने दिया. डॉक्टर मेडिको फॉरएवर ने दिया. डॉक्टर गुरीश पाटिल से सी. नहीं भाई, सी नहीं आंसर. प्रोसील. प्रोसील इज द करेक्ट आंसर. व्हाई प्रोसील? देखो, laryngeal mask airway is something which is put inside the, instead of intubation, rather than putting endotracheal tube, what I can do is, so if this is endotracheal tube and many times I don't want to go through the vocal cord, अरे अंदर क्यों डाल रहे हैं vocal? Imagine किसी के ट्रेकिया में बड़ा सा ट्यूब डाल दो, करता रहेगा पूरे टाइम. So many times you feel it's better to use LMA. What is laryngeal mask airway? It goes from, it's a tube like this which will come and that end will stay here. Right, so it is not going inside the trachea, it is not going inside the esophagus. So this is what is called as the laryngeal mask airway, the tip of which lies at the edge of the esophagus. So this is the laryngeal mask airway. यहाँ पे, ठीक है, ऐसे होता है laryngeal mask airway. यहाँ पे आता है, इसको यहाँ पे रख देते हैं. So that is how the shape is made, laryngeal mask airway. Now the normal laryngeal mask airway which is there, so this is the normal one. I'll tell you the differences also. This is what is seen as the classic LMA. Classic laryngeal mask airway. You see there is a tube from which oxygen can go inside. यहाँ से carbon dioxide बाहर आ जाएगा. Correct. This is the seal which lies at the larynx. That is exactly why it is called laryngeal mask airway. Correct. Problem क्या है? Laryngeal mask airway में I can't give IPPV. Laryngeal mask airway में I can't put IPPV. कहाँ गया? ये है laryngeal mask airway. In this I can't put IPPV. If I put the laryngeal mask airway, I can't give IPPV from here to the patient. Okay, because if you give IPPV to the patient, which I have done from endotracheal tube, laryngeal mask airway तो यहाँ पे था, somewhere here. So the breath will go here and some will go here. This will cause abdominal distension, regurgitation and aspiration. I don't want that to take place. That's exactly why people made Proceal LMA. What you see in front of you is not that normal classic LMA. So till here you can see this is a classic LMA. Till here, like this. This much is classic LMA. But you see, apart from that, they've added a drain tube also. यहाँ पे ये drain tube is to put a Ryle's tube from here inside the stomach. ताकि स्टमक में कुछ खाना रहेगा, कुछ भी रहेगा, that stomach thing can be aspirated from here. You can aspirate, right? It can get aspirated from here. Okay, that can get aspirated. Now यहाँ पे दिख रहा है hole है, because you put a Ryle's tube from here which goes inside the stomach. So now you see, if I'm giving oxygen or IPPV from here, वो यहाँ से गया patient के lungs में, कार्बन डाइऑक्साइड यहाँ से बाहर निकल गया, and if I'm putting the Ryle's tube, it is going from here inside the stomach of the patient. So therefore, this device, I can give positive pressure ventilation to the patient, IPPV. Okay. Dr. Sukubai says you get confused. I'm trying to make it easy, na? That's exactly why I asked you, right? That's exactly why I asked you this question. So this what you see in front of you is classic LMA, right? And this is called Proceal because it has double seal. One seal is over here and second seal is at the back. Hence it is called Proceal. Proceal का मतलब होता है better seal. लेकिन you will realize कि classic LMA में and Proceal LMA में, this is Proceal, the second one, right? इन दोनों में क्या है? Can you see cuff? I have to inflate the cuff. We are so lazy. We don't want to do anything. So people made another one, and this is now called, as all of you are saying, correct. Okay, and this is what is called iGel. This is what is called iGel, right? Now Proceal, guys, because it is used for IPPV, is called second generation LMA. This is first generation. This is second generation. When I speak of iGel, this also becomes a second generation LMA. क्यों? यहाँ से ऑक्सीजन अंदर जा रहा है, कार्बन डाइऑक्साइड बाहर आ रहा है, and from here they've given you drain tube from where it can go inside the stomach. ठीक है, यहाँ से एस्पिरेट हो जाएगा. नहीं, LMA सुप्रीम नहीं है. This is iGel. Okay, दिस इज आई जेल गाइस. सो दिस इज आई जेल. इंपॉर्टेंट पॉइंट क्या होता है आई जेल में? यहाँ पे देर इज कफ and you'll realize in eye gel there is no cuff. Can you see? We have become so lazy, we don't want to inflate the cuff also. Proceal और classic LMA का cuff भी inflate नहीं करना चाहते. We just use eye gel, put in the mouth and you are in the right place. This is very important because it can be used for CPR. In fact, nowadays I'm using this for the OT also, but for CPR and emergency, eye gel is so important that anyone can open the mouth and put it inside the patient's airway to take care of the breath. Okay, so this is what is called eye gel. And the last is, everyone knows, this is called the mouthpiece or the oropharyngeal airway. It prevents the backfall of tongue on the posterior pharyngeal wall. It prevents the backfall of tongue on the posterior pharyngeal wall. So you have got oropharyngeal airway, similar to that is nasopharyngeal airway. So these are the airway devices. Okay, clear? Okay, common question, simple question, but INICET question. Okay, such questions come from INICET also. A patient of road traffic accidents is brought to the casualty. Immediately a green colored IV cannula was taken in this patient to give IV fluids and to resuscitate. What is the gauge of the cannula? Eye gel be used in pediatric? Yes, Dr. Sukubai. Correct. We can use eye gel in pediatric also. Different sizes are there. So if you talk of LMA, let me clear that point. LMA comes in different sizes. 1, 1.5, 1, 1.5, 2, 2.5, 3, 4, 5 and 6. Eye gel comes in 5 sizes. Size 1, size 2, size 3, size 4 and size 5. So everything has different sizes. Next question was here. Okay, so let me see the answers for this now. Dr. Sukubai has given one answer. Dr. Medico Forever says 18. Dr. Neelam, Dr. Rose says B. Okay, all of you have worked in casualty. All of you have worked, all our interns and post interns. All of you know, and you've done it 1,000 times. You take the green color IV cannula. It is 18 gauge. Green is 18 gauge. Remember, the most common use is 20 gauge. It is pink in color, right? This is the blue color which is used in pediatric patients and children. Okay, ये pediatrics में use करते हैं. 18 and 16, these are which are used for giving the blood or used for resuscitation because these are fat. मोटे होते हैं सब. ठीक है? 16 is gray. So these are the various numbers. Orange is 14. Right, gray is 16, green is 18, 20 is pink, right, 22 is blue and yellow is 24. So out of that, orange we don't expect them to ask, not even yellow. Gray question mark है, but green, blue and pink ये तीनों याद रखना चाहिए. This is the most common. Remember, the flow rate is 54, right? Green में flow rate is around 80 और इसका flow rate is around 30. So these are important points. So these three are important. If you forget the other three, I'm still okay with that. But this 22 gauge, this 20 gauge and this 18 gauge, you should not forget. The color green, pink and blue, and the flow rate is 80, 54 and 33. These you should remember. Okay. Dr. Neelam says white is 17. Yes. पर मैंने white कभी देखा नहीं है. You are right. I have never seen in India. बाहर होता होगा, but India में मैंने कभी नहीं देखा है. मतलब बॉम्बे, दिल्ली कहीं भी I have not seen that. Okay, Dr. Neelam. Let's take the next question. So almost towards the end, I'll take 1 or 2 more questions. And then we'll be done for the revision of anesthesia. If you've seen, we have covered whole of anesthesia, all the important points and topics, previous year's questions. If there are doubts, you can ask me in between also. Otherwise, last में पूछ सकते हो. In the adjoining image, right? This image is indicating which maneuver in the patient. Ah, Dr. Medico, 24 is for yellow. Son who will work for 24 hours, correct. Dr. Sukubai says, नहीं ऑप्शन देख के बोलो ना. A, B, C की D. एक बार एग्जाम में ये ऑप्शन भी दिया था. I'll tell you what. This was given as one of the options. Neck, bend, spine, twist. Imagine this was given in the exam. Neck bend, spine twist. ये भी एग्जाम में दिया हुआ ऑप्शन है. How in the world can someone write this as option? Neck bend and spine twist. Neck bend and spine twist. Okay, ऐसा भी ऑप्शन एग्जाम्स में आता है. So when you sit in the exams, don't try to laugh over it. it means that you're supposed to ignore that option. Okay. Okay, so यहाँ पे correct answer, I think most of you have given me the correct answer. This is head tilt chin lift what you're doing, right? This maneuver being done here is head tilt chin lift. The next question comes, where is head tilt chin lift contraindicated? Where will you not do it? हाँ डॉक्टर मसूद सिद्दीकी करेक्ट, मजा लेने के लिए. नेक बेंड स्पाइन ट्विस्ट ऐसा भी लिखा होता है, नेक बेंड स्पाइन ट्विस्ट. नाउ टेल मी, हेड टिल्ट चिन लिफ्ट इज कॉन्ट्राइंडिकेटेड वेयर? किस पेशेंट में ये मैनूवर नहीं करना है? वेयर यू विल नॉट डू दिस? सच क्वेश्चंस आर वेरी इंपॉर्टेंट. सीपीआर एंड इमरजेंसी पे क्वेश्चन तो आता ही है घूम फिर के. राइट, दे डू. चलो, सो हेड टिल्ट. सर यू आर ओपी मतलब मेरे को नहीं समझा डॉक्टर दीपदास, आई एम सॉरी यार, मैं पूरा पुराना जनरेशन का हूं. ओपी नहीं समझा. राइट, वेरी नाइस डॉक्टर मसूद सिद्दीकी एंड डॉक्टर रोज. करेक्ट आंसर, सर्वाइकल स्पाइन. This question has been asked in exam. This maneuver can be asked in the exam. Where is this maneuver contraindicated? And they'll give you 4 options. They can give you a patient of paraplegia. They can give a patient of aneurysm. They can give pregnancy, and they will give cervical spine. Do you understand how questions come in the exam? They will give you the same image and they will ask you कि where is this maneuver being done contraindicated? कहाँ नहीं करना है? They will give you 4 options. Is it not to be done in paraplegia? Not to be done in pregnancy? In aneurysm, or maybe in cervical spine injury? So correct answer is cervical spine injury में you're not supposed to do this. Okay. अच्छा डॉक्टर मसूद, thank you for saying what is OP. All right, ठीक है. So this is how questions come in the exam. So all of you gave me the correct answer. Head tilt chin lift should not be done in cervical spine. लेकिन अगर कोई ट्रॉमा में आता है तो उसको cervical spine injury suspected तो रहता ही है. What will you do there? That is where you will do the jaw thrust. That is why it is called a triple maneuver, and that is why jaw thrust came. The whole concept was head tilt and chin lift. It takes the tongue away from the posterior pharyngeal wall. So normally क्या होता है when someone collapses, if this is the trachea, this is the esophagus. So normally what will happen when someone has collapsed, the tongue falls back at the posterior pharyngeal wall. So can you see oxygen is not going inside, carbon dioxide is not coming outside. So when you do head tilt chin lift, what happens is the tongue which is attached here, it goes away from the posterior pharyngeal wall, and now if you give a breath, it can go inside the patient. Is it clear? So this is why head tilt chin lift becomes such an important part. And when you do CPR, हाँ मुकेश बेटा, गुड नाइट. इतना सुन लिया वो बहुत है, अब जाके सो जाओ, कल स्कूल रहेगा. गुड नाइट, टेक केयर एंड ऑल द बेस्ट. ठीक है. Be a good doctor. See, the small child was there with us. He listened for us for so much time. 10-15 minutes उसने anesthesia सुना. अब सोने को उसको भेज दिया हम लोगों ने. यार डॉक्टर्स रात को पढ़ते हैं ना, we can't help it. डॉक्टर्स शाम को रात को पढ़ते रहते हैं. गुड नाइट. All right, so let's चलो ठीक है. गुड यार, you people saying all the comments यार made my day. मेरे को सच्ची बहुत अच्छा लगा. Really nice, wonderful class, wonderful people, really liked teaching. मेरे को अभी तक भूख कहाँ लगी यार, मैं आराम से बैठ के तभी तो बैठा हूँ. Really enjoying. You know ना, एनेस्थीसिया पीपल ऐसे ही तो होता है. सिवोफ्लोरिन लेके आया है, उसके बाद तो आदमी फ्रेश ही रहता है. नींद तो शाम को आती है घर पे आने के बाद, उसके बाद यू आर फ्रेश. यू हैव टेकन सिवोफ्लोरिन, राइट? Now we were discussing about what and how is what is done in CPR, right? So in CPR now the point is you don't do A, B and C. It has been changed to C, A and B. The first point is to do a chest compression, and then you take care of the airway, and then you need to give a breath to the patient. This is what is done nowadays. अरे सही, उधर शायरी भी आ रही है साथ में पढ़ते पढ़ते डॉक्टर मेडिको फॉरएवर की. हाँ ग्रेट, शायरी भी आ जा रहा है. व्हाट टू डू नेक्सस इज एवरी टाइम एक्स. नेक्सस, डॉक्टर सुकू भाई मेरे को नेक्सस नहीं समझ में आया. हाँ डॉक्टर दीपदास, थैंक यू फॉर दैट पॉइंट ऑल्सो यार. डॉक्टर दीपदास, आई गॉट योर पॉइंट, मैसेज. थैंक यू यार, थैंक यू. और तुम लोग इतना फास्ट मैसेज लिखोगे ना तो मेरे को देखने में और पढ़ाने में दोनों में थोड़ा सा दिक्कत हो जाता है ना। डॉक्टर ईशांत सांगवान सेज आई एम नीट एस्पिरेंट। अरे डॉक्टर निशांत यूजी के कि पीजी के? अरे हम बेहोशी की बात कर रहे हैं डॉक्टर ईशान। आई डोंट नो यू अंडरस्टैंड और नॉट। अरे वी हैव गॉट सो मेनी पीपल कमिंग फ्रॉम यूजी आल्सो, बट ठीक है। नेक्सस क्राइटेरिया, अच्छा ठीक है डॉक्टर सुको भाई, फ्रैंकली स्पीकिंग नेक्सस क्राइटेरिया इज समथिंग विच इज नॉट आई एम वेरी मच अवेयर ऑफ, और पूरा मेरे को ठीक से नहीं पता है, तो लेट मी वो हाँ सर्वाइकल स्पाइन फ्रैक्चर का होता है, दैट इज व्हाट ऑर्थो पीपल विल टीच यू मच बेटर यार। व्हाई यू वांट टू लिसन टू द रॉन्ग थिंग्स फ्रॉम मी? दे विल टीच यू ऑल द बेस्ट, आई मीन सॉरी, दे आर द वंस हु विल टीच यू द बेस्ट, आई एम सेइंग, ठीक है। तो फॉर मी लेट मी जस्ट पुट इट दिस वे, when a patient comes, so nexus criteria से पूरा ortho वाला points है, according to me when the patient comes to the emergency, any patient who is supposed to be coming from an injury is said to be a suspected cervical spine injury unless and until proved otherwise. Therefore you are always supposed to do a inline manual stabilization and not try to move the neck of the patient. Now this patient is not breathing, what will you do? तो बेसिकली इसमें since you are not supposed to move the neck of this patient, head tilt and chin lift is to be avoided. The only thing which can be done in this patient is jaw thrust, by which you will try to move. But however, the inline stabilization is maintained, and that is exactly why they say many times we want to intubate the patient. Many times in cervical spine we don't do laryngoscopy intubation, we straight away do a tracheostomy if needed. Tracheostomy is done. Okay, that is my point of view. Okay. Arey Ankit sir, thank you for being around, Dr. Ankit. Thank you so much. Right? You know that's what everyone. सब साथ में आते हैं तो ऐसे ही चलता रहता है यार. Thank you, Dr. Ankit. Good to see. Thank you. Right. So, anyways, as we were discussing going forward from here, our point was to discuss the CPR. So, I'm not going with the straight away, what you call with the ATLS part of it. Let me just discuss the basic life support, you know, BLS. Let's not talk about the ATLS, you know, which becomes specialized. I'm not talking of ACLS, which becomes stabilized, specialized. Patient अपने पास आता है. If a patient has come to us, you are the person and the doctor in casualty. What will you do first? The first thing to do is that scene safety. Scene safety का मतलब है casualty में you are safe. But if you are there in the road and someone has collapsed, फिर क्या करोगे? वहां पे रोड पे थोड़ी CPR करोगे, पेशेंट को साइड में लाना पड़ेगा. सीन सेफ्टी इज द फर्स्ट थिंग. आफ्टर द सीन सेफ्टी यू चेक रेस्पॉन्स. अगर पेशेंट रिस्पॉन्ड कर रहा है तो फिर छोड़ दो यार, उसको टाटा बाय बाय बोल दो. जबरदस्ती थोड़ी बोला कि मैं CPR करने वाला हूं तुम्हारा. तो सीन सेफ्टी, चेक रेस्पॉन्स, एंड द थर्ड थिंग इज कॉल फॉर हेल्प इमीडिएटली, because two people is always better than one person trying to save a person. Remember, so scene safety का मतलब है both of the people should be safe, the victim as well as the rescuer. So these are first 3 points: scene safety, check response, call for help. After that you check for the breath and then you check for the pulse. और अगर breath और pulse present है तो छोड़ दो पेशेंट को, क्यों डिस्टर्ब कर रहे हो उसको? Don't disturb, right? But if there is no breath and there is no pulse, this how you check the breath? Look for the visible chest rise, and pulse is checked is carotid, right? Once breath and pulse are absent, this is where you start your CPR. And nowadays CPR is CAB, chest compression, airway and breathing. Chest compression is given at the lower 1/3 of the sternum. Exam question, it is given 100 to 120 breaths per minute. Sorry, 100 to 120 per minute is the chest compression times. Okay, so this is again exam question. And the depth, so this is rate of chest compression. When you speak of depth, it is 2 inches or 5 centimeter to 2.4 inches or 6 centimeter. Practically कैसे समझेगा? Remember this 1/3? So it's supposed to be 1/3 the depth of the chest. ठीक है? So this is the site of chest compression. That is C. After chest compression, you then have to open the airway, because normally अगर कोई collapse करता है तो tongue पीछे गिर जाता है, tongue falls back. So oxygen is not going in, carbon dioxide is not coming out. So what you do is basically you have to give breath to the patient. अरे but before giving the breath, at least airway should be open ना. अगर tongue पीछे गिरा रहेगा and you start giving your breath, तो breath जाएगा किधर? That is exactly why airway comes next. So after the chest compression, the next point is airway. Airway का मतलब होता है open the airway or remove any obstruction. How to remove the obstruction? अगर कोई vomitus है, foreign body है तो निकाल दो. अगर vomitus foreign body नहीं है, तो for airway the maneuver is head tilt chin lift. That is the point, because when someone collapses, basically it is the tongue which has fallen down. So you are supposed to do the maneuver which is called head tilt chin lift. Along with that, jaw thrust. Okay, that can be done. So these are the maneuvers to open the airway. Okay, so open the airway and obstruction will be there. So in case you want to relieve the obstruction, you'll take out the vomiters, any foreign body, and then head tilt chin lift, and then in cervical spine jaw thrust can be done. These are the airway opening maneuvers. Once the airway is opened, then you give the breath to the patient, right? And the breath can be mouth to mask, bag mask. When you give mouth to mouth, always pinch the nose, नहीं तो बाहर निकल जाएगा breath, right? Inspiration is given over 1 second, expiration over 1 second. Don't do excessive ventilation, and always give a breath to a patient. 2 breaths are given at one point of time, right? How do you make all of them together? Like chest compression भी करना और ये दोनों साथ में करना है. So basically what you're supposed to do, and what thing is called, it is called 5 cycles of 30:2 in 2 minutes, and you have to keep on repeating it again and again. Okay, so basically it is 5 cycles of 30:2 in 2 minutes, and you keep on repeating it every 2 minutes. You'll keep on repeating it. This 30:2 stays everywhere the same except for pediatric patient with 2 rescuer, where it becomes 15:2. करेक्ट? लेकिन अभी तक इसमें डिफिब्रिलेटर नहीं आया है. अगर डिफिब्रिलेटर आएगा तो अपना जो CPR का चीज है ये तो ठीक है, but once you get defibrillator, something else gets added onto that. Okay, once a defib will come, then something else will come. So till now, that is how you're supposed to do. Check the breath, check the pulse. If both are absent, you start with chest compression, airway and breathing. So we discussed how to give the chest compression, how was for the airway, how to give the breath, and ultimately 5 cycles of 30:2 in 2 minutes. In pediatric people with 2 rescuers, it becomes 15:2. अब सॉरी हाँ, अभी तक मैंने देखा नहीं था. वेट यार, अब मैंने मैसेजेस देख रहा था बिकॉज आई वाज ट्राइंग टू फिनिश ऑफ ऑल द थिंग्स. वेट, कंप्लीट रिकॉयल पीडियाट्रिक्स का ये तो बता दिया. डॉक्टर श्वेता, यस विल टेक अ सॉन्ग यार, 2 मिनट्स. इन्फेंट्स में भी देखो नॉर्मली सेम होता है. ओके, पीडियाट्रिक और इन्फेंट में ना, लेट मी पुट फ्यू थिंग्स लाइक दिस. In pediatric and infant, what happens in pediatric people, again the depth of chest compression becomes 1/3. In pediatric it is lower 1/3 of the sternum, and the depth is 1/3. You cannot decide upon the centimeters. This centimeters is not true for, this centimeters. This one is not true for pediatrics and infants. So when it comes to infants, our chest compression goes like this. 2 finger technique. 2 finger? You think 2 finger is only what gynec people can do? Sorry, Dr. Sonali will kill me. But you think 2 finger खाली gynec लोग का है क्या? They are the James Bond of medical profession. Have you seen? Gynec people. जब देखो patient कितना है? 2 finger. कितना finger? Patient 2 finger. Go to the gynec ward. Always the patient is 2 finger. Patient presents to the gynec emergency, 2 finger. Patient coming for cesarean, 2 finger. So we think 2 finger is hallmark of gynec. No, 2 finger can be done by pediatric people also. 2 finger technique. Okay, so infants में 2 finger and thumb encircling technique होता है. You don't do a chest compression directly. ठीक है, so 2 finger and thumb encircling plus pediatric and infants में the site of chest compression lower 1/3 of the sternum से थोड़ा सा ऊपर रहता है. This is slightly above than that, slightly above. Okay, because their heart is not gone completely down, it's slightly up. Okay, so that's some changes which are there in pediatric and infants. Apart from that, things are the same. Also, that pediatric and infants, they will need more oxygen, and that is exactly when there are 2 rescuers, the rate becomes 15:2. Acha, if mouth to mouth done directly or put a cloth? Yes, mouth to mouth nowadays no one does directly, but if it's always better to use a cloth. Okay, thumb on xiphoid. 2 finger वाला सुट्टा, हाँ करेक्ट, ये भी सही है. Thumb on xiphoid नहीं होता है. हाँ, thumb on xiphoid नहीं, you basically put it over here. Thumb on xiphoid will more be for that, वो what you call, अरे मुकेश बेटा आप सो जाओ यार, बाकी लोग अभी पढ़ाई कर रहे हैं ना, आप सो जाओ. अच्छा डॉक्टर दीपदास लिग्नोकेन क्या पूछ रहे हो आप? मेरे को क्वेश्चन नहीं समझा अभी तक. आई हैव सीन दैट लिग्नोकेन सिंस व्हेन, बट इस टाइप मींस व्हाट? आई डिडंट गेट दैट. So Dr. Sukubai, I answered your question there. Okay, mouth to mouth is done directly, or we put a cloth. It's always better to put a cloth so that you don't catch the infections. अरे किस चीज के लिए एंटी अरिथमिक you're asking me, डॉक्टर दीपदास? अरे तो पूछो, तो पूरा क्वेश्चन तो पूछो. क्लास 2A, क्लास 2A एंटी अरिथमिक एजेंट. इज दैट व्हाट यू आस्किंग मी? अरे यार क्वेश्चन पूरा तो लिखो तुम लोग. ऐसे आधा लिखोगे तो कैसे समझ में आएगा मुझे? तो डूब गया हूँ पूरा, सामने भी नहीं दिख रहा हूँ, पूरा अंदर मोबाइल के अंदर घुसा हूँ देखने के लिए. ठीक है. डॉक्टर दीपदास, यू टाइप द होल क्वेश्चन ना. सर लिग्नोकेन इज टाइप व्हाट? लाइडोकेन इज सेम एज लिग्नोकेन यार. लाइडोकेन इज व्हाट दे से अब्रॉड, लिग्नोकेन इज व्हाट वी से इन इंडिया. अकॉर्डिंग टू मी बोथ आर द सेम. ठीक है. और टाइप का मतलब क्या है मुझे नहीं पूछ रहे, मुझे समझ में आया. टाइप मतलब आई डिडंट गेट इट इन व्हाट टाइप. इफ यू से अरिथमिक एजेंट, यस इट इज क्लास 2A अरिथमिक एजेंट अकॉर्डिंग टू मी. बाकी तो मुझे नहीं समझ में आया यार, और कंटिन्यूस मोड में है शायद वहां पे. अरे बेटा नीट यूजी आप लोग कर लो, अपने आप पीजी में पहुंच जाओगे. बी मोटिवेटेड ऑल ऑफ यू. सब यूजी वाले भी हैं. एनीवेज लेट्स स्टार्ट विद द डिस्कशन दैट वी वर डूइंग. वी वर डिस्कसिंग सीपीआर, राइट? अरे बेटा आप यूजी का पढ़ लो, हो जाएगा. डोंट वरी, लेट अस फिनिश द पीजी वाले लोगों का काम. नाउ द नेक्स्ट क्वेश्चन गाइज. So we were discussing here where we discussed chest compressions, airway and breathing. I discussed with you how each of the things are given. We also discussed about the pediatric and infants. Next is, this is the ECG during CPR. This rhythm is seen. What is your next step on this? Okay. ECG during CPR shows the following rhythm pattern. Next appropriate step क्या है? जल्दी जल्दी, मैं सोचा था अभी तक खत्म कर दूंगा यार, पर अभी तक खत्म नहीं हुआ हमारा. एक क्वेश्चन अभी भी बाकी रहता है. आई थिंक वन मोर क्वेश्चन इज लेफ्ट आफ्टर दिस, देन विल बी डन. हाँ हाँ डॉक्टर श्वेता, देखो गिटार इधर ही रखा है यार, गिटार दूर नहीं रखा है मैंने, गिटार सामने ही रखा है मैंने. लेट मी फिनिश ऑफ दिस पॉइंट. विद दैट वी वुड हैव रिवाइज्ड कंप्लीट एनेस्थीसिया गाइज. So the correct answer, I got A adrenaline, I got C defibrillate also, I got C adrenaline भी मिला. Defibrillator Dr. Sukubai and Dr. Uma Karthik says adrenaline. Defibrillator C. So most of you agree with me. I have given the correct answer. Concept on tips. Wonderful यार, teach me also. Nice. नहीं 5 घंटे नहीं जाना यार, बस हो गया. एनेस्थीसिया 4 घंटे में बहुत है, ज्यादा टाइम नहीं वेस्ट करना एनेस्थीसिया पे. बहुत ज्यादा नहीं पढ़ना होता एनेस्थीसिया. एनेस्थीसिया थोड़ा थोड़ा पढ़ना होता है, उससे सब आंसर आ जाते हैं. करेक्ट आंसर इज defibrillate. Okay, defibrillate. What is the pattern guys? So the point is which I was discussing with you. Chest compression में we did scene safety, check response, call for help, we checked breath, checked pulse, right? We have seen 5 cycles of 30:2. You get the defibrillator. You attach the defibrillator pads to the patient. Once you attach the defibrillator pads guys, उसके बाद you will check the rhythm. So therefore once you have the defibrillator pad, okay, so you have attached the pads to the patient. Remember, on the right side it is below the clavicle, on the left side it is on mid axillary. ठीक है, right side clavicle and left side mid axillary. And apply jelly. Apply jelly. मैंने एक बार ना ऐसे लगा के ऐसा लगाया था पेशेंट को और शॉक दे दिया. फीमेल पेशेंट 28 ईयर ओल्ड, बच गई. शी केम आफ्टर 4 months. सर यू बर्न्ट मी. मैं बोला यू आर मैड, बच गई तू, यू आर सेव्ड, वी गेव अ शॉक. बट द पॉइंट इज राइट. ऑलवेज यूज जेली. Okay, attach the pads guys. So always in my classes I'll say please attach the pads, and before attaching the pads use jelly also before putting that shock to the patient, right? You attach the pads. I said on the right side is below the clavicle, left side is mid axillary, and then you assess the rhythm. When someone is dying guys, the rhythm can be of 2 types. Okay, one, it will be something like this. Okay, this is called ventricular tachycardia, and this is called ventricular fibrillation. This is the same thing which you can see on this. This which you are seeing over here is ventricular fibrillation, right? The other kind of pattern you can see is something like this: pulseless electrical activity or flat line. So if the pattern is ventricular tachycardia or ventricular fibrillation, these are called shockable rhythms, where you can give the shock to the patient, right? Shock, monophasic defibrillator 360 joules, biphasic में 200 joules. After the shock, straight away you can start your CPR 5 cycles of 30:2. Okay, straight away after that, giving the shock. Remember, there's no time in between. As soon as you give the shock, immediately start that 30:2 का 5 cycles immediately, right? After that you check the pulse. अगर pulse नहीं आया रहेगा तो वापस go and assess the rhythm over there. Attach the pads and assess the rhythm, right? अगर rhythm में फिर से ventricular fibrillation आता है, फिर से shock दे दो. Shock दे के give again 5 cycles and again go back. That's what you're doing. But in case your rhythm becomes pulseless electrical activity or asystole, if you're in the road, you cannot do anything. You straight away start CPR. But if you're in the hospital and there is pulseless electrical activity and asystole, the only drug which can be used here is adrenaline. ADR can be used. And this ADR can be repeated every 5 minutes. And after giving adrenaline, do not wait for pulse check. Start 5 cycles of 30:2, right? And then again assess the rhythm. This goes on for 30 to 40 minutes. And once the pulse doesn't come in 30 to 40 minutes, you declare the patient dead. Okay? Everyone, okay? So that is CPR in short. I tried to finish off everything of the CPR. Dr. Deepdas is saying anesthetic agent contraindicated in hypertensive patient. Ketamine. Right? Dr. Deepdas का आंसर था ketamine. राइट, डिफिब्रिलेटर का भी आंसर हो गया. ठीक है, और कोई क्वेश्चन किसी ने पूछा है क्या? राइट, डॉक्टर दीपदास गिव योर आंसर. व्हेन टू गिव एट्रोपिन? गाइस, नाउअडेज एट्रोपिन इज आउट. ड्रग नॉट यूज्ड ड्यूरिंग सीपीआर. एट्रोपिन इज नॉट टू बी यूज्ड. वेजोप्रेसिन इज नॉट यूज्ड. 5% डेक्सट्रोज इज नॉट यूज्ड. ठीक है, इट इज नॉट यूज नाउअडेज इन BLS ACLS में मना करते हैं, नहीं यूज करना है. द ओनली ड्रग यूज इज ADR एंड एमियोडेरोन. ठीक है, एट्रोपिन इज नॉट यूज्ड. हम लोग हॉस्पिटल में देते हैं प्रैक्टिकली, आई एम नॉट डिनाइंग. सो डॉक्टर सुकुबाई इज आस्क्ड करेक्टली, हॉस्पिटल में हम लोग अभी भी देते हैं एट्रोपिन. आई एम नॉट डिनाइंग, बट आइडियली BLS सेज डोंट गिव इट. एट्रोपिन, वेजोप्रेसिन, 5% डेक्सट्रोज नॉट टू बी यूज्ड. ओनली एड्रेनालिन एंड एमियोडेरोन कैन बी यूज्ड. ठीक है, प्रोपोफॉल एंड मिडाजोलम कंपैरिजन. अरे डॉक्टर दीपदास बोला तो नॉट यूज्ड इन which anesthetic agent not to be used in hypertensive, guys? Dr. Deepdas, is ketamine, which will not use in hypertensive patient, right? Ketamine is ideally contraindicated because it increases everything including the blood pressure and all. ठीक है, right? Dr. Sukubai, correct, you are right. लोग मना करते हैं, but फिर भी it's like, see, guidelines are what they say is helpful or not helpful. But if someone feels you want to give atropine, give it. When someone is dying, whatever you do to save the patient doesn't make a difference, but the medical evidence says that it does not make any sense to give atropine. That's why the guidelines have said don't use it. I'm not saying people are not using, hence I cleared the doubt. You are absolutely correct. People are saying to use it, लेकिन उसका कोई फायदा नहीं होता है, is what the guidelines are saying. It does not make any sense in this kind of situation. It's better to use adrenaline, which you can repeat every 3 to 5 minutes. Okay? Propofol is not contraindicated, guys. So Dr. Deepdas, propofol नहीं contraindicated hypertensive में. It's ketamine because the BP को further increase करेगा. Propofol can be used in hypertensive, not an issue. Dr. Sukubai, your point is also clear. ठीक है? Okay. Anyone else with questions? Dr. Deepdas का question है propofol क्यों नहीं? Propofol कुछ नहीं करता है ना. Propofol actually just decreases the BP. तो अगर hypertensive patient है तो उसका BP तो decrease होने वाला है ना, Dr. Deepdas. ओके, तो डॉक्टर किशोर कुमार, हाँ डॉक्टर JNV बीड करते यार, गाना करते. 2 मिनिट थांबा, 2 मिनिट. अजून एक क्वेश्चन राहिलाय. 1 more question is left. त्याचा नंतर आम्ही. Okay, त्याचा नंतर. Okay, so Dr. Kishore Kumar has asked me a question, that is cardiac arrest, LA, anaphylaxis. So remember, ADR na can be used in all the three doses. 1:1000. This is for anaphylaxis. 1:10,000 is for CPR, and for local anesthesia is 1:1 lakh से लेके 1:2 lakh के बीच में. Is that okay? Right, that's what I said. 1:1000 is for anaphylaxis. 1:10,000 which can be given IV. This is for your CPR. और ये जो बच जाता है, this is supposed to be used for your local anesthesia. Clear? ठीक है? ये clear हो गया? हो चांगला मराठी येतात यार. I am SSC HSC board from Bombay यार. कैसे मराठी नहीं आएगा? पढ़ा है मैं मराठी पढ़ा है एग्जाम में भी. मतलब आई गिवन एग्जाम्स ऑल्सो यार. जस्ट बिकॉज आई एम इन दिल्ली एंड वर्किंग इन दिल्ली ना, ऐसा थोड़ी मराठी नहीं आता है. यू कैन टेक बॉम्बे अवे फ्रॉम समवन्स हार्ट इवन इफ यू आर इन दिल्ली. ओके, चलो. आई थिंक ऑल डाउट्स क्लियर. देन वन मोर क्वेश्चन गाइस, लास्ट क्वेश्चन यार. एक क्वेश्चन तो ले लें लास्ट वाला. हाँ, दिस इज द लास्ट क्वेश्चन. ओके, टिल नाउ वी हैव कवर्ड ऑल द पॉइंट्स ऑफ एनेस्थीसिया. दिस वाज अगेन वन क्वेश्चन व्हिच वाज आस्क्ड इन 2020 आई थिंक, राइट? So, which of the following investigation gives the most accurate prognostic data with respect to predicting any possibility of perioperative cardiac complication? This is from pre-anesthetic checkup. Okay. So, which out of them you think is going to predict perioperative cardiac complication out of all the, four things given? Exercise ECG testing, myocardial perfusion, dobutamine stress echocardiography or coronary angiography. Cardiac patient में. Dr. Sukubai says C. Dr. Medico Forever says C. सब में आंसर C है. बहुत C है दुनिया में. C, हर चीज का आंसर C है. ओके, C. डॉक्टर दीपान को समझ में आ गया. C कर रहे हैं. करेक्ट. Dobutamine stress ecography is the correct answer. Okay, Dr. Neelam says C. Correct, absolutely correct, all of you. So dobutamine stress ecography. Correct. So the point is, normally what happens is, how will you predict that perioperative cardiac complications can be there or cannot be there, right? So if a patient is coming for a non-cardiac surgery, like initially Dr. Deep Das was saying hypertensive patient है, या जिसको cardiac का issues है, hypertension, जिसका BP बहुत high है, some patient is hypertensive for 20 years. Imagine for 20 years, how much problem must have been there in the heart of the patient. 20 साल से hypertensive है. So before the surgery, imagine when you're getting a surgery done and I'm giving anesthesia to the patient. That itself is a stress ना. There's a stress of anesthesia, stress of surgery. अरे अपने को मजा आता है सूंघने में sevoflurane, but patient को तो stress पड़ रहा है ना. You are giving drugs which are going to create stress for the patient. Not only from anesthesia, the surgical thing itself is a stress for the patient. So therefore, how will this stress of the patient can lead to further problems, right? So there can be various problems with the patient which ultimately can lead to myocardial ischemia. MI हो सकता है. Why hypertensive patient वही हाइपरटेंसिव पेशेंट जो है, ठीक है, पेरीऑपरेटिव मायोकार्डियल इश्कीमिया हो सकता है, इन द सेंस दैट इंट्राऑपरेटिव और पोस्ट ऑपरेटिव, दैट इज व्हाट इज कॉल्ड पेरीऑपरेटिव, राइट? So there can be problems because of that high BP. 20 years patient hypertensive, there will be hemodynamic variations in the surgery, there can be anemia, hypoxia, and all these things are already there in the patient's blood vessels. वहाँ पे problems है, there are clots everywhere, right? There are plaques everywhere. So this can cause MI to the patient. How will I come to know before the surgery? How should I come to know that something like this can happen because this patient is 20 years hypertensive? So now, initially there was this one chart which was there in 2017, the guidelines of management of a patient before non-cardiac surgery. That means cardiac patient coming for non-cardiac surgery, which means maybe hypertensive patient coming for non-cardiac surgery. You got a patient for hypertensive who's coming for laparoscopic cholecystectomy. You're getting a hypertensive patient coming for appendicitis. You get someone who's hypertensive coming for hysterectomy, right? Laparoscopic. So they have said the best thing here is pharmacological stress testing, which is dobutamine stress echo, right? If the patient is fine, you can straight away take for surgery. But if you want to get a testing done, it is called dobutamine stress echo, right? This is the answer. Second point, this was 2017 and this is 2022 European Council guidelines. This is the new guideline. I'm just sharing with you. You people don't have to know so much about it. It also depends on types of surgeries which is undergoing. If the surgery is low risk, don't worry, hypertensive patient will tolerate. But if it is intermediate and high risk surgery, which you people know, in that case, guys, another which is important thing is, apart from what you say ECG that we do in the patient, troponin and BNP has been added. So this BNP is to see heart failure can happen or not. Anyways, they are not going to ask you this thing. Functional capacity has been an important point, right? Along with that, stress imaging, right? This is echocardiography, which can be transthoracic, okay, which includes your dobutamine stress echo, and coronary angiography also can be done. However, you will find that echography stands out of all of them. Even today, if you will see, functional capacity is a question that we ask the patient. You can ask all of them. ECG normally in all these patients is already done, but we are not following troponin and BNP. All right, and this is dobutamine stress echo which we follow, and if there is abnormality in dobutamine stress echo, then the patient has to do an angiography. So ultimately, apart from ECG, the most important cardiac investigation which is there is your dobutamine stress echo, right? So the correct answer here was dobutamine stress echo. This is what tells you about the pericardial myocardial ischemia which can take place. Okay, this is what can tell you about the perioperative myocardial ischemia. Okay, so this was the last question, guys. अब इसके बाद any questions, then ask me. Otherwise, we have sessions coming for tomorrow. Dr. Manchu will be there. Okay, he will be doing radiology, right? So be aware of that. And I hope all of you are aware of these test series which we have, right? So this again, be aware of it. And we still have Dr. Mamta's class left for microbiology. So Dr. Himanshu tomorrow, and after that Thursday we have Dr. Mamta. Right, with that we'll finish the sprint sessions, and please test the GT. It's already live, huh? You can do it. डॉक्टर मेडिको को देखो ना क्या क्या सुनाई देता है. करेक्ट. अभी एक बार मेरे को आंसर सब देखने दो कि तुम लोग ने क्या क्या पूछा है. वेट. Exercise ECG is done to diagnose stable angina. Yes. Which of the following NSE does not trigger malignant hyperthermia? Halothane. Yes, it does. Dr. Deepdas. Ether. Chloroform. इजेक्शन फ्रैक्शन. अरे तो इजेक्शन फ्रैक्शन आएगा ना. स्ट्रेस इको करोगे तो स्ट्रेस इको में यू विल बी डूइंग इजेक्शन फ्रैक्शन अंडर दैट. सो व्हाट इज द होल कंसेप्ट ऑफ डोब्यूटामिन स्ट्रेस इको, गाइस? सी, एक तो होता है नॉर्मल इकोकार्डियोग्राफी. सो डोब्यूटामिन स्ट्रेस इको टेल्स यू टू थिंग्स. इट टेल्स यू कंप्लीट इकोकार्डियोग्राफी. 2D इको होता है ना, उसके ऊपर का हो गया. मीन्स यू आर गेटिंग द स्ट्रेस बिकॉज ऑफ द ड्रग, एंड विद दैट यू आर डूइंग द इको ऑफ द पेशेंट. सो इट डज टेल यू द इजेक्शन फ्रैक्शन ऑल्सो. How much is ejection fraction with the stress? Along with that, you come to know about the reversible myocardial ischemia अगर है कि नहीं पेशेंट में. अगर ये पॉजिटिव आता है, then we send the patient for coronary angiography. ठीक है? Is that clear? All of you? अरे थैंक यू गाइस. अभी कोई और क्वेश्चन किसी का रह गया? डॉक्टर मेडिको. हाँ करेक्ट. पंखे की आवाज आ रही है. करेक्ट. और ईथर क्लोरोफॉर्म सक्सेनाइलकोलिन का क्या था? अच्छा, यू आर आस्किंग कौन कौन सा ड्रग करता है मैलिग्नेंट हाइपरथर्मिया? विच ऑफ द फॉलोइंग? यार देखो, मैलिग्नेंट हाइपरथर्मिया, डॉक्टर दीपदास, मैलिग्नेंट हाइपरथर्मिया, डॉक्टर दीपदास. तो मैलिग्नेंट हाइपरथर्मिया इज ट्रिगर्ड बेसिकली बाय ऑल वोलाटाइल एनेस्थेटिक एजेंट्स. द मोस्ट मैक्सिमम आउट ऑफ देम इज हैलोथेन, देन सक्सेनाइलकोलिन एंड लिग्नोकेन. ठीक है? तो दैट इज द आंसर फॉर डॉक्टर दीपदास. एंड आई थिंक लेट्स गो फॉर द सॉन्ग. ठीक है? अरे डॉक्टर मुकेश, अरे मुकेश बेटा, मेरा भी कल क्लास नहीं है. अभी तुम सो जाओ, तुम्हारा सोने का टाइम हो गया. हम लोग तो ऐसा गिटार बजाते हैं. ठीक है? थोड़ा सा सॉन्ग, विथ सॉन्ग इज व्हाट आई एम थिंकिंग नाउ बिफोर वी एंड द सेशन. ओके, सो वी आर टुवर्ड्स द लास्ट पॉइंट ऑफ द सेशन, राइट? टुमारो डॉक्टर हिमांशु विल बी देयर. रिमेंबर अबाउट आवर GTs ऑल्सो. तो थैंक यू फॉर ऑल ऑफ यू फॉर ज्वाइनिंग मी. एक गाना कर लेते हैं. Thank you, Dr. Medico, forever. Thank you, and thank you, everyone. Let's do the song a little bit. Okay, chalo. GT में अपियर करो। अच्छा कौन सा सॉन्ग? आई सिंग ओल्ड सॉन्ग्स ओनली यार, मेरे को नए तो आते नहीं है। गिव मी सम सनशाइन। ओके, आई विल ट्राई टू डू दैट। आई एम नॉट वेरी श्योर कि मेरे को आएगा कि नहीं। चलो ये तो थोड़ा सा ये वाला हो गया। एक मैं सुनाता हूँ थोड़ा सा सॉफ्ट वाला। ओके, लेट्स डू अ सॉफ्ट सॉन्ग यार। अल्टीमेटली काम ना सॉफ्ट सॉन्ग आता है। दिस इज अ सॉन्ग फ्रॉम अ हिंदी मूवी ओनली, बट थोड़ा सा पंजाबी लिरिक्स है इसमें। तो आई होप यू पीपल मस्ट हैव हर्ड। आई एम नॉट वेरी गुड विद सिंगिंग, बट स्टिल लेट्स जस्ट डू इट फॉर फन, राइट? Thank you guys. So we did a small. अब किसी को मेडिकल का कोई डाउट है तो पूछ लो, एनेस्थीसिया डाउट्स, अदरवाइज थैंक यू फॉर ज्वाइनिंग मी, लिसनिंग टू मी, थैंक यू सो मच एवरीवन. अरे डॉक्टर मेडिको फॉरएवर ने अच्छे कमेंट दे दिया, थैंक यू गाइस. सो थैंक यू फॉर ज्वाइनिंग मी एट दिस सेशन. एनी क्वेश्चंस एंड डाउट्स प्लीज आस्क मी. ऑल द बेस्ट टू ऑल द पीपल हु आर प्रिपेयरिंग. डोंट वरी, जस्ट टेक लाइफ लाइटली यार, ज्यादा टेंशन नहीं लेते हैं, ठीक है. ऑल द बेस्ट टू ऑल ऑफ यू, ठीक है. ऑल द बेस्ट. ज्वाइन आवर टेलीग्राम ग्रुप. एंड दूसरा चीज है कि ऑल द रिटन पार्ट यू विल बी गेटिंग इट इन द टेलीग्राम ग्रुप, ठीक है. ज्वाइन द ग्रुप, यू विल गेट द पीडीएफ ओवर देयर. The PDF of this session is available on the Telegram group by tomorrow. ठीक है, Telegram group पे. Okay. Dr. Medico Forever says first time I stayed till the end. Thank you so much. Thank you Dr. Mohammad Yusuf. Thank you everyone. Thank you Yusuf Khan ji. Thank you Dr. JNV Beat ji. Thank you. Dr. JNV Beat ने बोला one more song. ठीक है. Dr. All in One says thank you. Okay, thank you. I am saying thank you. Thank you for all of you for saying all that. Thank you Dr. Mansi. और कोई बात, कोई कुछ और है, कोई और है. थैंक यू एवरीवन. थैंक यू. डॉक्टर एमबीबीएस साइन अप सेज दिस थिंग. अरे डॉक्टर मानसी, नीट यूजी, अरे नीट यूजी वाले पीजी में आ गए. चलो, डॉक्टर जेएनवी बीर ने बोला था एक गाना कर लेते हैं, उसके बाद फिर सो ही जाते हैं वैसे, ठीक है. तो एक सॉन्ग करके लेट्स फिनिश ऑफ देयर एंड ओके, लास्ट वन, ठीक है. लास्ट एक थोड़ा सा 2 मिनट का करके देन विल गो, ठीक है. So I actually I know old songs only यार, मेरे को नए songs नहीं आते तुम लोग की तरह, और गाना तो मैं अच्छा गाता नहीं हूँ, just that I Thank you guys, thank you. Okay, thank you for all your time. You people stuck up with me for so long. Thank you. Okay guys, okay, thank you for joining at the session. I'll sign off and all the best to everyone. Do well. So that's my parting message, and don't worry, all of us are there. ठीक है, Telegram group में भी कोई questions होंगे, doubts होंगे, we are all there with you. Okay. Doctor, thank you guys, ठीक है. So my Telegram ID is Dr. Vinish, so you can get in touch with me directly also. That's my Telegram ID. ठीक है. Thank you guys, thank you all of you, thank you so much, and all the best to all of you. All the best guys, do well, ठीक है. And once you score, Once you get your seats, do let us know. We like all your reviews because that is what gives us the kick to keep on going. Okay, thank you guys. Okay, good night. Good night. Bye bye. Bye. ऑफलाइन क्लास की याद आ गई, ऐसा भी मैसेज आया. थैंक यू गाइस. चलो ऑल गुड नाइट गाइस, गुड नाइट, ऑल दी बेस्ट. आप सो जाओ यार ऑल ऑफ यू. ठीक है, गुड नाइट, ऑल दी बेस्ट, डू वेल.